dignitaries on the dais.
Now I request President South Zone Dr. Ramanand Hirar to do the further proceedings of the program.
Very good morning to everyone. Honorable Chief Guest of the Day, Padma Shri Dr. Nageshwar Reddy. My colleagues in IPS office, Dr. Uday Kumar, Vice President, Dr. Suresh Kumar, Secretary, and Dr. Gangara, the Treasurer, Organizing Committee Chairman, Dr. Gauri Devi, Organizing Secretary, Dr. Chaitanya, and Telangana State Branch President, Dr. George, and Secretary, Dr. Pawan Kumar, dignitaries on the dais and off the dais, and the PG delegates. Let me be very brief in my address. I know that the PGCME is an important event for the entire postgraduates in the sense, because usually the CMEs are conducted at the local level and the PGs do not have an exposure to a wider number of faculties who has various other interests and specialities they have they go through, and the PGCME at the zonal level
of IRS Reddy Garu. I think he being
and he's gracing this occasion. I am very for this a small program. South Zone CM. Coming to the today's topic, it is very apt to the students who are very not usually they are not seeing the dilemmas in the comorbidities psychiatry. We have chosen the our CME chairman Dr. Arvind and other team have eminent speakers for this to enlighten in the field of psychiatry. We have the membership of South Zone membership around 11,015 members on South Zone total group. We have South Zone have organizing various activities in addition to South Zone conference going to be held in Trivandrum in the October. We had the midterm practitioner CME recently held at Tanjavur, and we also focused on South Zone PG training program. Today we are going to organize for today and tomorrow. In addition to various subcommittees, we are doing lot of activities. Our branch is the best branch in the IPS Indian Psychiatric Society, and similarly our Karnataka state branch stood first in the all the states among the India, and the second best is the Telangana state. And we have there is a lot of work we are dedicating to the our psychiatric fraternity by doing all the committed members of our psychiatrics. We have the important programs like Women Empowerment Committee, like Sammanvi. We are doing a lot of activities for particularly women empowerment on various activities related to women issues. And recently we are conducting the RCBC training, research capacity building, for very useful for publication, statistical knowledge about the how to write an article, how to publish an article, how to done a research. We are doing the second session this year. We are organizing the RCBC program now started this year, this month only. And also we are quarterly psychiatric update we are doing on important addiction, the important books that are released every quarterly on important topics compiled by all the eminent speakers and with their knowledge are imparted. And and one booklet we are giving free of cost. And also we have the community awareness programs, suicide prevention committees, we have suicide helplines, and various other programs we are planning on the platforms under the banner of IPS South Zone. Today, I would like to have this. I congratulate Dr. Indaram Subbareddy Gari for honoring a doctorate in SV University. Of course, he has various feathers in his cap. We have congratulate on behalf of IPS South Zone. I think the program will be a grand success with all your cooperation and with the pharma people and the organizing chairman and secretary. Thank you, one and all.
Thank you, sir. I now request IPS Telangana State Branch President Dr. V. George Reddy, sir, to please address the gathering.
Good morning, respected President Dr. Ramanan Nerat sir, the President-elect Dr. Uday Kumar sir, and General Secretary Dr. Suresh Kumar sir, and Treasurer Dr. Gangaram sir, and all the organizing office bearers for this event, and my General Secretary Dr. Pavan Kumar, and a wonderful chief guest today who needs no introduction, Dr. Nageshwar Reddy sir. As Dr. Gauri Devi madam said, I'll just add one which happened personally to me. I'm sure sir will not remember that. In 2000, when I finished my MBBS, I was like, having acute abdominal pain. That's when I went to Asian and self-diagnosed myself, paid for an endoscopy, and was waiting for sir. They sent me to some other doctor, but I said I want only him. Then when sir came to the examination room and he just took brief history and he just patted my back and he said, George Reddy, you don't need an endoscopy. Just take these 2 tablets, you are in stress. And 3 days, I was just normal. So I became a great fan of him after that. And this happened in 2000, sir, when I was working at NIMS. And a wonderful human being, though we relate to him to gastrointestinal tract. The way sir worked during the pandemic, destigmatizing COVID, releasing a lot of facts about COVID. I think it was really helpful for our medical fraternity, and it really, that's where he stood up, and common man's words he used, and he could destigmatize the pandemic, I felt. Thank you, sir, for being here. And definitely, I think Telangana State Branch did justice by giving this PG training program to Asha Hospital. Wonderful organizing team, and no doubt the program will be wonderful. It will be a rich experience for the postgraduates. Without taking much time, I request the postgraduates not to forget just my 3 words. Our branch psychiatry is spreading, but still we need lot of psychiatrists. The WHO data talks about the necessity of psychiatrists. Request is, after you finish your post-graduation, look for areas where the psychiatrist is not there. Reach out to places where really the need is there, but unfortunately we are not able to reach. So look at newer places, don't flock too much, and that is the real service we can do for our patients. Second thing is, take the wisdom of our seniors, and really there are so many seniors who have done wonderfully. Their experience, you can take it from the beginning so that you can really give a quality patient care. And third thing, on a personal note, I'm selfish. Please do join IPS. Please do join IPS South Zone, and please do join IPS Telangana State Branch. Please take membership when you're at the postgraduate level so that it can strengthen our association. And I thank the organizing committee. I thank the IPS South Zone for giving me an opportunity. And I thank all the senior dignitaries who are there occupying the chairs. Thank you very much.
Thank you, sir. Now I request our chief guest for today's event, Dr. D. Nageshwar Reddy sir. So please give your address and honor with your valuable speech.
Distinguished guests on this dais and friends, it's indeed a big honor for me to be here among the Psychiatry Association to be addressing you all. In fact, when Dr. Gauri Devi called and asked me, I was a little perplexed because I didn't know how I belonged here to a group which is more intellectual than I am. I was very glad when I came here to see many of my contemporaries. We started practice together, Dr. Gauri Devi, and we were together in Medno, and I still remember many cross patients, Dr. Chandrasekhar, MS Reddy and all of us started practice together. Dr. Indra Subbareddy was my senior actually in Kannur, and of course he's trailblazed in this area also, becoming a leader. So having seen so many friends here after a long time, it's a great occasion, and I also realized the growth that ASHA has made. ASHA hospitals has now spread out throughout the city with various branches in each department. I think has been a tremendous achievement where psychiatry as a specialty has grown. Of course, we require more I think, public interventions to tell people what can happen in this specialty and so on. In fact, when I was doing my MBBS, I was very interested in psychiatry. We used to have a fantastic teacher, I think Dr. Chandramouli. He died. He used to be a very good teacher, and I was very inspired. I wanted to take up psychiatry at that point of stage to do my post-graduation. Thought over it for a little, but I thought I didn't have either the intellectual capability or the stability to go into this branch, because in addition to the intellectual capability, I think one has to have a tremendous amount of stability to go into psychiatry. It's not such an easy specialty like other physical parts of medicines where you make a diagnosis, you give some tablets or do a procedure and get detached from the patient. You're constantly attached to your patients, and I think this involves a lot of mental trauma, stress to you, which I think is not so easy as one thinks of. Now, as PG students, I see you're going to embark on a journey of getting into a specialty, I think, which has become very sophisticated. During our days as undergraduate, we used to have 2 drugs and 1 ECT, that's all. That's the only therapies we had. It was more a thrill of diagnosing a disease, but watching these patients slowly deteriorate, not having much ability to change their course. But this has changed dramatically in psychiatry, I think. Better understanding of neurochemistry, neurobiology, better devices. I've just heard of the transcranial magnetic stimulation that is coming, and so many other new modalities have dramatically changed not only our approach to the patient, but also I think a patient's lifespan of what happens with a psychiatric illness. So I think these are definitely very challenging days. These are very stimulating days, and for all those of you postgraduates who are embarking on this journey, I think it's very exciting to be in a field like this. Generally, when I'm addressing PGs, I'm asked what is a pathway to success. I talk about 6 things, the 3 C's and 3 H's. The 3 H's is first hard work. Of course, in every specialty, one has to work hard. But it's very important to remember that not just working hard, but working smartly. There are many people I've seen in careers who worked extremely hard, but ultimately haven't listened to what they wanted to do. It's just not, I think smart work is important, how to divide your work smartly so that whatever work you do, there's benefits coming out of it in terms of social benefits, financial benefits, patient benefits, and so on. So I think hard work or smart work is the first important thing. The second important thing is humility. I think this is extremely important. Of course, being privileged, I think doctors, we're privileged. We come across so many big people in the society, sportsmen, film actors, artists, and so on. And one of the important things I found in all the successful people in whatever field, medical or whatever, is humility. And they're grown to this level because of humility. Otherwise, they become average people. I think this is the second most important thing for success, humility. The third important thing is honesty. Again, this is not so easy. because the whole society itself is becoming so dishonest or so much around you, which is different. But I think it's very important to stick to honesty, and this is, I think, for us important because we have to self-evaluate ourselves at what level we are. Are we honest enough to treat a particular disease? Do we have the capability to do that? Are we organized in a honest way, and so on? So these are the three H's. The three C's are the first important aspect of the C is communication. I think this is extremely important in all specialties, especially in medicine. The difference between, again, for postgraduates, the difference between a good psychiatrist and a great psychiatrist. You see some of your seniors here who become great psychiatrists. The reason they become great psychiatrists is at one level, all have similar skills, all have similar knowledge, everybody is reading the same advance and so on. The difference is communication. The difference between a good psychiatrist and a great psychiatrist is communication. And there are so many examples. I don't have enough time to talk about this, but I think communication is the one which makes a difference between a good and a great psychiatrist. In fact, we had many classmates, or in fact, people who are my classmates who became junior because repeatedly they failed in medicine. But in life, they became very successful. And when I examined what is the difference, I find that they may be not good at medicine, they're not very high in that sense, but the communication skills are very great. And this is the one which makes a very, very important difference in whatever you're doing in your life. The second important thing is compassion. I think, again, compassion or empathy is a factor which is extremely important. People think empathy is sympathy. That's not true. It's not sympathizing with the patient. Empathy is getting into the shoes of the patient and see how he feels, how the family feels. Empathy is a direct eye contact with the patient, getting into the patient's shoes and feeling what the patient is feeling. So this makes a lot of difference when we are dealing with a patient. When we empathize with our patients, I think the way we approach and treat them is totally different from just looking at them with the sympathy. So in addition to this, the third C is the colleagues, how you react with your colleagues. This is again extremely important. All of you are going to finish your PGs, you're going into practice, you're going to have in your practice rivals, you're going to have people who are also maybe not practicing as ethically as you think. All these are going to come up in practice. But it's extremely important to be very congenial to your colleagues. This is again a difference between medical industry versus other industries. If you look at other industries like either sports or film or other industries, they never talk bad about each other in public. You know, it's very, very, very rare. They may in private confess that this cap is this and all, but never in. But unfortunately, doctors are totally opposite. I've seen people coming with a prescription immediately. An young doctor says, "What is this? Completely wrong." Somebody, I mean, he may be wrong. He may be right in that sense. But I think it's very important. Our communication, the colleagues, are compatibility to the colleagues. That the third thing also is extremely important. We never thank each other. We never say sorry to each other. We never take opinions of each other. These three things, sorry, thank you, and what's your opinion, are three important words that we should use with our colleagues so that we maintain. This is extremely important. I think, again, Asha is an example of here how they're able to maintain this. People of similar age have come together. I'm sure they're using these three principles to be together to achieve so much in their practice. I think this is, so these are the 3 C's and 3 H's that I think are very important for practice. So the other important thing is, how do you become successful? So success could be fame, success could be power, success could be a combination of fame and power. So again, to all the PGs, I'll ask you, how many of you are successful in the sense you have a lot of money? How many? Nobody. You have a lot of power. Your father is some MLA or minister or something that you have a lot of power. Nobody. You have combination of both. Again, nobody. Okay, so we'll redefine success now. Success, if you look at most of the social journals, success is defined as being happy with what you're doing. So now the redefinition of success is being happy with what you're doing. So in that sense, how many of you are successful? No, almost everybody is successful. So you see, Dr. Gauri Devi gave me 10 minutes. She told me in 10 minutes we make everybody successful. And I succeeded in doing that. So I think the important thing is, I think, this how you measure success. So again, as postgraduates, you have a fantastic journey ahead of you. Before I leave, one last thing I want to tell you. I have this analogy of rubber ball versus a glass ball. I don't know how many of you heard of this rubber ball versus a glass ball. So your career is like a rubber ball. You just bounce it. It falls, it comes back again. In other sense, if you do something which in your career you're not successful, you can always go back. If you're not happy with something, you can do something else. So career will always come back. A glass ball is like family, friends, and health. You drop it, it breaks, it never comes back. So this is an important thing for you. Family, friends, and health should be first priority. A career will always come back. And now that all of you are already successful, I wish you all the luck, and I wish this conference a great success. Thank you.
Thank you so much, sir. You have really given a very valuable words, and I'm sure you have taught us the real meaning of success here to everyone, all the students here. Now, I would like to request our organizing chairman, Dr. Gauri Devi Madam, and our President South Zone, Dr. Ramanan, to please felicitate our chief guest, Dr. Nageshwar Reddy, sir. But we now request and invite Dr. Indila Ramasubba Reddy, sir, onto the dais and request organizing chairman, Dr. Gauri Devi, our chief guest, Nageshwar Reddy, sir, and our president, South Zone, Dr. Ramanan, all the dignitaries to felicitate him for being awarded honorary doctorate from Vice Chancellor at SV University, Tirupati. During 62nd convocation of Sri Venkateshwar University, Tirupati, it is a rare medical doctorate to receive. It is rare for a medical doctor to receive honorary doctorate from such a prestigious university. Many congratulations, sir. Thank you, sir.
Brief message by Dr. IRS Reddy. Thank you for the South Zone, President, Secretary, and other office bearers, and also the organizing committee, Gauri and other colleagues, and all the South Zone members.
Just 48 hours back, I received this honor at Tirupati from Venkateswara University. Probably I belong to Venkateswara University. My MBBS, Kurnool Medical College. Those days there was no health university. Myself and Nageshwar Reddy were all alumni of Kurnool Medical College and also SV University. So it is a very rare honor. Probably a medical doctor nowadays, only health university gives honorary doctorates after NTR Health University. The general universities like Andhra, Nagarjuna, Venkateswara, usually they don't give. They give to celebrities like cinema stars, sports people, literary people, academicians like that. No, probably Dr. Nageshwar Reddy got this honor from Nagarjuna University about 25 years back or 30 years back. Maybe after that, I may be the only doctor in the both Telugu states to have this honorary doctorate from a university like Venkateswara Nagarjuna. So I am lucky that two of us from SV, we belong to SV University, so and we got this honor. And I think this honor, I am so proud, not that my individual achievement, but to the psychiatric profession. Because psychiatrists are very much, this thing, even by the medical fraternity, very much neglected in the society, by the medical community and everybody. So a psychiatrist being honored is definitely an elevation to the entire profession and entire fraternity. So I dedicate this, my award, my honorary doctorate, to the entire psychiatric fraternity of our state, South Zone and this thing. So that way I am so happy and thankful. And this is the first conference. After receiving this honor doctorate, I am coming here yesterday. Before yesterday, I got this. So I am very happy and thank once again the South Zone office bearers and the organizing committee for inviting me, that too in the presence of my good friend, Dr. Nageshwar Reddy. So thank you, Ramanan, for all these things. Thank you.
1 minute. I take this opportunity to thank, felicitate Dr. Indla, who is a friend of mine, who was the national president, who was a zonal president, and who has encouraged, who was very much keen on establishing the election commission at the national level. And fortunately, I was the first, the person in the election commission. And I think it's an honor for us to congratulate and felicitate facilitate this thing. Felicitation to Dr. Ayaras. Thank you. On behalf of IPS and as well as all the members here. Thank you.
Thank you, sir. Now I request Dr. Chaitanya Deepak, Organizing Secretary, to give vote of thanks.
Good morning all, and welcome to this PG training program on today on behalf of the organizing committee. I would like to thank today's chief guest Padma Bhushan Dr. Nageshwar Rao Garu to grace this occasion despite his busy schedule. I would like to thank IPS South Zone President Dr. Ramana Nirath sir, Vice President Dr. Uday Kumar sir, Honorary Secretary Suresh sir, Editor Dr. Shahul Amin sir, and CME Chairperson Dr. Arvind, and Treasurer Dr. Gangaram, and South Zone Representative Dr. Naresh and Dr. Vishal sir, and for giving us this opportunity to host the PG training program. I would like to specially thank Dr. V.K. Arvind, who has been like guiding us from the beginning in choosing all the topics and all. And I'd like to thank all the speakers and chairpersons, both offline and offline, for accepting our invitation to share their knowledge and empower our postgraduates with their knowledge. I thank IPS Telangana State Branch President Dr. George Reddy and immediate past President Dr. Ansubha Reddy sir, and President-elect Dr. Minhas and Secretary Dr. Pavan, and other office bearers for their support. I thank all the postgraduates who have come from different places of the south of India for making this program a success. I would like to thank my teachers like Dr. Raghuram Reddy Garu, Dr. Prasad Rao, Dr. Chandrasekhar, Dr. Jagannath, and Dr. Ramana, and Dr. Ashok Reddy, Dr. Minhas for their support. And I would also like to thank my colleagues Dr. Sweta, Dr. Ajay, Dr. Siddharth, Dr. Sandeep, and all other staff of Asha for helping me day and night to make this program. And I would like to especially thank Dr. Gauri Devi, our organizing chair, for her meticulous planning and of the event with short notice. And I would also like to thank Sun Pharma for sponsoring the program. And I would like to thank all the audio, visual, and technical team for supporting us. Thank you, one and all.
Thank you, sir. Now I request our organizing chairman and our chief guest to kindly felicitate all the dignitaries on the dais. As a token of our gratitude, we would like to present mementos to all of you. Dr. George Reddy, sir. Dr. Gauri Devi, madam. Dr. Ramanand, sir. Dr. Uday Kumar, sir. Dr. Suresh Kumar, sir. Dr. Gangaram ji. Now I request everyone present in the hall to stand for the national anthem.
Janagana mana adinayaka
जय हे भारत भाग्य विधाता सिंधु जल जल चितरण
Thank you, everyone. We'll now proceed with the academic programs of today's event.
You can't control here, but I can see here.
You cannot control.
But at least can I change?
Yes, yes.
I can change here and see.
You can read it out for me.
All PG students kindly pay attention to the announcement. Those who have registered for RTMS demo, kindly give your name at the registration desk, please. What noise?
Check, test, test, check, test, check, check, test, test, test.
Hello. PGs who have your posters, come and meet me, Dr. Mridula.
Check,
You'll have
check,
to
check.
put them up in third floor.
ల్యాప్టాప్ ఆన్ చేసినప్పుడు మైక్స్ అన్న ఆఫ్
I don't think. Yeah.
Hello, hello, check this. Hello, hello. Hello. Hello, check this. Hello. 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 Hello, check this. Hello. Hello. Hello.
I think all the PGs should come in front because otherwise the speakers will feel we are talking to chairs. Okay, so kindly come front because this is a PGCM. It's not for everybody, you know. It's basically for you people. So first I leave the sofas. You can sit in all the chairs. Okay. Yeah. Thank you. Thank you.
A very good morning to one and all. So let's begin our academic forum. Our first session for today is Concept and Pattern of Comorbidities in Psychiatric Disorders. I would like to request Dr. S. Sirisha and Dr. B. Rajshekhar to chair this session. Dr. S. Sirisha is a professor and HOD Psychiatry at Institute of Mental Health, Usmania Medical College, Hyderabad. She has finished her undergraduation and post-graduation from SV Medical College, Tirupati, Andhra Pradesh. She's been a co-guide for 4 theses and a guide for about 10 PG theses. A warm welcome, ma'am. Dr. Rajshekhar is a professor of psychiatry and deputy superintendent of Institute of Mental Health and Usmania Medical College. Warm welcome, sir. I would request our chairpersons to introduce our speaker and to do the further proceedings. Thank you.
Hello, good morning everyone. Warm welcome to all dignitaries and also PGs. It's my great privilege to introduce speaker of the today's session, Dr. Fani Prashant. He did his MD Psychiatry from PG IMR Chandigarh. He is Director and Consultant Psychiatrist Chaitanya Hospital and Consultant Psychiatrist at Care Hospital, Hyderabad. He is first editor of Telangana Journal of Psychiatry and he has many publications to his credit and conducted and participated numerous academic activities nationally and internationally. It's great privilege to introduce you, sir. Over to Dr. Rajshekhar for the introduction about topic.
Respected Gauridevi Madam, my senior teachers and colleagues and dear friends, especially students, the comorbidity in psychiatric disorder is not a very old concept. It has been actually evolving over past few decades, and it's very important because of a lot of treatment and clinical implications. So I'm not going to go further into the topic and request Dr. Fani Prashant to take over. Thank you.
Thank you very much for the kind words, sir. So it's a great privilege to actually teach PGs. Okay, you don't get to teach PGs every day. Okay, and then being in private practice for the past 15 years, I feel very honored to be the opening person for this topic. The topic itself is a really nice thing. Okay, it's basically the dilemmas and comorbidities, which is very true because we day in and day out, we see psychiatric patients don't come with one single symptom or one single diagnosis. They always have a lot of things going on along with one diagnosis. So that is where the comorbidity actually starts, the thought starts in the clinician's mind as to what we are looking at. Are we looking at a disorder or we are looking at something else? Okay, so that is where the comorbidity starts in the thing. So my outline of my presentation would be, I'll go briefly through the history and then talk about why two disorders can coexist, and then concepts of comorbidity, epidemiology of comorbidity, and then patterns of comorbidity. So when we come to the history, actually the term comorbidity was first introduced in 1970 by the Feinstein. Okay, he actually introduced it for medical epidemiology, not for psychiatry in that strict sense. And he defined it by any distinct clinical entity that has existed or may occur during a clinical course of a patient who has the index disease in a study. So there are two things which we need to understand here. One is that a distinct clinical entity, and then the second is the index disease. So if you are using comorbidity, you have to first say what is your index disease, and then what is the other distinct clinical entity you are seeing along with it that is going to be the comorbid disease. And then they actually further classified it to see that the comorbidity is more of three types. One is pathogenic comorbidity. That means that there is some common underlying etiological condition for two conditions. Like somebody can present with a cataract and a nephropathy or a neuropathy, and then the underlying disease might be only a diabetes. Okay, but you're seeing two different disorders at the same time, one from the eye, one from the kidney, but they're actually having the same underlying disease. Diagnostic comorbidity, like at the level of diagnostic criteria, these individually are non-specific diagnostic criteria. Common diagnostic criteria like a fever, cough, and a cold can be a symptom of influenza. It can be a symptom of tuberculosis. Okay, so if you're looking at overlapping diagnostic criteria, if you use these three criteria, then you might get into comorbidity at a diagnostic level. Prognostic comorbidity is one disease is leading to another disease. That is what is a prognostic comorbidity. Strictly, these terms should be applied to diseases or to mostly a disorder. Okay, because in psychiatry we don't have diseases as per, we only have disorder. I hope everybody is familiar with what is the syndrome, what is the disorder, what is the disease. I hope things are clear. Okay, fine. So to classify further, we need to know the etiopathogenesis, why a disease is coming from where. But unfortunately in psychiatry, there's a long way road ahead to find out this. So the later, once this thing is more of diseases to be classified as comorbid, the definition started to change for psychiatric epidemiology. Somebody defined comorbidity as a relative risk a person with one disorder to receive a diagnosis of another disorder. Like I have schizophrenia, what is the risk of me having an obsessive compulsive disorder or depression or another anxiety disorder. That is what is comorbidity. Okay, that is what is defined as comorbidity. This was given by Boyd. And then comorbidity can be defined as the presence of more than one specific disorder in a person in defined period of time. So what was happening is definition had to emphasize clearly one descriptive value, that is specific disorder, and then a broader perspective of comorbidity to a lifetime prevalence. Let's say I have in my childhood, I had ADHD, now I am having depression. Okay, so I had two comorbid disorders, but it is at a lifetime level. It is not at a cross-sectional level. So one has to be clear as to whether it is one yearly or 12-month or lifetime comorbidity. That definition had to come into place. So that's why working. But there is a lot of lack of consensus with regard to the actual definition of comorbidity, especially when it comes to psychiatry. The basic problem is with the classification system which we are dealing with, the diagnosis of disorders, and then the lack of etiological processes behind the psychiatric disorders. So there are other types of comorbidity which are there in the literature. If you look at, some people talk of homotypic comorbidity, where diagnosing similar diagnostic groups like major depression disorder with dysthymia, they both belong to the similar group, but they are comorbid. Or heterotypic, one diagnostic group to another diagnostic group. The other pattern is concurrent comorbidity. That means the similar etiopathological hypothesis is there for the disorders. This is more like spectrum disorders. Okay, I'll talk about that later. And discordant comorbidity. That means there is no common etiopathological process between the two disorders, but they are found more commonly than the. So comorbidity, because the word is more specific for diseases, psychiatrists actually, if you look at literature, a lot of psychiatrists argue you should not use comorbidity as this thing. So what are the other names which we can give to these disorders? Okay, some people, Vinakur said that you can use co-syndromal. Messer said that you can use as primary and secondary. That means what developed first and what developed next. Okay, or co-occurrence, concomitance, covariance. These are all epidemiological terms. If you can look at it, if somebody is working in epidemiology, all these terms come into place. So basically there are two approaches to look at these disorders. That is, one is primary, secondary. This is at a level of order of onset. And hierarchy. That means that, let us say I have psychosis, okay, that takes precedence over a delusional disorder. Okay, so you can't diagnose a delusional disorder when somebody is diagnosed with schizophrenia, let us say. Okay, so the hierarchy is clear as to what comes on the top and what comes in the thing. There are two approaches which have been taken in our system of classification. But why do two disorders generally coexist? Okay, in epidemiological terms, first I'll talk about epidemiological terms, then I'll come to the psychiatry. In epidemiology, you can see coexistence. One, it's just a chance factor. Let us say there is rheumatoid arthritis in 10% of population and eczema in 8% of population. There's an overlap of around 2%. 2% of people might have both rheumatoid arthritis and eczema, but it doesn't really make any sense as to what is the connection between both of them. Okay, so that sort of a coexistence can happen. Or there might be direct causation. That is, one illness is causing to the other. Let us say somebody is having depression. They can have substance use disorder because of the depression is causing lack of sleeplessness, and then they want to have anxiety, which is causing substance use disorders in a different way. One is leading to the another one. There are associated risk factors. That means these two risk factors are interrelated. One is, let us say, example which is given is smoking and alcohol. Both of them can produce different disorders. Alcohol can produce liver disorder, smoking can produce chronic obstructive pulmonary disease. But when you look at it, there are two different things which are coexisting, but the risk factors for both of them are common and interrelated between each of them. That can be another model which is there. Or heterogeneity. The risk factors are independent. They are not related to each other, but they can produce similar illnesses. Like here, smoking and age is what is given as. One, smoking and age related ischemic heart disease can be other, and the lung cancer can be there. So one is to do with the heart, one is to do with the lung. Okay, but both the smoking and age are not correlated between among themselves. These are heterogenetic. Third is independence. That means you're actually seeing hypertension and you're seeing panic disorder. But when you look at it, it is both combined together, pheochromocytoma. Okay, it's actually a representation of a bigger disease, a third disease, but you're seeing two different diseases which are existing at a cross-sectional level. So these are the basic models behind which in epidemiologically people talk of why two disorders coexist. When we come to the concepts of comorbidity, this slide I want to spend a little time for all of you to understand it clearly. The first thing is that this is the index disease. Let us say a person has schizophrenia, hypertension, hypothyroidism. Okay, so he comes to a psychiatrist. Okay, the index disorder becomes schizophrenia, and then the comorbid diseases becomes hypertension and hypothyroidism. He goes to an endocrinologist. The index case will become hypothyroidism, and then the comorbid diseases become hypertension and schizophrenia. Okay, so what is the index disorder and what are the comorbid disorders is defined in that way. But when they go to a general physician, he sees all three of them together and says that this is multi-morbid case. I am giving importance to each one of them independently, not as the primary disorder and the comorbid disorders. I am giving equal importance to all the three in the management. That becomes multimorbidity. Along with that, what is the age of the patient? What is the sex of the patient? What are the other medical factors which are there? Obesity is there, lifestyle issues are there. That becomes morbidity burden. That is, these illnesses are affecting a person in a particular way that is causing the morbidity in this person. And let us say this person also has some living issues, family issues are there, there is a divorce in the family, there is no social support which is there. Then the complexity, non-health related individual attributes becomes the patient complexity. So comorbid disease is only a little part in the whole clinical picture when you look at it. And this is the concept which all of us has to understand how this concept of comorbidity goes into picture. Then common hypothetical models in psychiatry. We just talked about hypothetical models in epidemiology. So the more common hypothetical models which are proposed are, there are two manifestations of the same disorder. Let us say tics and OCD are there. Okay, it is a manifestation of Tourette's disease, something similar to the last one we talked about. Two stages of the same condition. Let us say I started off as conduct disorder and then ended up as antisocial personality disorder and over a period of time. Okay, so there are the two different illnesses which came because of the time, same condition presenting in two different time periods. Some same or correlated risk factors. Here we really don't have too much of a literature available, but there are some evidences like childhood sexual abuse is associated with personality disorder or affective disorders similar to this. And there are two distinct syndromes. That means these are two not related in any way, but they are co-occurring together. And one predisposes to the other. Let us say a personality disorder predisposes to affective disorder, which predisposes to substance use disorder, and as on. Okay, so one can predispose to the other. So these are the reasons why comorbidity is seen in psychiatry in a hypothetical model. But various terms you see in comorbidity through the literature, if you go through, people frequently talk about lumpers versus splitters. People talk about dimensional versus categorical, constructivist versus realist, artifactual versus apparent. What all does this mean? Lumpers versus splitters means that lumping up together of diagnostic categories to one. Let us say in ICD-9, ICD-8, you could see neurotic depression. Okay, it had anxiety, depression, somatic symptoms, pain symptoms, all clubbed together in one. But if you want to classify the same person in ICD-10, you have to give depression, somatoform disorder, anxiety disorder. So the same person with a single diagnosis, which is lumped together as one identification. Now with the categorical classification which came up in ICD-10, you see 4 different diagnoses out of the same person. Okay, so that is the splitters versus the lumpers which was talking about. The dimensional versus categorical goes in the same way. We talk about it in detail later. Constructivist versus realist. Again, the constructs of the diagnostic classification. How did we come to a theoretical, polythetic, monothetic way of diagnosing in DSM? How do we classify disorders in ICD-10? This dimensional approach versus categorical approach basically. But the constructivists talk about how classificatory systems influenced our comorbidity, whereas realists talk about it's a real phenomena. You have to see it in clinically, it is there. There's no two-way thinking about it. And then artifactual versus apparent. Artifactual is again basically because of the classificatory system, there is an artifact that the comorbidity is very high, whereas the actual fact is it is really high. Okay, so where do we stand there? So if we look at, I'll go through the DSMs, how it actually went in comorbidity, how it was there. In the DSM 2 and 3, the initial systems were hierarchical systems. Okay, less, but they were actually involved in over-inclusive diagnosis, like I example gave of a neurotic depression in ICD-9. Similarly, in DSM 1 to 2, we had similar. DSM 3 is the first approach where categorical diagnosis was being made. The number of diagnoses increased to 100, let us say. But there was a non-hierarchical system here. You can diagnose schizophrenia, you can diagnose any other disorder along with that. Depression also you could diagnose along with schizophrenia. There is nothing like if schizophrenia is there, it's a primary thing. Depressive symptoms are a part of schizophrenia as well, so you should need not diagnose. It was not there. And then, but there were good exclusion criteria. That means that if there was a medical condition or a substance use which is associated, you can't diagnose it. If there is a persistent delusional disorder, you can't diagnose it. Okay, so those sort of exclusion criteria were very strict in DSM 3. But DSM 3 are actually lowered the bar a little and loosened the exclusion criteria. So from DSM 3R, you see a high comorbidity rates which have shot up in the literature 1990s, 1990 onwards. If you look at literature, it is very high. And then DSM 4 and 5, even though 5 tried to, I'll talk about DSM 5 in detail, but they followed the same pattern. Okay, so DSM-5 tried to actually give some special attention to comorbidity in two aspects. One, comorbidity is due to etiological similarities. Okay, that is reflected in their way of grouping of similar disorders. Okay, they made of spectrum disorders, they talked of OCD related disorders, anxiety related disorders. They grouped them depending upon, they saw that these have some common etiological reasons why we are grouping them together. At the same time, categorical models were maintained. You had to have some categories clearly defined so that you can come to a diagnosis and then make multiple diagnoses at the same time. So you can see that similar grouping of similar disorders reflecting presumed common etiology in spectrum disorders and related disorders by altering the measurement model. Even though the DSM, if you see the main part, you see categorical diagnosis which are there, but the dimensional part of it, please. The dimensional part of it actually is there in the section behind it, where you could diagnose, let us say if you had schizophrenia, you can diagnose the spectrum of depression, affective disorders, manic symptoms, anxiety symptoms. These all can be clubbed in the schizophrenia itself. Okay, the dimensional part of it is there, but that is for the clinician to try and see how it goes, so that whether it could be incorporated in the future DSMs which are coming. So the dimensional part of it actually was included, but it was not dare enough to put it in the main thing. They tried to put it in the behind section where you could still try it out, and it is really nice and fascinating to study how the dimensional models have been there in the DSM-5. So comorbidity and spectrum approach. Because comorbidity was getting into a more difficult scenario, that is where the spectrum or the dimensional model came into picture. This was proposed again in 1990 in the University of Pittsburgh and Pisa. The term spectrum traditionally used to underlie relationship among clusters of symptoms or place defined symptoms in relation to one another. So if you have a similar cluster like anxiety, okay, or irrational anxiety, and then that over that irrational anxiety, whether I have social anxiety, whether I have generalized anxiety, whether I have panic anxiety, okay, specific anxiety, specific phobia, all these things had a common symptom cluster. Okay, over which each individual disease is expressed. That is the concept of a spectrum disorder. Actually, the advantages is that subsyndromal symptoms could be grouped together. And then you had categories which are clearly differentiated, but at the same time together. And then temperamental and personality traits could be identified which are similar to each other. And reduced artifactual comorbidity, unless, okay, what is there in the, if I look at OCD with social anxiety, with GAD, I might get a very high comorbidity, but they're all in cluster of a spectrum that reduce the comorbidity. These are only a part of the similar expression, so they're not really comorbid, that sort of a thing. And coherence to look more, because if they are all together, put together, now we look at causal relation, genetic factors, studying for this thing, which Dr. Vikas will be talking about in the later presentation as to how this comorbidity went into the research. That is where the spectrum concept came up. So what are the critical issues in assessment of comorbidity? When one tries to assess comorbidity in an epidemiological study or a clinical sample, what are the areas which one need to look at? What is at a conceptual level? How do we define a disorder, categorical versus dimensional? Or whether we should take a threshold versus subthreshold. Let us say I make 3 out of 5 symptoms compulsory to make a diagnosis. Now I say maybe 2 is good enough, I don't need the third one. Okay, so just by dropping one syndromal categorization, the comorbidity might go up. And then hierarchical rules. Okay, one takes precedence over the other symptom. Units of contents, like what all the illnesses am I looking at? whether I can group anxiety disorders, affective disorders, okay, and other disorders together and look at it, or within anxiety disorders, I want to look at GAD, social anxiety, or so what are we trying to look at? We're defining the units where we are looking into, and then time window, whether it is across 1 year, whether it is across lifetime I'm looking at, that needs to be there. And what is the assessment method which I'm using? Structured interview, clinical assessment, or semi-structured interview. Depending upon that, the comorbidity again changes. Okay, it has been, and the design analysis. How do you taking a sample, whether you're taking a community sample, you're taking a clinical sample, or we are correcting for base rates or not from the population, and what are the confounding factors which are there. All these put together, okay, it is difficult to actually assess comorbidity in a very strict sense, in a very proper manner. So why is there so much debate on comorbidity in psychiatry? Mostly psychiatric illnesses are disorders and not disorders and not diseases. There is high comorbidity reported in most of the epidemiological studies, approximately around 45 to 50%. Comorbidity has been used widely in research to talk about coexisting, concurrent, syndromal, subsyndromal illnesses. It's not been very clearly defined, and also been shown to has poor prognosis and difficult to treat. Clinicians often miss the comorbid disorders unless you're looked for. Okay, if I say that there is a common comorbidity of OCD with schizophrenia, when I'm looking at schizophrenia, I might ask for OC symptoms in the patient. If I don't know what is comorbid, I'll not look for it. Why will I look for it? Schizophrenia is presented, I treat the schizophrenia only. Okay. So is it a true concept, or it's an artifact? The same thing was talked about lumpers versus splitters. When you're splitting the diagnosis into multiple, you see a high comorbidity, whereas clumping together, the comorbidity decreases. The same thing is talked about in a different way by constructivists versus realists. This is where I was talking about. They say that comorbidity is an artifact in classification. The high comorbidity is due to increased number of categories in the DSM, okay, reducing the number of threshold symptoms, reducing the exclusionary rules, symptom overlap, I'll talk about it later, non-specificity of symptoms or accessory symptoms. Let us say in anxiety disorder, generalized anxiety disorder, there are 6 non-specific symptoms which could diagnose you to, similar to those of depression, somatic symptoms. So there is a large overlap if you see between the symptoms. Okay, so whether that is causing the overlap between MDD and GAD, which we generally talk of. Whereas realists talk about comorbidity is real and they indicate common causal link between the disorders. There's a latent variable construct and a network model. Okay, comorbidity is a real phenomena. These are the two models. In the latent variable model, they say that there's a common latent variable, something like a neuroticism or something, which can lead to depression, anxiety, other disorders, which is commonly caused. Whereas in a network model, one disease causes some symptoms. Let us say affective disorder causes anxiety, lack of sleep. This might lead to substance use disorder, which might be the network model. Some of the symptoms are there which are existing from one disorder, which is making the person go towards the other disorder. And the DSM and arbitrariness and circularity. There are two things which we need to understand. How do we define our disorders? We define our disorders through a classificatory system. Then how do we measure those disorders? We use the same classificatory system again. It is not like, okay, the definition of diabetes is increased glucose levels above 120 milligrams per DL. Okay, then I measure it through blood levels of sugar. Okay, I'm defining it in one way. Or if I say that the temperature is measured by thermometer, and thermometer is the instrument that measures temperature. Okay, so you're using the same argument in both the ways, so it becomes circular. Okay, you're coming back to the same point again. You're defining the disorders in the same way. You're using the same instrument again to find those disorders that causes. The same thing is arbitrariness of the DSM. This is what I was talking about. Generalized anxiety disorders, the symptoms which are very common between depression and anxiety, this overlap of symptomatology alone can contribute to the comorbidity of generalized anxiety disorder and MDD, which we can only see. Which one truly explains comorbidity, let us say? So whether the model, neither model, because what actually exists in the population is not what is written in textbooks. Okay, so what we generally see, okay, whether the DSM classification is the only reason we are seeing the comorbidity, no, that cannot be explained very truly, or it is purely a real factor, that's why we are seeing so much comorbidity, that also alone cannot explain. It should be somewhere in between, but we need to take the population characteristics into play. To show this, there was one study which was there, Netherlands Mental Health Survey of Incidence Survey. They used CIDI, that is a common diagnostic instrument to this thing. They took around 7,000 people. This is a model which you people need to understand. This is depression, anxiety symptoms insomnia, and concentration. These are the 4 symptoms which are taken. So if depression is present, not anxiety, depression and anxiety both are present, no depression, anxiety, no depression, no anxiety. Similarly, insomnia, concentration is not present, insomnia, concentration difficulties, insomnia is present, not present, but concentration difficulties, no difficulty. So no insomnia, no concentration difficulties, and no depression and no anxiety, the population is very high. You can see. So this is the general population. So, but when we try to do diagnosis, let us say depression is this blue one, anxiety is this green one. We are trying to strictly define depression and anxiety. The comorbidity is this one, this bar you see. But if I little relax the anxiety disorder diagnosis and push it a little bar, the comorbidity becomes these 2. So the comorbidity actually increased by putting my threshold a little down and then increasing the diagnostic criteria or reducing the diagnostic criteria for anxiety disorders. So this is one example. Whereas the other example is OCD, okay, with mania, obsessions, okay, drug use, compulsions and mania, the similar pathway. So people who do not have compulsions, mania or drug use or this is the highest one. Very low levels in the population, but if you can see OCD and mania and drug use, if you combine together as diagnosis, this is one. But if I little relax and then increase the OCD diagnosis to even some amount of drug and mania, you can't see that the actual comorbidity increase, because general population, there is lack of that category here. Okay, actually the comorbidity decreased. Okay, so it is just not an artifact that I reduce a criteria and then the comorbidity increased. Okay, it has to be generally present in the population as well. So the population characteristics also have to be taken into consideration. Comorbidity depends on interplay of disease definition, symptom distribution in the population. It's not an artifact because it depends on the distribution in the population, and it is not real alone because, okay, definition makes the difference in comorbidity. So it's an interplay between how we define disorders and how they exist in the population as a natural way. So, but in the final word is that the comorbidity is real. These are 2 examples of Archimedes, who wrote it somewhere in very old times, as to how he saw a patient who has thassos, became morose, result of justifiable grief, and she suffered from insomnia, loss of appetite, complained of fears, talked too much, she showed despondency, many intense and continuous pains. So he is describing a multiple faceted patient who is not defined to one disorder here. This existed much before DSM or any other classification system. So it's a realistic thing that comorbidity is there out in the population. So why is comorbidity important? Again, to define similar disorders with possible similar underlying category, etiologies. Dr. Vikas Menon is going to take up this in a more serious way. Associated with higher burden, implications in treatment, requirement for healthcare services. They have significant poor outcomes in various clinical domains, and they require multi-pronged approach. But the perspective is also something important. As a clinician, I want to see that if my patient has a comorbid disorder, is it important or in any way going to change the way I'm prescribing medication, or I should actually change my medication because this patient has bipolar disorder, he's coming in mania, now he's coming in depression. The treatment varies between the both condition. Or if he has OCD along with BPAD, can I add an SSRI? Should I actually put a mood stabilizer before going up on the SSRI? So how I treat a patient makes a lot of difference depending upon the comorbidity which we see. But an epidemiological research person wants to see what is there out in the general population, because clinical samples will show you a multiply high because the patient is seeking for help, so he might have more problems. Whereas people who are not seeking help will have milder problems. They are out there in the population. So epidemiologists or research wants to be stricter definition, have to able to identify, categorize, clearly define. That is how my comorbidity should be. And policy makers should know what is the actual burden in the society so that they can allocate adequate funds to the care of certain disorders much higher than the original ones, like depression, which is suicide. In summary, there is a temptation to reduce in the research issue to the need to, whether it is true or false. There is a lot of papers. You just go on comorbidity concept, you see it is artifactual. It is this one. My head got bonkers, okay, reading all those papers. Okay, but it's not really true we should not get into the temptation at all. So why should we bother whether it is true or not? Okay, comorbidity does not reflect a single process, and the process provides no basis for any theoretical interference. It's simply a descriptor in epidemiology. It's an epidemiological descriptor which we are seeing, and it needs to be looked at it. Why is it important? In the scientific and clinical interest, only because it raises important question about the possibility of underlying mechanisms. But for this reason, it constitutes the beginning. It should be the beginning point and not the end point for a research endeavor. Okay. Moreover, the phenomena is no conceptual unity or an etiological homogeneity. Rather, the way forward has to be to take particular patterns of comorbidity in order to test competing hypotheses about underlying mechanisms. So this is where the comorbidity concept lies in. So now I move to the next part, which is the patterns of comorbidity. Here I'll not go into each individual disorders and go into the pattern, because that will be the next topics which are going to be there. I'm going to give you a brief understanding as to where it moves. In the epidemiology of comorbidity, if you see, clinical setting shows a very high comorbidity. That is called as Bergson's bias. Because as I said, help-seeking population, the comorbidity is going to be very high. But there are good epidemiological studies, which generally the PG should talk about epidemiological catchment areas and the National Comorbidity Survey. These two, I think all of you have to thoroughly read, understand how the study was done, what were the instruments used, what were the limitations and all. That's in itself a essay question for you maybe. Okay, so in epidemiological catchment survey, there was 29% of mental illness suffered from a comorbid substance use disorder, whereas in National Comorbidity Survey, lifetime prevalence of any DSM-3R mental disorder was around 49%, 27% in 12 months. There was, those with a lifetime disorder had 50 to 53 to 58% of having 3 or more disorders. If I had one disorder, I had 50% chance that I'm going to have 2 or 3 more disorders along with it. Those with severe mental illnesses had more than 89% to 90%. Definitely they're going to have 2 or more comorbid disorders. Okay, they actually replicated the National Comorbidity Survey once the DSM-3R to 4 went on, but they came up with the similar findings. Around 50% of the patients with mental illness had 3 or more comorbid conditions. The World Mental Health Survey, that was purely of the US population. Okay, so they went along with the World Mental Health Survey initiative across 28 countries using the diagnostic instrument CD. Various in lifetime prevalence of disorders occurred. Highest was in USA and the lowest was in Nigeria and to some extent in Chinese also, because Chinese have a different system of categorization and diagnosing disorders, but it was CD which was used, but China and Nigeria had lower rates of comorbidity, around lower prevalence of illnesses. Around 40 to 50% had 2 or 3 more disorders. And age of onset in psychiatric illnesses, all the countries had the similar pattern on the thing. So one study examined what is called as a latent variable model, which I was talking about. There's a common thing which is there from which all the mental disorders are actually coming out. So they used the same National Comorbidity Survey sample and then they tried to group disorders together. Okay, they were able to group disorders into particular 5 latent classes. Okay, the first one was the fear class, where all our phobia, panic, anxiety come into. The distress class, which was MDD, GAD and dysthymia, this was proposed even in DSM-5 to put them together as a distress disorders rather than any affective disorders. And then externalizing class, like where they act out on the things, alcohol, drug dependent conduct disorder, to some extent antisocial personality as well. Multimorbid class, where high across all diagnoses are elevated. And few disorder class, where there is low probability between 2 disorders occurring together. BPID-1 was a multimorbid class. This was showing a different pattern compared to all other disorders. When I tried to look at Indian research on comorbidity, we don't really have great studies. Most of it comes from clinical data where doctors try to utilize their outpatient basis, whoever is coming. Then in them as a serial thing, the sample is very low. Sometimes it's very high even in the outpatient morbidity, but the morbidities are very high because of that. You can see 70 to 80% some places and 58 to 80%. Comorbidity in childhood disorders was also studied. MR had almost like 57% comorbidity, whereas pervasive developmental disorders had 46, ADHD had 40% externalizing behaviors. But these are all, Indian data is highly biased because of clinical sample. You're seeing very high data. This is the last part of my presentation, which I'm trying to talk of, because this is a very important study, which I found very useful to understanding of the comorbidity as it exists as of today. This is exploring comorbidity with a mental disorder among Danish national population. What they did was, this is published in JAMA, March 2. All of you should read it thoroughly, understand it properly. It's a very useful article. So basically they tried to explore comorbidity in mental disorders among the population. What they did was, what is the question they asked? After an individual receives a diagnosis of a specific mental disorder, that the risk of developing other mental disorder increases. This was the definition of one of the definitions of comorbidity, that is the risk of one disorder is going to the. Method is they used a population based on cohort study of Danish registry. People born between 1900 to 2015, observed for 16 years, between 2000 to 2016. Totally around 5 million patients were there. This was a huge sample of patients, out of which they followed them for 83.9 million person years it's called. Each disorder was paired with another disorder, like depression was paired with another neurotic disorders. They took ICD-10 criteria, so they paired disorders according to ICD groups, and one group to the other group they paired up. And then they studied which index disorder. Let us say I have depression now. What is my chance of having conduct disorder? What is my chance of having neurotic disorder? What is my chance of having substance use disorder? Similarly, if I have substance use disorder, what is my chance of having depression? So the primary diagnosis to a secondary or to secondary to primary, they tried to find out the risk. They calculated in hazard ratios is what it is called. It's again a abdominal. So I'll talk briefly about results to make you understand what it is. This is pairwise association between disorders. Let us say I have a prior diagnosis of schizophrenia, my index disorder. What are my chances of having all these disorders? Okay, the model, there are two different colors for two different models, where one is previous mental disorders have been eliminated, mental disorders have also been included. If you see above 1 means that there is a definite hazard, there is a definite probability of having comorbid disorders. All disorders were above 1. They all cross this. Some of them are very common. Let us say prior diagnosis of this thing was very commonly associated with substance use. This was intellectual disabilities and developmental disorders, where the diagnosis becomes a little blurry. Okay, similarly, prior diagnosis of mood disorders, if you can see, the neurotic disorders will be very high. Similarly, eating disorders is no, personality disorders is very high. So similarly, they were able to pair between two types of disorders, and they all found that they were above 1 in the hazard ratio. And then the time dependent association between pair. Like let us say I took substance use disorder. Okay, mood disorder is the prior disorder and the substance use disorder is the second disorder. So within the first 6 months, okay, the possibility of them being together is around 80%, like 80, very high hazard ratio. Okay, but within 6 months to 1 year, the risk comes down and it remains still high, but it is reduced from the 6 months to similarly, neurotic disorders and depression. The prior diagnosis of depression, okay, then what is the chance of having? The one is males and one is females. The orange one is females and males, okay. And time dependent absolute risk for mental disorders. Okay, so absolute risk of diagnosing other disorders after the first diagnosis of mood disorder. If I have been diagnosed of mood disorder within 6 months, okay, age related, whether if let us say for absolute risk of diagnosis of neurotic disorders depending upon age of first, let's say I have first diagnosis of mood disorder, what is my chance of developing neurotic disorder? But what is the age groups? The younger age groups seem to be much more at hazard ratio rather than the older age groups. So it gives you a nice picture. These are they have a website where you can go and then select your patient age, sex, and what is the primary diagnosis and what are the risks that this patient is going to develop the thing. It will give you an absolute value. Okay, so that can be used in our clinical practice to say and then project it to the patient that this is what you are having, these are the things, this is the risk you can have. So I need to address those areas of risk. That is something which we can do with this sort of a projection. So what are the findings implication? Comorbidity is very pervasive among psychiatric disorders. The hazard ratios were time and age sensitive. Both time, the early age of onset, the early in the illness, the comorbidity is very high. Older age group, later age group, the comorbidity come down. Effects of the pair was bidirectional, but as depression is affecting anxiety, anxiety is affecting depression as well. And some pairs of disorders had significant association, like neurotic disorders and depression had. So may support latent variable hypothesis. That means there is something common. That's why so many comorbidities are coming up in most of the psychiatric disorders. With this, my take-home points are: to define comorbidity, the classification and etiopathogenesis of psychiatric disorders need to be delineated. We are far away from that at this point of time. Comorbidity is pervasive across disorders and high among specific disorders. Comorbidity is a very loosely termed term in research, but let us not talk about whether it is true or false, but why is it important? And comorbidity might be the starting point to identify common etiological connections between disorders and better classification of disorders. With this, I thank you all for patient listening. Okay.
Any questions to be taken up?
Yeah, thank you, Fani sir, for a very good presentation. The study which you have cited, the 2019 JAMA study, it found that the risk of comorbidity is highest in the first year, but it persists over next 15 to 16 years. And second, I want a comment on something. It said that comorbidity is a pharma hype. Do you want to say anything about that?
There's a lot of talk about the comorbidity. Even the classificatory system, let us say DSM-5, has been influenced largely by the pharmaceutical industry and then the insurance industry, because if you have a disorder, the insurance company is likely to cover for it. That's why you need to have separate categories to it. It's been an ongoing sort of a debate. Maybe it is true to some extent, because you see a higher comorbidity in countries like US and then various categories which are specifically only to US, where you don't see that sort of a categories here. That might be true, that it's being influenced by the pharma industry as well.
So we request the audience to ask questions, and I think, madam, there are for certain online also there are certain questions, I believe. So meanwhile, we request the audience to ask questions and comment. Anand sir, please give the mic to Anand sir.
Thank you, Fani Prashant. That was an excellent presentation after quite a long time. The question which I am trying to address is again about the last study which you have talked about, is a Danish study. What are the tools they have used? Because you are projecting only the diagnosis. This is present or not present. That's how they probably would have calculated the hazard ratios. So did they use any severity of the symptom scales or anything like that? It's only the DSM diagnosis.
They are using ICD-10. I think they used the CD.
Okay.
Okay. They used
Fine.
They used the tag.
Any questions from the PG students or any other audience?
Good morning, sir. This is Dr. Anudeep, sir, first year psychiatry resident from Apollo Hospital. Sir, my question is, it's very hard to diagnose on the first interaction or the first consultation, and they have been to prior consultations with other psychiatrists as well, and they are on different. They have been on different types of drugs. So, how do we identify if it was a comorbid disorder in the past? Was it an influence of any drug, or how important is the masking of the disease by the prior medications?
So the what you're trying to ask is that when a patient is presenting to you, yes, already on treatment, we really don't know what the past history is. Yes. How do we identify whether there was a past comorbid disorder or not, and whether this medication is masking it or not? Yes. It's a very tough challenge. Okay, it's not very easy to answer that. Okay, but there is something called a recall bias. Okay, recall bias in the sense that if I ask the patient, okay, was there were any manic symptoms in the past? Okay, yes, this is no sir, nothing is there. But when you see the treatment of the previous doctor, it's very clearly a mood stabilizer which is there and an anti-manic agent which is there. Definitely they must have had. Okay, yes. So to identify the way you ask, how do you elicit in the clinical acumen to understand, and how you ask the question makes a lot of difference as to yes or no answers is not something. The process, how you went, why did you go, what happened during that time, why was the reason you were put on medication, why were you given ECTs at that time, because they say there's nothing, only sleep problem was there, we went and then everything was okay. So how you elicit the history, that is where the art of psychiatry, according to me, rather than the science of psychiatry, is very important. We need to understand our clinical acumen and eliciting a history, understanding. Just don't take symptoms on the face value. If somebody says I was sad, I went, okay, you don't consider it just depression. It could be because he was sad because he was feeling somebody was persecuting them. Okay, so what are the symptoms? You need to go into psychopathology, understanding the psychopathology, and then how the disease evolved over a period of time. It's very difficult to understand that in 5-10 minutes of a consultation. You need to sit with them, understand that, take a life chart, understand the events as they go, understand what the drugs are, how the drugs were used, and what were the drugs, how did it influence the symptoms. So you need to see this whole scenario of the clinical picture in a wholesome manner. You can't point it out in one go.
Yes, thank you, sir.
If I may add just one point to your question, before that, very nice presentation, sir. From your presentation only, I would like to give the answer. Like any illnesses, if it is of long duration, not responding to treatment, and associated with poor psychosocial functioning, then you have to suspect comorbidities and you have to look into it. So that is the high index of suspicion is most needed. So that is what Dr. Garu has presented. Any other question?
I just want to, it's okay, I think my voice is quite audible. No, the idea of comorbidity for PG students came to my mind basically because when we were students, we were making only diagnosis of schizophrenia. No, we were very happy to say that it's clear cut. Subsequently, when we are treating, the schizophrenic patient goes into depression, then we said post-psychotic depression. Schizophrenia with post-psychotic depression. Then we have the concept of, as you say, like lumping them together, like it became schizoaffective, schizodepressive, schizomanic. And subsequently now we are very clear that we make a diagnosis of schizophrenia, we make diagnosis of depression, also we make the diagnosis of OCD. So this concept made me think that, I think each one of us have our own, say like when we make a diagnosis, when you look at our prescription patterns, we make diagnosis as we want because we give priority to one index diagnosis and you add. As you are rightly pointing out, diabetes, hypertension, and schizophrenia or depression, how one views. Maybe supposing I'm organic oriented, I say like, no, the patient has hypertension and, maybe I give more importance there or maybe complex. So this is how I think one need to look at the patient, whatever may be the comorbidity, you need to look at the patient as a whole and which is the most common troubling disorder and which are being associated with. So these are important. It has diagnostic implications. You said you are mind boggling, but you made our mind very clear. Thank you. And congrats for your nice presentation.
Any other questions? Any other queries, clarifications from postgraduates?
Thank you so much, sir, for such a wonderful presentation and for the insights from all our senior faculty. I'm sure the students have a better concept of comorbidities from now. I would now request our chairpersons to present memento to our speaker. I request our speaker, Dr. Fani Prashant sir, to give mementos to our chairpersons. Before moving on to our next session, a small announcement for the audience joining us virtually. There's a link being provided for the questions, and the questions can be dropped in that link and they'll be taken during the session. There's a small announcement that Suresh sir would like to make to us.
As the PGs, most of may not aware, I am Zonal Secretary of IPS South Zone. The small announcement from the IPS National Midterm CME. They want to all the zones. There is a national level quiz program is going on. So I request all the postgraduates give their.
Hello, check this.
It is the screening quiz program on online platform. It will be held on July 9th. Please enroll all your email IDs so that they will coordinate. Those who are, each zone will be selected with 2 candidates from each zone. So I request, I will represent all the members of the South Zone postgraduates to participate in the online quiz program, the online quiz screening program. Those who won the quiz program at a zonal level, each zone select 2 members from each zone, and the final quiz will be on the national midterm semi at Raipur. They will be called. The transport and accommodation will be provided for the two candidates. And again, another program is combined with this quiz program. Those who are selected for the quiz program, 1 member can be selected for jam session. Jam session means just 1 minute session. This just 1 minute session, they have 5 rounds. This just 5 minutes. Each candidate speak for 1 minute. Each zone person, after 2 candidates from quiz winners, they will choose one among them. They will speak on 1 minute. This time usually on the spot the program will be topic will be announced. This time they are announced on bipolar disorder. So those who this bipolar disorder topic on 5 subtopics of the bipolar disorder, each one can present within 1 minute what best they can possible they have to present within 1 minute. 5 rounds will be made. The winners will be get first and second prize will be given. So this is the announcement. Please enroll your members for all the zones are already given the names. Only South Zone is lagging. The South Zone is the best branch in an entire IPS South Zone, and so you being the most largest number of postgraduates, they have to represent the zone and keep the zone at a national level. Please, thank you, Honorable.
So moving on to our next session, we have the topic underpinnings of comorbidity in psychiatric disorders. To chair this session, I would request Dr. B. Anand and Dr. B. Kishan to honor the dais. Dr. B. Anand Bogaraju is a professor of psychiatry, Mallareddy Institute of Medical Sciences, Hyderabad. He is retired as a professor of psychiatry in Institute of Mental Health. His interests are in data analysis and research in mental health. Dr. P. Kishan is a professor and head of the Department Psychiatry, Prathama Institute of Medical Sciences, Karimnagar. He is serving IPS as chairperson subcommittee of SAG, Indian Psychiatric Society 2021 to 22. He is an executive member of World Psychiatric Association section on religion, spirituality and mental health from 2020 to 2023. Warm welcome, sir. I now request our chairpersons to introduce our speaker and do the further proceedings.
Thank you, the organizers, for giving us this opportunity. So the topic which was dealt previously by Dr. Fani Prashant, it's just like in the IPL, Ishan Kishan opening the batting, and you see that why it is important is because the momentum is maintained, and that all gives us a lot of energy to carry through the session. So the session now is going to be, as previously been told by the speaker, is what are the underpinnings, what are the different causations of the comorbidities. In 2015, the Lancet Commission has published a paper where, as you know, that Lancet publishes very comprehensive type of reports, where they found that in schizophrenia, the mortality is 2.5 times higher when compared to the general population, or with that particular disorder, and 1.57 times higher in depression. That means a disorder plus schizophrenia, but the mortality is high. Why is it high? Is something which probably we will try to understand in our today's presentation. In the previous presentation, you have seen that some models have been described, especially the model which is the latent variable model, which most of the psychometry is based upon. And then the other model is he has touched upon that also, is the networking model. So A and B are two networks. There is a connecting symptoms. Now, what does it mean to us? Like, for example, if suppose somebody has insomnia and irritability for at least 2 weeks, you cannot make a diagnosis just based upon these two symptoms. In the same study which he has shown, that is a 2015 study, I think, MSc study, where the author has shown that these association of irritability and insomnia is very common in mental disorder rather than in general population. What it means is that they indicate that there is some mental illness. So that's why he said that they are called as the bridge symptoms, because they do not actually, based on those two symptoms, you don't diagnose a disorder, but they are more or less bridge symptoms between MDD, that is depression, and GAD. So several complexities are there, and we learn in psychiatry that the most important rule is that there is something called a tolerance to ambiguity. So over time we learn that we have to tolerate a lot of ambiguities. If the same session has been presented to a purely, let us say, a medical PGs, probably they think that what is the confusion. But I think as psychiatrists we know that we need to tolerate the ambiguities. And I request Dr. Kishan to kindly introduce the speaker.
Presentation.
Good morning, everybody. And without wasting time, we are going to second session. After Pani's session has given really a lot of clarity about the overview of the comorbidity. Now, what are the basic understanding and underpinnings of comorbidity? I think going to Vikas Menon is the additional professor of Department of Psychiatry, JIPMER. His special area of interest is mood disorders, suicide, digital psychiatry, and consultant liaison psychiatry. Vikas is a very clear, young, upcoming, dynamic speaker. Is known to his presentation very crisp and clear and comprehensive. Over to Vikas.
Good morning. Am I audible? Am I audible? Yeah. Okay. So, first of all, good morning to everybody, and thank you to the organizing team of this event for inviting me here. Thank you to the respected chairperson for the kind words. And it's a pleasure to be here on this PGCME. I'm also thankful to my previous speaker, Dr. Fani Prashant, for setting a very nice introduction to the topic, and from where we can, what do you say, hit the ground running rather than having to introduce again. So the topic that we are discussing is underpinnings of comorbidity in psychiatric disorders. So this is a vast topic, and We'll try to simplify it. And in this presentation, I'm only going to talk about underpinnings of psychiatric comorbidity. The other part is, physical and psychiatric comorbidity, about what we will not be discussing. So we're going ahead with this. And so this is the outline of, sorry. Slides are jumping. Yeah. So this is the outline of the presentation. So we'll first discuss about why is comorbidity important and what is the cost of comorbidity, and then we'll discuss why do we need to understand the models of this comorbidity. What are the various models that we have? So the previous speaker just briefly touched upon these issues. So we'll see what these models are and what are their applications in various psychiatric disorders. Then we'll see what are the common liability models. So there are certain shared liabilities across psychiatric disorders, or you can understand them as risk factors. So what are those liabilities which may predispose to comorbidities? We'll see that. And then at the end, we'll try and see what is an integrated model for understanding psychiatric comorbidity. So the first thing is, why is comorbidity important? So you see this global burden of disease study, which was a very important study where they estimated the disability due to chronic illness and injury. So this study, over the period of observation, they found that the comorbidity rates rose substantially, and those with 10 or more disorders increased by nearly 52%. With 1/3 of the participants had more than 5 chronic or acute illnesses. So that is the extent of the comorbidity we're talking about. And most of these participants 65 years of age. And together, from this study as well as findings from empirical research, we know that nearly 1/4 to 1/3 of individuals who present in general practice have comorbidity. Now, this does not refer to only psychiatric comorbidity, but also physical as well as psychiatric comorbidity. So that is the extent of the problem we are talking about. What does comorbidity cost? So what are the costs of comorbidity? We need to know the extent of the problem that we are talking about. So can we get rid of this? Okay. So there are economic costs involved, there are social costs involved, and there are indirect costs involved. So the direct costs, when we talk about comorbidity, we can understand, it's much more difficult to treat comorbid conditions because they're dealing with multiple disorders. So more healthcare costs, they are more debilitating, they have poorer response to treatment when they have comorbidities, they consume a lot of healthcare resources. So all that is direct expenses. And then many of these individuals, because they are poorly responsive to treatment, they need to be managed in some social kind of a setup where there are social care costs involved. So that is also a direct cost. But what about the indirect cost due to loss of productivity and employment? That is also a facet which is linked to cost of comorbidity. So if you take, we don't have much data from India, so I thought we'll just crunch some numbers related from the West, related to sleep disorders. So if we talk about sleep disorders, the costs we're talking about, this is data from Australia, so it's nearly about $1 billion. The annual cost of treating sleep disorders is about $1 billion, and you can see there that you can see there that the sleep disorder treatment alone costs about $274 million, and treatment of other disorders due to sleep, it's about $544 million. So that is the various disorders that are caused due to sleep disorders, which may mean depression, anxiety, diabetes, hypertension. All these can be caused due to sleep impairment. And look at the non-financial costs there. So that is about 4 times the cost, the direct costs that are involved in sleep disorders. So that is the extent of the problem that we are talking about. So why we need to understand models of disease comorbidity? Now we know what is the extent and magnitude of the problem we are talking about. Why we need to understand models of disease comorbidity? That is important to better understand the complex causal relationships between risk factors, medical illnesses, and psychiatric disorders. And if we begin to understand these models better, then we can design better, more evidence-based co-treatment approaches to treat these comorbid disorders. So we need to understand the models in order to facilitate our treatment. So with this background, we'll go individually to various models of comorbidity, some of which the terms you were introduced to in the previous session. So we'll just run through the various names first, and then we'll discuss the applications of these models. there is not enough evidence for all these models, but for wherever there is evidence and some application, we'll discuss that. So first we have the bivariate comorbidity models, where we talk about two disorders being comorbid together. The various submodels under these categories are, you have the associated liabilities model, you have the multiformity model. Just take in these names first and then we'll discuss each of these in some detail. You have the causation model, you have the independence model and the spurious association model. And then you have multivariate comorbidity models, where we are talking about more than two diseases co-occurring at the same time. So these are basically whatever these models we have discussed previously here. These models are, amalgamated in various permutations and combinations, and that's what is multivariate comorbidity models. So first we'll discuss about the associated liabilities model. So what we mean by a liability? What is meant by a liability? A liability is an indirectly observed propensity to develop a manifest disease. The disease is what you observe. The liability is what is latent or what is there within the individual, which is not directly observable. So have a look at this figure. You see, this is a liability factor A and this is a liability factor B. If A is present, it leads on to disorder 1, and if B is present, it leads on to disorder 2. But you see here, A and B are correlated, these arrow marks here. So that, and depending on the strength of the association between these liability factors, you can have three different models, that is the chance model versus the correlated liabilities model versus alternate forms model. If these two are not correlated, it means that whatever comorbidity you get between disorder 1 and 2 is purely due to chance, because these two liability factors are not correlated. So whatever you are observing is due to chance. But if these are correlated to an extent between 0 to 1, correlation coefficients usually range from 0 to 1. Depending on the extent of these correlations, you can get differing rates of comorbidity. If the correlation is very strong, you get a higher rate of comorbidity between 1 and 2 and vice versa. And now consider a possibility where A and B are perfectly correlated. They are perfectly correlated. If A is present, B is also present. So that means that disorders 1 and 2 can now be understood as alternate forms of expression of these liabilities, because they are so well correlated. Whenever one is there, the other is also present. So that's a perfect correlation. So then it becomes an alternate forms model. So that is the associated liabilities model. Next is the multiformity model, where there is heterogeneity in the expression of liability. So you see this figure here, A can code for 1, at the same time A can code for 2 also. Similarly, B can code for 1, B can code for 2. So effectively, now there are three ways of being comorbid with disorder 1 and 2. What are the three ways? You could either be elevated on liability factor A, you could either be elevated on liability factor B, or you could be elevated on liability factors A and B. So there are three ways of being comorbid with disorders 1 and 2. That's what the multiformity model states. And then you have the causation model. The causation model is slightly different from what we have discussed previously, because here the expression of comorbidity does not depend on the nature or expression of liabilities, but it is due to a direct influence of one disorder on the development of another disorder. So see this figure. So disorders 1 and 2, either 1 can lead to 2 or 2 can lead to 1. In both cases, it's a direct causation. Or look at the panel below, that is a bidirectional association. So you can have a reciprocal relationship between 1 and 2. So that is directional causation, that is the first two panels, versus the last panel is reciprocal causation. So you can have different types here too. Now coming to the independence model. So here again it's very interesting again. Here it's slightly different, because A can lead to 1, we know that, and the liability B leads to disorder 2. But look at the center panel. So there you have this comorbidity, 1 and 2 are together now, but that is coded for by a separate independent liability factor C, which has no correlation between A and B. So A, B and C are three distinct liability factors. And the presence, so here actually this is where the terms that is introduced by the previous speaker becomes very important, because here it's actually not a comorbidity. The better term to say is co-presence or co-occurrence. When we say comorbidity, what do we understand? One disorder is there and then the other disorder comes in at some point of time, then you call it comorbidity. But according to this model, it's more of a co-occurrence of disorders 1 and 2. So that is where this comorbidity term also has its limitations. So that's what we have to understand. So the independent liability factor and the co-presence of both also has its own liability factor. Now, the last model that in bivariate is the spurious association model. So in spurious association model, it is some other factor that is caused real what you see. Okay. So what does it mean? So some external variable or set of variables which you know or you don't know or you poorly know about, it is actually what is causing the association. For example, you're doing a study on depression. Okay. Now you have a sampling method. Inherently, all our study sampling methods are biased towards selecting comorbid cases. Do you know why? Because the more number of comorbidities an individual has, the greater opportunity he has to be recruited into several trials. And then when you sit and do a demographic analysis, you will invariably find comorbidity in most of your patients because they are just having too many opportunities to participate in various trials because they have more disorders. The other way of looking at it is maybe certain combinations of risk factors or what we call liabilities are more common in certain subgroups, like for example, socioeconomically disadvantaged people, they have more risk factors clustering together and they are likely to have more comorbidities. So there the problem is with the some other external variable rather than the liability. So these are different ways of one more spurious association maybe as an artifact of the diagnostic system again which was referred to in the previous session. We will be discussing about that also. So these are the bivariate models. Now a multivariate model, as I said, is basically more integrating whatever we have discussed previously, and it's basically when more than two disorders are simultaneously comorbid in the same individual. So here you see it's more flexible, hybrid and more comprehensive. Just see this figure here. So you see liability factor A codes for disorders 1 to 3, okay, and liability factor B on the right side codes for disorders 4, 5 and 6. A codes for 1, 2, 3, B codes for 4, 5, 6. Now if we see why disorders, comorbidity between disorders in the first group, that is 1 to 3, and comorbidity between disorders in the second group, that is 4 to 6, can be understood by what we discussed as the alternate forms model. Now these are just different forms of expression of the same liability, alternate forms of expression of the same liability. Okay. Now you see here the arrow mark on top, A and B are correlated. Okay. So any comorbidity between disorders in the first group, that is 1 to 3 and 4, 5 and 6, now can be understood by the correlated liabilities model because A and B are correlated on top. Okay. And now here comes the interesting part. B also codes for 3, disorder 3, and B also codes for disorder 4. So any comorbidity between disorder 3 and all the other disorders can be understood by the multiformity model because there is heterogeneity in the expression of liability. The same liability factor can code for this. A also codes for 3, B also codes for 3. Okay. So this is basically what is the multivariate model. You are integrating all the previous models, maybe one or two may be operating in different permutations and combinations. That's why you get many disorders comorbid in the same individual. So this now we'll see. We discussed so many models. What are the applications of these in real life practice? What are the we see comorbidity between schizophrenia and depression. We see comorbidity between many disorders. How can we link it to these models that we discussed? So if we see depression and anxiety are highly comorbid, we don't debate about that. We see that in clinical practice. Depression and anxiety are highly comorbid. So this study that has just been published in Translational Psychiatry has shown that shared genetic liability can explain much of this association. So that is which model? That is like the correlated liabilities model. Okay. As an example for an application of the reciprocal causation model, we need look no further than the association between smoking and depression. We know from epidemiological studies that tobacco smoking is a risk factor for depression. At the same time, we know there is something called a self-medication hypothesis, where people who are depressed are more likely to smoke compared to non-depressed individuals. So this is an example where you have the reciprocal causation model. Some more examples of the reciprocal causation model. Another example, sleep, anxiety and depression. These are three highly comorbid conditions. Okay. Anxiety and depression can predict sleep impairment. At the same time, sleep impairment can also predict later onset of depressed and anxious mood. So this is another example of reciprocal or bidirectional causation. What about any application of the spurious model? Yes, as the previous speaker also mentioned, it could be an artifact of the current diagnostic system, because the current diagnostic system has a lot of overlapping symptoms. Distractibility is a symptom of mania, distractibility is a symptom of depression, distractibility is a symptom of ADHD. Anhedonia is a symptom of depression, anhedonia is a symptom of negative symptoms of schizophrenia, and so on. If you're using the same symptoms in multiple disorders, you're bound to get traits of comorbidity. You're using the same symptoms to prepare a checklist of diagnosis. How are you not going to get comorbidity? So that is what Mario Maj, who was previously the president of the Psychiatric Association, argued in this quite an old article, but still I thought it's a very important article that was published in the British Journal of Psychiatry. You can search and get it online. Okay, so now we've finished the first part of the presentation. Now we go to the second part, that is, so now we know what are the various models of comorbidity, but what are the common liability models? How can we understand psychiatric disorders in terms of their common neurobiological underpinnings? So that is what we are going to discuss. Each of these models that we are discussing today is a separate seminar or topic in itself, but we just get introduced to what are the shared liability models. So obviously, any discussion on this has to first start with genetic overlap, because that is the one for which there is probably maximum research evidence, if not clinical evidence, at least maximum research evidence is there for genetic overlap. And so this was a study that was just published in the journal Genes about a couple of months ago, where the authors tried to look at genetic predictors for schizophrenia and depression comorbidity. Because we all know from empirical research that patients with schizophrenia have an increased risk of depressive disorders compared to the general population. So we know that finding. So are there genetic predictors to explain this? This is what was examined in this study. And the results of that study was neatly summarized in this Venn diagram. You can get it online. So I have not enlarged the figure enough to show you all the genes. It may not be important for us to remember all the genes, also not possible. But what is important to note is on the left hand side, the pink ellipse is all the genes that are contributory to schizophrenia. On the right hand, the green ellipse is all the genes that are contributing to depression. And look at that intersection part, the brown part in the center. So there you have about 7 or 8 genes which are increasingly expressed in people who have comorbidity of both schizophrenia and depression compared to those who do not. So this study concluded that there are some genetic predictors, or these these genes may explain some of these overlapping comorbidities. Some other example also of genetic overlap, we know that phenotypic as well as genetic overlap has been suggested for autism spectrum disorder and schizophrenia, for ASD and bipolar, for ADHD and bipolar, and for major depression and ADHD. So in this context, investigators used genome-wide genotypic data from the Psychiatric Genetics Consortium, which is basically a very large group of genetic data which researchers can access and use. And they looked at the genetic correlation between all these pairs of disorders. What did they find? There was substantial genetic correlation between schizophrenia and bipolar disorder. Now think to our clinical experience. We are all trained to think that schizophrenia and bipolar are at two ends of the spectrum as far as our, in fact when we were training, we were discouraged from making any kind of a differential diagnosis. Either you say schizophrenia or you say bipolar, not both. So it is at variance with what we observe in clinical practice. So substantial sharing of genetic risk variance between schizophrenia and bipolar. That pair had the highest correlation. To a moderate extent, correlation was noted between bipolar and MDD, schizophrenia and MDD, ADHD and MDD, and to a lower extent between schizophrenia and autism spectrum disorders. But between all these pairs, there was some genetic correlation. This was another study that looked at genetic correlation between the 3 major disorders that we classify under severe mental illness: schizophrenia, bipolar, and major depression. Here the authors used polygenic risk model. So don't get confused by these terms. So polygenic risk model is basically a statistical model where you have multiple risk variants together, and then you use a weighted sum of these risk alleles to predict a given condition. So that is leave that side, but polygenic risk models were used to test the efficacy of discriminating between cases and controls and between diagnoses. See, whenever you use statistical models to test discrimination between different subgroups that you want, If the model performs well, it means the variables that you have put into the model is efficient to distinguish between the disorders. So what did they find? They found that between cases and controls, the models performed very well. That means they were able to distinguish between healthy controls and each psychiatric disorder. But was the model efficient to distinguish between schizophrenia, bipolar and MDD? Not so much, not so robust. So what does that tell you? Again, whatever genes were inputted into these models seem to be shared. Many overlapping SNPs, single nucleotide polymorphisms between all these disorders that we are talking about. Again, it points to significant genetic overlap. So what could all this mean? That there is a shared polygenic component across these disorders which may explain the cognitive, psychotic and depressive symptomatology across these three disorders. We know that all these three disorders carry symptoms in all these domains. But does that mean that all these are the same disorders? Not really, because we know, isn't it, from our empirical experience and clinical experience that they have their own symptom profiles. All these disorders have their own course and outcome patterns. They have their own individual treatment response patterns. So how do we understand this? A good example I thought is to think from a model outside psychiatry. Think about Crohn's disease versus ankylosing spondylitis. These are two examples from outside the field of psychiatry. Both these are immunological disorders, and we know that there is substantial genetic overlap between these two disorders. That has been proven in literature, but nobody will argue that these are same disorders because they have different target organs, different pathophysiology and different preferred treatments, but still they have a lot of genetic overlap. So these kind of discrepancies exist in other fields also, and we should try to understand it from this perspective. So that's about the first liability model, that's genetic overlap. Model 2 is gene environment interactions that are implicated in comorbidity. So what this means is, you may have a genetic susceptibility variant, but for that to express, you need certain environmental factors. So the expression of the genetic factors are contingent upon certain environmental factors, which are non-specific to psychopathology. So that's why you get a variety of disorders. For example, evidence from genome-wide environment interaction studies show that interactions of certain common genetic variants with prenatal insults like exposure to cytomegalovirus or exposure to stressful life events are implicated in both depression and schizophrenia. As an example, to understand why there is comorbidity between schizophrenia and SUD, think about how early onset and heavy cannabis use may trigger underlying genetic vulnerability to schizophrenia. So that's a gene environment interaction there. Another example, when we think about the comorbidity between substance use and suicidal behavior, substance use we know interacts with individual genetic variability to raise the suicide risk. So again, here it's an example for gene environment interaction. So in reality, what we are dealing with is probably a polygene environment interaction causation model of mental illness, which may explain much of the comorbidity that we are seeing in day-to-day practice. Another model, shared neurotransmitter perturbations across psychiatric disorders. We know that, isn't it? We know that there are neurotransmitter alterations in many psychiatric disorders. We know about the dopamine theory of schizophrenia. We know about the monoamine hypothesis of depression. And there are other neurotransmitters that are implicated like glutamate, GABA and opioid systems that are linked to depression and schizophrenia. There are also alterations in glutamatergic signaling have been linked to autism spectrum disorder. So a lot of cross-cutting evidence there. So if we see the example between depression and anxiety, again, why could depression and anxiety be heavily comorbid? We know that there is decreased levels of serotonin in the brain linked to depression and anxiety symptoms. Evidence from post-mortem studies tells us that there are varying levels of metabolites of all these three neurotransmitters found in post-mortem autopsy brains. And then evidence from biochemical studies also point to the same thing. Evidence from neuroimaging studies have shown differences in all these three neurotransmitter group of receptors, their number, their structure, their binding and things like that. So these are all common across depression and anxiety. And we also know that medications that act on serotonin, norepinephrine and dopamine show cross-cutting efficacy in both depression and anxiety disorders. So these are some evidences for shared neurotransmitter perturbations across psychiatric disorders. If we talk about the comorbidity between schizophrenia and autism spectrum disorder, again here glutamatergic abnormalities may underlie both disorders. We know that NMDR hypofunction, autoimmune response against extracellular response of the domain of the NMDR have been postulated in schizophrenia. In ASD, for example, alterations in glutamatergic receptor expression, their synaptic and extrasynaptic localization, which are important for neural development and neuroplasticity, are underlying ASD. So these have all been shown. With regard to treatment, positive glutamatergic modulators have been used with some success, like D-cycloserine and all, with some success in ASD. At the same time, there are trials for D-cycloserine in cognitive, positive and negative symptoms of schizophrenia as well, with mixed evidence of course, but this is another pointer towards shared neurotransmitter perturbations in various pairs of psychiatric conditions. Another example I want to show is the cross-cutting efficacy of various molecules which may be primarily developed for one indication, you know. For example, you take the example of pimavanserin. We know that it's a recently licensed drug which primarily acts as a inverse agonist or antagonist at the 5-HT2A receptor. It is primarily marketed as an antipsychotic, and it was first developed to treat hallucinations in Parkinson's disease, and till date, you know, remains the only FDA approved agent for this indication. But some investigators had this bright idea, why not test the efficacy of adjunctive pimavanserin for MDD, for treatment resistant depression. So that is called the Clarity trial. And what did it find? It found quite a robust efficacy. The effect size is about 0.63. To give a synonym, you know, or to give an analogy, the effect size for antidepressants, what we universally believe is effective in major depression, the effect size is 0.3. So pimavanserin had twice the effect size of antidepressants. So there is definitely some cross-cutting efficacy of molecules which also might underlie, so this neurotransmitter perturbations which are common also may underlie comorbidity. Model 4 is immune dysregulation. So here this is also something that's very well known now. Immune dysfunction cuts across, it's more of a transdiagnostic feature. So in depression, if you see, you know, you have basically 3 lines of evidence. Depression is the condition for which there is maximal research on immune inflammatory dysfunction, and to a lesser extent in other major psychiatric conditions. So you have raised inflammatory and HPA axis markers in depression. Then you have increased rates of depression in medical conditions with supposedly inflammatory basis like rheumatoid arthritis or psoriasis. There you see increased rates of depression. And then you have depressogenic effects of cytokine therapy, or when you give that for viral hepatitis, for example, certain people go into depression. So these are all basically various lines of evidence that point to immune inflammatory dysfunction in depression and by extension other psychiatric conditions. So in this context, you know, we carried out 2 studies in our center where we found basically these were cross-section studies in depression as well as acute psychosis, where we found raised levels of inflammatory markers in both. But if you ask me whether the pattern was different in both, well, we did not study many inflammatory markers, so our study was not really powered to answer that question. And the treatment, importantly, the treatment did not normalize marker levels. What would you understand when treatment does not normalize a biomarker? What would you understand from that finding? Anyone wants to try and answer that? So you have a biomarker which you think is relevant for a particular disease, you treat the disease, and now the patient is in remission, but the marker has not normalized. So it may not, we talk about state and trait markers, you know. So state is when it's state dependent on the particular condition, but when inflammation is not normalizing with treatment, we need to think about it as has been pointed out as it is in terms of trait marker. So it may represent an underlying vulnerability which continues to be present irrespective of fluctuations in the disease condition. So that's again what we call liability, you know, the propensity to develop a condition. So this was a fairly large meta-analysis published in Translational Psychiatry where they looked at the reproducibility of perturbations of these immune inflammatory biomarkers across a range of psychiatric disorders. So they pooled basically, you know, studies on these 7 or 8 psychiatric disorders that are listed here and studied the patterns, you know, whether they are different across these disorders. They are fairly large study because they pooled results from more than 700 publications and studied 44 inflammation related factors. But what did they find? 11 inflammatory markers were altered in more than 2 disorders. So these 11 markers seem to be transdiagnostic. They are not specific to any particular diagnosis. And at the same time, there were also patterns, some patterns, interesting patterns that were unique to one disorder. For example, interleukin 4 was increased in bipolar, decreased in suicide, but it was not altered in other conditions. So why I am presenting this here is because this could be the line that future research takes, you know. We are talking now about, a trend is now about talking about biosignatures in various psychiatric conditions. So can you build an immune inflammatory biomarker signature profile for different psychiatric disorders and for different psychiatric comorbidity patterns? That is the question that we need to ask ourselves and probably investigate in the future. So coming to the next model, that is gut microbiome. All these are in very vast areas. We're just summarizing and talking the basics here. So this is the gut microbiome, and I'm sure you all know about importance of the gut microbiome axis in various psychiatric disorders. So in this context of our knowledge of alterations in gut microbiome across a range of psychiatric disorders, investigators from published their findings in JAMA Psychiatry last year about a review of gut microbiome alterations in about 8 or 9 psychiatric conditions, which includes the major psychiatric illnesses as well as some of the childhood psychiatric conditions like ADHD and ASD, autism spectrum disorder. What did they find? This study had more than nearly 2,500 patients and control. So that's a very large meta-analysis where you pool results and increase the power of the finding. So they found more commonalities across conditions than differences. You know, there was decreased anti-inflammatory bacteria profile and increased pro-inflammatory bacteria profile. So many of these studies were underpowered to find differences in bacteria at the species level. So for that you need very large samples. So here we are talking more about the genus level taxonomy. So this is the common finding that was found. There have also been meta-analysis of gut microbiome alterations in specific psychiatric disorders. So this was in autism spectrum disorder, published in Frontiers, and they had 9 studies, and they also found an association between autism spectrum disorder and altered microbiota composition. But again, here sample sizes were limited, so analysis was restricted to the genus level. Unless we know the species that are involved, you know, we cannot again begin to think in terms of treatment. What microbiota will you supplement in these individuals unless you don't know the species that are involved? So that's a limitation which hopefully will get corrected in future research. The last model that I'm going to discuss is shared changes in brain connectivity, or what we call the connectome, you know, as a whole. So that where there are alterations that are shared between psychiatric disorders. So this paper in Nature Communications looked at psychopathology dimensions. So rather than taking disorders, you know, they looked at psychopathology dimensions which are again cross-cutting. For example, we'll see what are the dimensions they assess. So in this research, basically authors used machine learning approaches. I'm not sure whether you're familiar with these terms, machine learning, but these are artificial intelligence approaches. You know, when you need big data, you use machine learning approaches and similar approaches. So don't get again too caught up with these terms. They have used some artificial intelligence approach to map a range of psychiatric symptoms to individual differences in functional brain networks. Okay, and 4 dimensions of psychopathology, that is mood, psychosis, fear, and externalizing behavior. Now you know that all these are cross-cutting dimensions, isn't it? Mood as a psychopathology dimension can be seen in schizophrenia, can be seen in bipolar, can be seen in ADHD, and all the other disorders similarly. So what did they find? They found again more commonalities than differences, that the certain networks in the brain, you know, relating to disruptions in the default mode network and executive function networks were a common feature across these psychopathology conditions. So that may underlie presence of these symptoms in more than one disorders. Another, so similar findings have also been, similar patterns of neural circuit disruptions that cuts across psychiatric diagnostic categories were found in other studies published in American Journal of Psychiatry as well as in JAMA Psychiatry, particularly networks involving the anterior insula and dorsal anterior cingulate based network, which are important for executive function. So that may underlie executive function deficits across psychiatric disorders. So how all this becomes important is, now if you know that there's a certain neural circuit that is disrupted across psychiatric disorders, now you can begin to think in terms of some interventions that target those particular networks, isn't it? Then it will have cross-cutting efficacy. So that's the utility of these models, but they're a little far off from that. This study has just been published a couple of days ago in Biological Psychiatry, which is a very, very high impact factor journal, and something which we should try to read if we are looking at in terms of latest advancements in biological psychiatry. So I thought this is relevant to our presentation, that these authors, what did they do? They studied 4 groups of patients, that is major depression, bipolar, schizophrenia, along with more than 800 healthy controls, and they trained machine learning algorithms, to differentiate groups based on diffusion weighted imaging, which was the technique they used to study brain connectivity patterns. So here again, they found that the models they trained, the models they developed using artificial intelligence approaches could differentiate between patients and healthy controls, but could not differentiate between cases. Remember, we just discussed this point some time ago. The models are not efficiently able to distinguish between psychiatric disorders, but between patients and controls they are able to. So they are able to say that there is some disorder going on, but they are not able to say with certainty whether it is schizophrenia or bipolar or not. So that again tells us about the shared changes, disruptions in brain connectivity as a possible underlying liability factor across psychiatric disorders. So coming to the last part of the presentation, that is, we know all the various liability models now. We have discussed about the bivariate model, the multivariate model. How do we put all this together and understand as an integrated model, how we can understand psychiatric comorbidity in very simple terms? I'm not going into any technicalities now. We have to understand the fundamentals that, basically the brain and the body communicate together to maintain homeostasis. Okay, this much we accept. And whenever there is increased demands on the brain in terms of maintaining homeostasis, even though there are disruptions, the brain gets stressed, and there's a sequence of events that are triggered at physiological and molecular levels. Okay, the sequence of events are triggered. There are some damage sensing molecules in the body, like called damage associated molecular patterns or nucleotide binding ligand receptors. These are basically, whenever you are under stress, cellular stress is detected by these molecules. And then what happens normally, if you are in a healthy, if your systems are functioning efficiently, it leads to healthy processes like neurovascular coupling, synaptogenesis, neuroplasticity, which are all healthy ways how your brain adapts to stress. Okay, but if you have an underlying genetic susceptibility variant, this stress response of the brain becomes exaggerated, takes various directions, and you get a range of dysfunction syndromes characterized by deficits in cognitive, behavioral, and emotional systems. Okay, now when we get these disruptions, patients present to us, and what do we call them? We call them based on what we see predominating in the clinical picture. If the patient is presenting predominantly with depression, we say it's a depressed patient. If the patient is presenting with some other psychotic symptoms, we say, okay, it's a psychotic spectrum patient. But these are all basically due to challenges that the brain is not able to maintain the homeostasis. So it manifests in various ways, due to what we call them depends on what we see. And the lifelong genetic or underlying trait that the individual carries predisposes them to periodic symptoms as and when they face stress and they are not able to adapt to it healthily. Okay. Before closing, I also want to bring in this two-dimensional model. So this was also something that the previous speaker referred to, how there is a kind of a difference between the dimensional and the categorical models of classification. So because our current classificatory systems are categorical, by design or by default, they encourage more comorbidity findings. So to remove this as well as some of the other limitations in psychiatric taxonomy, the investigators have come up with two different models. I'm sure you are all familiar with these terms, RDoC and HiTOP. RDoC was developed by the NIMH in 2009, and the HiTOP is little more recent. That's the hierarchical taxonomy of psychopathology. There is no time to go into the details of this, but you can read this for your knowledge. These are two-dimensional frameworks for psychiatric nosology, and they aim to address the limitations of the current classification, which also includes what we're talking about today, that is high rates of comorbidity as an artifact of the current categorical classificatory systems. And if you see both of them, they are very similar. They base their classification not on symptoms, but on shared psychopathology dimensions, what we call biobehaviorally grounded psychopathology dimensions. So For example, if you see RDoc, it has 6 domains, 6 or 7 domains like positive valence, negative valence, and other things. So you can read about it. And this is the article that I would recommend you to go through. A fairly recent article published in this journal, linking RDoc and HiTOP, a new interface for advancing psychiatric nosology and neuroscience. So that if we start following such dimensional models, maybe the rates of comorbidity will automatically come down. To sum up, we discussed various models. The brain is the central organ of homeostatic control, and what we discussed is the stress response system. We just discussed about how abnormalities of the brain stress system may result in wide-ranging dysfunction, and we have divided them into various disorders. We have divided them into various disorders, based on what we see, rather than any strong neurobiological underpinning. Whatever we have discussed now, it's not based on that we have unfortunately or fortunately grouped these disorders, and then we discuss about comorbidity. So all psychiatric disorders are at some level, basically manifestations of disruptions in underlying deeper brain molecular and the brain structure. So that's how we should understand these various disorders. So don't view them in isolation. I would again come back to the same message that was told in the previous session, that is, we need to take an integrated approach to psychopathology, a dimensional approach, and look at the patient as a whole. Yes, while you are being trained, you are limited by the frameworks of ICD and DSM. That's understandable because you have to formulate your diagnosis and present it in the exam. That's fine. That's useful to pass the exams. But once you pass the exams, you need to realize that psychiatry is much more than ICD and DSM, and you need to look at the patient from an integrated point of view and try to understand the comorbidity also from an integrated perspective. So these are some suggested reading material. Maybe I can share the slides with the organizers and they could then send it over to you. I have to acknowledge the inputs given by Dr. Bhaskar Mukherjee, Dr. Samir Praharaj, and Dr. Shahul Amin. These are 3 people whom I work very closely with, and their inputs have been very valuable in designing the structure of this presentation. Thank you for a patient listening, and thank you to the chairperson, thank you to the organizers.
Thank you, Dr. Vikas Menon, for giving you a comprehensive overview, you can say, about the different models, the bivariate and the multivariate models in the classification, and trying to understand what are the intersections what we mean by the comorbidity. And he has tried to give the current understanding of the genetic gene environment interactions. Then not much of imaging, but he has pointed out to something about imaging, then about the neurotransmitters, and about the current classification, the understanding of the RDoc and HiTOP, and connectiomics, the brain connectiomics. So what is happening in the artificial intelligence level and all that. You have any questions? Kindly shoot them direct to Dr. Vikas. Somebody can raise their hand and then introduce themselves while you ask a question. Okay, to start with, I have a couple of questions to ask. Well, actually, when they talk about the brain imaging, what they find is the limitation in the resolution of the voxels, because it is mostly the studies are based upon the 3 Tesla. So recently they have developed the 9 Tesla also, and there are many research institutions all over the world, at least about 60 and odd, who have started trying to use these machines. So they say that probably that higher resolution is required to find out more about the structure and functional abnormalities in this. Do you have any much information, because you have been going through these articles?
Sir, I agree with your point that, because many of these connectivity alterations that we are talking about is not at a very gross level. It is at a very microcircuit level. So probably you need better techniques to evaluate all this and come up with specific targets that we can develop in terms of intervention. So if you're looking at interventions, then really we need advanced technology imaging techniques.
Thank you. Another question is about, most of the SNPs which happen in the at the DNA level is sometimes adaptive and sometimes maladaptive. So this evolutionary aspects of genetics is something which is again another dilemma, which is for us to understand. What is your opinion about this?
First of all, sir, I would like to say that when we are talking about these kinds of studies, we need large samples. We need large samples, and we need big data approaches like what we were discussing in order to one SNP. All these genetic studies that we have talked about have also shown us one thing, that the predictor, the ability to predict for a single SNP or even for 10 or 15 SNPs together is less than 1%. So in terms of clinical significance, if you have to build a model with SNPs, it requires many SNPs in various permutations and combinations, and you need very large samples to do that, which, most of the papers, if you see, that are getting published are all from the Psychiatric Genetics Consortium. So if at all we are thinking in terms of such studies, we need to build a consortium of institutes. Like I know that there is an initiative going on from NIMHANS about the Asian Bipolar Genetics Network. So there they are tying up with countries like Thailand, Singapore. We at JIPMER Pondicherry are also a part of that consortium. It has just got some funding from NIH, and we are planning to recruit about, I think it's about 20K cases and 20K controls. So that is the level of samples that we are talking about. And then we need to think in terms of, building SNPs with predictive accuracy.
Thank you. And sometimes the focus shifts on to epigenetics.
Yes.
So what is your...
Those are two sides of the same coin, sir, I would say. So genetics and epigenetics should not be looked at in isolation. It's an interaction between genetic and epigenetic factors, like what we were discussing, some of these environmental factors which are necessary for genetic expression to occur. So that is where the individual variations come in. Like somebody with a genetic susceptibility, two people with the same genetic susceptibility variant may not behave the same way depending on their epigenetic factors. So that is also equally important for us to understand. I agree with you, sir.
Thank you. Thank you so much. Hand over to Dr. Kishan for final comment.
So before concluding, I think it's a wonderful talk. But because I think you covered a lot of things. Any comments on psychoneuroendocrinology related to this?
Yes.
You covered the stress response, other things. Any
Yes, sir. So there I would like to again emphasize that the HPA axis, if you talk in terms of psychoneuroendocrinology, the HPA axis is very important. And abnormalities in the HPA axis in terms of overactivity, excessive production of glucocorticoids, impaired feedback inhibition of these responses. So that have been a common perturbation across, of course, the evidence is maximal in depression, but also HPA axis abnormalities have been noted in bipolar disorder, in schizophrenia, and all other major psychiatric conditions. So psychoneuroendocrinology, I hinted to, sir, when I talked about immune inflammatory dysfunction. So that is a very, very important part when we're trying to understand comorbidity. And now trials of anti-inflammatory agents as an adjunctive treatment to have been, there has been good evidence with antidepressants, with antipsychotics, and even in bipolar disorder, even in bipolar mania also, there are trials of adjunctive anti-inflammatory agents like selective COX-2 inhibitors, aspirin, minocycline, and other anti-inflammatory agents. So there is a lot of evidence for alterations in psychoneuroendocrinology. So.
Yeah, thank you. And before, I think with this interaction, it is a very comprehensively covered topic, and most of them are here, all are postgraduates. Try to be there for all topics, and it's wonderfully structured by Dr. Gauri Devi and I think VK Aravind. And this will open, if you understand everything, meticulous understanding, it will open your future research abilities and areas to research, as well as it is certainly useful in the practice, in understanding, as well as in assessment of prognosis, and for trying for better prognosis in your future clinics. So try to be there for next think tomorrow afternoon, till tomorrow afternoon, I think try to utilize the what is really wonderfully structured CME program by Gauridevi Madam and Vicky Arvind. Thank you. Over to organizers.
Thank you so much, sir, for a very informative session. I would now request our chairpersons to present memento to our speaker. I would like to request our speaker to present mementos to our chairpersons. Thank you so much, sir. So now moving on to our third topic of the day, that is neurodevelopmental disorders of childhood, comorbidities, diagnostic dilemmas, and difficulty in management. I would like to invite Dr. Ram Subba Reddy and Dr. LVR Usha to chair for this session. Dr. Ram Subba Reddy is a professor of psychiatry, Usmania Medical College, Nilofer Hospital. He worked as assessor of speech therapy post-cochlear implant surgery, worked as assistant professor in Kurnool Medical College and associate professor at Gandhi Medical College. Dr. LVR Usha, she's done her MBBS from Armed Forces Medical College, served in the Army Medical Corps for 5 years. She's done her MD Psychiatry from Usmania Medical College, currently working as a professor at Usmania Medical College IMH, and has published many papers, including 4 in child psychiatry. I would request our chairpersons to introduce our speaker and do the further proceedings. Thanks, sir.
So, good morning to all the delegates presented here. Okay. Am I audible? Okay. First, I thank the organizers for giving me this opportunity. And today's topic is CME is mainly on comorbidities. The entire day, the speakers are talking about the comorbidities. And the present topic is neurodevelopmental disorders of childhood, comorbidities, diagnostic dilemmas, and difficulty in management. So the comorbidities are very common in psychiatry, and moreover in child psychiatry, it's more common in all child psychiatric conditions. So most of the times we are getting the cases from the peripheries like autism, ADHD, and all the cases are on the rise since 5 to 6 years. And most of the times all ASD cases, we can see the ADHD symptoms. Nearly 20 to 60% of the ASD cases present with ADHD symptoms, clinical symptoms. Even in ADHD also, we see 30 to 60% of cases with clinically ASD symptoms, autism symptoms. So these type of overlaps are very common in child psychiatry. So regarding the other conditions, even in the DSM-5, they brought the term neurodevelopmental disorders as a spectrum. So in this spectrum, the conditions include all these things: intellectual disability, communication disorders, ASD, ADHD, even movement disorders. All these things are there. But basically, in child psychiatry, we see only few conditions. Most commonly, ADHD and ASD, and intellectual disorders, SLDs. So there are some controversies and welcome changes in the DSM-5. The controversies are here. They brought the Asperger syndrome into the neurodevelopmental disorder under ASD. And based on the severity, they decided the condition is diagnosed as level 1. And which is having a good prognosis. Because of bringing this Asperger syndrome into this autism spectrum disorder, I think it is stigmatizing the children. And the one more thing is here, they changed the ADHD also, this criteria from 6 symptoms to 5 symptoms to diagnose inattention. And they changed the age of onset of symptoms from 7 to 12 years. I think these are some of the things we have to get clarification from our speaker. Now I request Dr. Usha Madam to introduce the speaker.
Thank you, organizers, for giving me this opportunity. I would like to tell something about the speaker. Dr. John Vijay, introduce the speaker. Dr. John Vijay Sagar is professor and head of the Department of Child and Adolescent Psychiatry at National Institute of Mental Health and Neurosciences. He was awarded the prestigious NIH USA funded Indo-US Fogarty Fellowship in 2014. His main interests are neurodevelopmental disorders, especially ASD, pediatric psychopharmacology, adolescent mental health, child abuse, and neurobiology of child psychiatric disorders. I would like to invite our speaker to proceed on with the topic.
A very good afternoon to all the participants of this PG training program, and I thank Dr. Reddy as well as Dr. Usha for having introduced the topic and also given a kind introduction about me. So at the outset, I would like to thank the organizers. Hello, am I audible?
Yes, sir, you are audible.
Yeah, thank you. So at the outset, I would like to thank the organizers for having chosen this topic as part of this PG training program with the theme of the comorbid disorders. As our chairperson, Dr. Reddy, has highlighted the complex presentations clinical presentations that can happen due to the co-occurrence of the neurodevelopmental disorders and the psychiatric disorders. So this topic, I think, is of practical relevance for all the practicing psychiatrists, postgraduate trainees in psychiatry. When we encounter children and adolescents and even adults as they move beyond the childhood and adolescent period with the presence of one or more neurodevelopmental conditions along with the psychiatric disorders. So I would share my slides. So hope my slides are visible. So I am going to present a brief practical overview of this comorbidities of neurodevelopmental disorders and in the clinical setting, how do they present? What are the challenges in the diagnosis and management? What are the important points we have to remember when we sit in outpatient, inpatient settings, evaluating these children and adolescents? So I'm not going to get into too much of this studies and statistics, looking at different kinds of research and the figures, like whether it's 20%, 30%, 40%. So that I have kept out of this presentation because it will be very confusing. So I have kept it a very simple and practical kind of presentation. So I would like to convey the greetings from my department, the Department of Child and Adolescent Psychiatry at the National Institute of Mental Health and Neuroscience, Bangalore. A quick recap of the concept of neurodevelopmental disorders before we talk about the comorbid conditions. As you can see, historically, the first time this concept appeared in the textbooks of psychiatry was in the 1820 when Jean Georget he had mentioned this in one of the textbooks written. So this was the earliest account about the developmental disorders. And subsequently, we see that the concept of developmental disorders were mentioned in the DSM-3, though the detailed characterization of these conditions was not done. What are these conditions? These are heterogeneous group of clinical conditions in which the neurobiological development is disrupted. And typically they present with the developmental delays or deviations. And the onset is in the early developmental period. the presence of these conditions results in the impairment in functioning, one or more domains of functioning, and there is persistence of these conditions across the lifespan. So as you can see, the DSM-5 and ICD-11 both have included these conditions under the rubric of the neurodevelopmental disorders. We are aware that in the DSM-4 as well as ICD-10, this kind of overarching kind of diagnostic category was not there of neurodevelopmental disorders. So across both these classificator systems, you can see that again this was highlighted by our chairperson in the introductory remarks, saying that the common neurodevelopmental disorders are intellectual disability, autism spectrum disorder, attention deficit hyperactive disorder, and stereotype movement disorders, tic disorders, developmental coordination disorders, and also the group of specific learning disorders which has been labeled as a developmental learning disorders. So these are all the common conditions which have been kept under the neurodevelopmental disorders. Moving on to comorbidity. So what is comorbidity? It is a co-occurrence of more than one disorder in the same individual, and it includes broad range of conditions. As far as children and adolescents are concerned, this is one very common statement that is made in any of the child and adolescent psychiatry introductory lectures on child psychiatric disorders, that comorbidity is the rule rather than the exception as far as children and adolescents are concerned. Comorbidity does not imply a causal association, and it can be of varying severity from mild to severe. And also, when we look at the chronological aspects of the comorbidity can happen at the same time, that is, presence of both disorders in a given individual point in time, or during a period of time. So maybe within a span of few months, maybe a year or so, where we see that during the process of our clinical evaluation and follow-up, two disorders are co-occurring in the same individual. And also the sequence part, like wherein an initial condition may start first. Typically, it is a neurodevelopmental disorder, as I mentioned in the initial slide, that they have an onset in the early developmental period. So that onset that is typically happening in very young children, and subsequently the other disorders, especially the psychiatric disorders, being added to the already existing neurodevelopmental disorders in a sequential manner. So why we need to screen for this comorbidities? What is the importance? Comorbid disorders are common and they're often missed or misdiagnosed. And so screening for these conditions helps in early identification and intervention, not just of the comorbid disorder, but also the neurodevelopmental condition also. And it helps reduce the caregiver burden. Comorbid disorders have the need for specific interventions which can be provided. Say, for example, in a child with a neurodevelopmental disorder like ADHD or autism, if we identify a comorbid psychiatric disorder of either a depression or an anxiety disorder, medication intervention can definitely be provided, and the child will get the benefit of improvement of those symptoms and improvement in their functioning. So overall, the functioning of the child and adolescent will improve with screening of comorbidities and the prompt intervention for the comorbidities. And also the identification and also the timely intervention leads to better short-term as well as long-term prognosis. So let me spend a couple of minutes on this slide, which highlights the various clinical scenarios which we may encounter when we see children presenting with the neurodevelopmental conditions and when we start screening for the comorbid conditions. So one of the scenarios is presence of two or more neurodevelopmental disorders in the same child or adolescent. So that is, say for example, if the child has autism spectrum disorder and intellectual disability, and we know that almost 40 to 50% children or slightly higher percentage of children with autism also have intellectual disability in the clinical samples. And the presence of ASD and ADHD, which again was mentioned by our chairperson, like rates anywhere ranging from 20 to 40%, and more common in the male children compared to the females, this presentation. And also it could be like ADHD with communication disorders and specific learning disorders. These are some of the examples where there is a coexistence of at least two or more neurodevelopmental conditions. And the other scenario is presence of one neurodevelopmental disorder with one or more psychiatric disorders, and presence of two or more neurodevelopmental disorders with one or more psychiatric disorders. As you can see, it could be combinations of any permutations and combinations of any disorders, and it could be ADHD with depression, intellectual disability with OCD and psychosis, autism spectrum disorder with intellectual disability, bipolar affective disorder, etc. Last but not the least, the presence of medical conditions in persons with neurodevelopmental disorders. This also we need to keep in mind. A given child or adolescent can have a neurodevelopmental condition and a medical disorder as coexisting conditions, like autism with epilepsy or intellectual disability with congenital heart disease, etc. So, specifically looking at the psychiatric comorbidities, why does this co-occurrence or coexistence happen? Impairment in the brain development, CNS development, contributes not only to the neurodevelopmental disorder, but also to the behavioral and emotional dysregulation that is seen in the psychiatric comorbidities. Also, there could be associated problems like speech and language impairments and seizures, which can predispose the person with a neurodevelopmental disorder to develop another condition. Then the third possible explanation is the limited intellectual potential, especially in those children where the intellectual functioning is sub-average. It increases the vulnerability to environmental influences and the stresses which the child experiences. Then these children with neurodevelopmental disorders are more likely, because among the children with different conditions, the children with neurodevelopmental disorders form a specific vulnerable group. And this group basically are more likely to experience adverse conditions of upbringing and more likely to have, say, problems like understimulation, overprotection, and even in terms of the parenting or caregiving practices, inconsistent disciplining, etc. So, as clinicians, when we look at either the misdiagnosed or underdiagnosed of these conditions, what are the possible factors? So, one of the common factors is that already a diagnosed neurodevelopmental disorder, the clinician may feel that I can't or I should not diagnose another condition. It's not right, and so sometimes we have this concept of overshadowing, where any features that are seen, any symptoms or features that are seen, are subsumed under the neurodevelopmental disorder itself, rather than making a separate diagnosis of a psychiatric condition. And also the concept of diagnostic masking, wherein the psychiatric disorders, when they are comorbid with the neurodevelopmental disorder, there is an atypical clinical presentation. Say, for example, if the child has a mood disorder, along with a pre-existing neurodevelopmental disorder of either an intellectual disability or autism spectrum disorder, they may not be able to clearly verbalize the mood changes, especially whether the sadness of mood, or at certain times in children and adolescents, we may even see the irritability or anger. So it may be seen mostly as a behavioral change, wherein the child may become restless, child may be having the sleep difficulties, or there may be certain periods of the day where for a prolonged time, for few hours, child may appear very withdrawn or dull, etc. So these kind of behavioral, I would say, the changes or markers may be the presenting features. rather than the typical syndromic features what we observe in children or adolescents without neurodevelopmental conditions. So let us, this is a list of some of the syndromes that can occur. So in fact, all the syndromes that are mentioned as part of the classification system ICD or DSM can occur as comorbid condition disorders in children with neurodevelopmental disorders. It could be depression, bipolar affective disorder, OCD, social anxiety disorder, specific phobia, psychosis. Some of the conditions are common, some of them are more common, some of them are somewhat less common. And there is also this occurrence of several behaviors which may not reach the threshold of a syndromal comorbidity. Say, for example, the presence of frequent self-injurious behaviors, aggression, socially inappropriate behaviors, repetitive behaviors, and impulsivity, etc. And this is something very common. All of us would have seen children with intellectual disability, autism, etc., having a constellation of these kind of symptoms which may not reach the syndromal threshold. And also we need to keep in mind that there are several common medical conditions that we encounter in children with neurodevelopmental disorders. So cerebral palsy, epilepsy, allergies or atopic conditions, heart disease, gastrointestinal disorders, nutritional deficiencies, infections, musculoskeletal disorders, neurometabolic disorders, sensory impairments, etc. And these medical conditions sometimes may be part of a genetic syndrome. Say, for example, in children with Angelman syndrome. So there may be a presence of autistic features, and also there could be certain problems related to the cardiovascular system. And similarly, we know that in children with Down syndrome, there is a presence of intellectual disability along with some cardiovascular and musculoskeletal kind of problems. And in some syndromes, actually, there is a presence of epilepsy and the other neurological symptoms. So then moving on to the concept of behavioral phenotypes, certain behavioral patterns, they are more likely to be associated with specific syndromes. And when we see prominent behaviors in those areas, we will have to suspect those genetic syndromes, and we have to go for a more specific evaluation. Like, say, for example, severe self-injurious behavior, even to the extent of self-mutilation, is a hallmark of Lesch-Nyhan syndrome. And the presence of severe obsessive-compulsive symptoms, especially in individuals with either intellectual disability, autism, or presence of both neurodevelopmental disorders, we have to suspect Prader-Willi syndrome. And Fragile X syndrome, children with Fragile X syndrome, they may present with features suggestive of autism as well as the ADHD. And especially in adolescents, when we evaluate for psychotic symptoms, the Villocado-facial syndrome, though it's not a very common condition, so it is one of the syndromes that we need to keep in mind. So as a clinical, in the clinical setting, as a mental health professional, when we need to suspect the presence of these comorbidities, say if a parent or caregiver comes to us and says that my child has already been diagnosed with this condition, he has been diagnosed with autism, or he has been diagnosed with intellectual disability or ADHD, and we are receiving some therapies for that. However, recently there is an onset of certain new symptoms. That's when we suspect. And also when there is a worsening of pre-existing behaviors, or for the current neurodevelopment disorder, when the interventions are ongoing, but there is an absence of improvement with the ongoing interventions, that's when we have to suspect for comorbidities. And when there is initial improvement, say for example, in a child with autism, when we are identifying it early and intensive therapeutic interventions when they are provided, we keep saying small changes, what we call as micro gains. And when these gains, after a certain period, they reach a plateau phase, that is, it has reached a level where there is no further improvement. So that's when we suspect there could be a comorbid condition. And impairment in functioning that cannot be explained by the neurodevelopmental disorder alone, especially if there is a recent severe impairment in functioning. That's where we suspect. And when parents or caregivers report sudden uncooperativeness by a child in even any of the day-to-day activities, when they report that child is suddenly become uncooperative, and I'm finding it very difficult to manage the child. So recent changes in routine when it happens, and also in the presence of the recent life events, we need to suspect. And of course, for all of us, we have seen the last couple of years, the COVID pandemic has brought in a lot of stress to the parents as well as to the children, and especially those children with neurodevelopmental conditions, due to difficulty in seeking the formal interventions outside. Many of the therapy centers being closed, or even some of the support systems like special schools and all these things being closed, they were at heightened risk of these comorbid conditions. So some of the common features of the comorbid disorders I have listed out on this slide. It could be the restlessness, frequent tantrum behaviors, oppositional behavior, aggression directed either towards self, others, as well as objects, self-injurious behaviors, clinging behavior to the parent, withdrawn behavior, talking to self, smiling to self, crying spells, etc. Quickly, I'll take you through certain case vignettes to just give you a brief understanding about the varied clinical scenarios which I presented earlier. This vignette, you can see that the child has been diagnosed with mild intellectual disability earlier, and recently over the last 1 month he is presenting with symptoms wherein he is talking and smiling to himself, and he has been reporting that the others are going to kill him, and there is a clear deterioration in the personal hygiene, aggressive behavior towards the caregivers, with sleep and appetite being impaired. So there is a possibility that in the background of mild intellectual disability, the child has developed an episode of psychosis, psychotic illness, and which needs to be evaluated in detail and provided the necessary intervention. The second case vignette, you can see that the child has been diagnosed with autism spectrum disorder at the age of 3 years, and she has been on regular developmental and behavioral interventions. But at the age of 14 years, following an episode of severe bullying in school, there is a history since 2 months where she's engaging in repetitive self-injurious behaviors. She has become withdrawn, sleep and appetite has been affected, her self-care has become impaired, and she has crying spells. So it's likely that on the background of an autism spectrum disorder, she has developed an episode of depression following the traumatic experience of severe bullying in the school context. So the third vignette, basically you can see that the child had a diagnosis of ADHD, attention deficit hyperactive disorder, at the age of 4 years. He was on both behavioral intervention as well as medication, methylphenidate being the medication. That child, he presented with a 4-month history of repeated blinking of eyes, repeated shrugging of shoulders, making repeated grunting sounds. And then a 2-month history, more recent history of repeated hand washing behavior, repeated touching of others, repeated checking of doorknobs, etc. So we can see that on the background of a neurodevelopmental condition of ADHD, the child has developed a tic disorder as well as probably a obsessive compulsive disorder. And both these comorbid conditions have to be evaluated in detail, and specific intervention needs to be provided. So the next case example is one of a child with 2 developmental conditions, that is ADHD as well as the specific learning disorder mixed type, when he was about 9 years old. And the child received behavior therapy and remedial intervention for 1 year. And on the background of that, the child, currently he is now grown up and has become an adolescent. And he has started using substances, tobacco and cannabis, started absenting him from school and getting into the deviant peer relationships, stealing money at home, showing running away behaviors and aggressive behaviors on multiple instances. So this shows that with the background of ADHD and specific learning disorders as the developmental conditions, during the adolescence phase, the boy has developed substance use disorder as well as conduct disorder as the comorbid conditions. The last case we met, the child who is 6-year-old, who had a prior diagnosis of ASD at the age of 3 years. This 6-year-old child is brought by the parents with a history of recent change in behavior following with the following symptoms. Parents report that intense anger with physical aggression appears as episodic phenomena, and also he has difficulties in academic learning. And they have noticed that there are episodes of jerky limb movements followed by stiffness of limbs. And child was initially evaluated in child psychiatry, later referred to the pediatric neurologist, where a diagnosis of comorbid epilepsy was made and EEG confirmed, like which showed that epileptiform discharges. So in the evaluation, what we need to consider, detailed history from multiple informants is necessary. And we have to focus on the medical history also. Behavioral observation of child is very important. And children who they can communicate, especially those with milder forms of neurodevelopmental condition who don't have much communication difficulties, the mental status examination has to be done. And a life chart approach, because all these conditions, whether it's neurodevelopmental or psychiatric disorders, whatever conditions that have onset during childhood and adolescence, we have to remember that they continue across the lifespan in some form or the other. So life charting of the course of these conditions is very important, where pictorially we can depict the onset of these conditions, the interventions that the child is receiving, and whether it's the pharmacotherapeutic or the non-pharmacological interventions, the response to interventions, etc. And the specific assessment scales have to be used, and assessments have to be carried out over multiple sessions. And child's functioning is something we need to assess in detail. That is very important. And certain times, the inpatient admission may be required, because in some clinical scenarios, in a OP setting, in a busy OP setting, actually with 1 or 2 sessions, we may not be able to clearly diagnose the comorbid condition. And sometimes we may have to rule out the medical conditions also, because certain medical comorbidities may present with behavioral symptoms. So to address that, and also for the round-the-clock behavioral observation and carrying out the assessments in detail, the inpatient admission may be required. So these are some of the tools for assessment. I am not going into the details. These are just list of tools. And some of the tools, they are available freely. Some of the tools have to be purchased. The tools are especially used in the setting of research, like though in the clinical settings, it may be difficult to use the tools routinely with all children. And other methods of assessment, which that we can educate the parents to maintain a mood diary and sleep diary, and also the behavioral observation notes, whatever they can maintain. And these days with the smartphones and the other gadgets, they can easily record the videos of the child's behavior and show it to us when they come for the clinical sessions. And the playroom observation of the child, and also doing the relevant medical investigations. So all the medical investigations are not required for all the children. Based on the conditions, what we suspect, the relevant medical investigations have to be carried out after discussion with the parents. And these are the principles of management. So the psychoeducation part is very important, wherein in a child with a diagnosis of neurodevelopmental disorder, the family has to first understand that there is a neurodevelopmental condition, whether it's intellectual disability or autism or ADHD or a combination of these disorders. They have to first understand that it's a developmental condition. Then whatever the comorbidity we diagnose, we need to spend some more time and explain to them, saying that this is an additional condition. And the available kind of intervention options have to be explained. And both at the individual level, family level, as you can see, there are interventions. And the medication, for example, we have to identify the clear target symptoms, and we have to start at a low dose and we have to titrate it slowly. And these children are specifically sensitive to the side effects, especially the extra-abdominal side effects or gastrointestinal side effects, or some of the metabolic side effects of these medications. So we need to monitor carefully. And of course, the presence of these comorbid issues creates problems when the child attends the school, whether it's a regular school setting or special school setting. So adequate liaison with the class teachers and the school management is very important for the professional as well as the parent to enable the classroom management of this problem behaviors that arise from the comorbid conditions. And caregivers also require a lot of psychological support, which can be planned in individual and group therapy formats. So with that, I end my presentation. I thank one and all for participating in this session. And I'll be happy to answer any questions or I would like to invite any comments or suggestions based on your experience in this area. Thank you.
Thank you, sir. Thank you, sir. Is it audible?
Yeah, thank you, sir.
Thank you, sir, for your wonderful, lucid presentation, and it's a highly informative presentation for all the postgraduates. I think most of the postgraduates who attended the child psychiatry posting, they can understand. The remaining people, I don't know. So the very detailed presentation regarding these neurodevelopmental disorders. Sir covered all aspects of the neurodevelopmental disorders, especially different types of disorders and its diagnosis, and is regarding the common reasons for misdiagnosis and underdiagnosis. And sir also mentioned behavior phenotypes, behavior patterns associated with specific syndromes, and he showed or he mentioned good case vignettes regarding the 5 case vignettes. I think you will have understand, you might have understand very well about the case vignettes. Some of the scales he mentioned, but so I think we don't know. They are only for the research purpose. Risk scale for child, dual diagnosis for all those things. So overall, it's a wonderful presentation, sir. Any questions from the postgraduates? Any questions from the postgraduates? At least those who attended child psychiatry postings. Any clarifications? If you want to, any clarifications or doubts, you can raise. Any other members?
Different scales that have been.
All the things you know well. PBCL, UPI,
Any single scale which can be used for all comorbidities?
Hello.
Sir, any single scale which you can tell to assess most of the comorbidities, sir? Any single one?
So how is it possible in psychiatry to get a single scale for all the comorbidities?
A checklist kind of a thing or any
Yeah,
scale?
so with regards to that, this the Nisonger that problem behavior scale is available freely. It's open access and it can be used. At least it gives though it may not give you the diagnosis, individual diagnosis, but it gives a good understanding of the problem behaviors which are accompanying the comorbid disorder in the child. And also specifically when we are looking at the presence of affective disorders and schizophrenia, this KIDDI schedule for affective disorders and schizophrenia can be used. That's also available, open access. You can use that. the aberrant behavior checklist or the developmental behavior checklist or child behavior checklist, these are all scales or tools that we need to purchase, especially we have used that even the behavior problem inventory and all those things. If we are planning some research activity, and definitely if we have some funding support, we can purchase and we can use it. But in the clinical settings, it may not be feasible for us to do all those things. What is important is, even if you do not use any of these scales, also in the clinical settings, what is important is getting a good history. First and foremost, confirming the neurodevelopmental disorder, and also taking a good psychiatric history, looking at the onset and whatever interventions that are ongoing, recent life events, behavioral changes, ruling out the medical conditions, behaviorally observing the child. I think, and using the clinical judgment. That is, I think, Sir was mentioning about the child psychiatric posting. I think it's it's beyond the posting also. Like as mental health professionals, when children form about 40% of the population, and the neurodevelopmental disorders are quite common. And in our clinical practice, definitely, if on an average we may see at least, if though we may not be solely practicing child psychiatry, but we may come across children and adolescents with these conditions, at least 2 or 3 children per week, and even more than that also. So in those instances, definitely we need to keep our mind open, keep our eyes open, and specifically ask questions and look for behavioral changes. And we have to suspect, we have to evaluate, rule out, and if we find that, we have to actively intervene and provide the needed interventions.
Thank you, sir. Thank you.
Dr. John, that was an excellent presentation on the comorbidities. The question which I would like to ask is, see, generally in comorbidities, as they say, is it a fact or is it an artifact? So when it comes to the child psychiatric symptomatology presentations itself, there is so much of admixture among the various categories itself. I think definitely this is a great problem in separating, because the concept itself is very difficult to know whether something is a fact or artifact. Some of them could be because of the arbitrary diagnostic criteria which are used in the diagnostic classificatory systems. That is one question. And second question is about the DMDD itself. Disruptive mood dysregulation disorder. There are so many symptoms which are listed, but then the operationalization of the symptoms is somehow difficult to understand, because if you take a child, probably out of the number of symptoms, definitely either they are syndromal or subsyndromal of this particular disorder. So these two questions which I have.
Yeah. So thank you, sir. Thank you for your questions. With regards to your first question, like whether it's a fact or artifact, I totally agree with I think you are very valuable kind of I think it's an experience from your clinical experience, wherein you have seen that it's an admixture of different symptoms or features. So the purer forms of this condition, as we open the either ICD or DSM, and these are categorized into clear compartments, and say that this is the disorder, these are the criteria, 4 out of 7 symptoms should be present for 6 months or 1 month. So that's not how especially the children or adolescents present to us in the clinical settings, and presence of the admixture of these things is very common. However, what I would like to say is, we need to be careful about over-diagnosing also. That's also one thing which we should avoid. Just because we have these diagnostic manuals, not every child there should be a one or more conditions. So especially we need to look at the psychosocial adversities also, or psychosocial factors what these children go through, and especially if it is present for a brief period and if it is improving, maybe for a couple of weeks, and if it's not persistent, say beyond a month, and also we'll better we can take a wait and watch approach rather than giving multiple diagnoses. Having said that, if it is persistent for a reasonable period of time, and if clear impairment of functioning is happening, better to diagnose and intervene. Both, I think errors, we should be aware of, like overdiagnosing and also underdiagnosing or misdiagnosing. And coming to your second question about the DMDD, though with the newer classification, this has been added as a independent disorder, the disruptive mood dysregulation disorder. There are a lot of, I think, critique about that, like wherein there are other disorders where certain symptoms there is a significant overlap. Like say, for example, children with mood disorders, especially severe depression or bipolar disorder, there is significant irritability, and even those children with severe behavioral disorder like that of severe oppositional defiant disorder, there could be irritability. So those things we may diagnose that as DMDD as per the new classification sometimes. And also this is a particular, at least in our center, our experience has been that our professionals have not been giving this diagnosis frequently. So I don't see many children getting this diagnosis, though it has entered the classification, it is there. The classical description what they've given there, sometimes there is overlap with the other conditions, and some of those conditions in terms of the prevalence are much more common, and they get precedence over that.
Thank you, Dr. Sagar.
Sagar, it's very nice presentation. The only thing I just would like to say, like below 5 years of age in the neurodevelopmental disorders, the issues that really we come across are, one is developmental delay. The second one is communication problems. The third one is stereotype behavior and other behaviors. See, most often what happens is, in addition to that, the one which I just would like to impress on people is the sensory issues. Many times only sensory issues will be predominant, but because of the sensory issues, child might be having stereotypic behavior, which can be diagnosed as autism, and they proceed making the diagnosis and sometimes giving the medication. At the same time, I would also like to add that many times, especially with pediatricians, they generally say there is a mild speech delay. The child is not really looking this side or that side, maybe some sensory issues, and they delay, so that the autism can be, not diagnosed or, misdiagnosed as just developmental disorder or any other medical disorder. So these are the issues. Why I am just saying is that these are the problems we come across, especially below the age group of 5 years. So the best thing is, as you rightly pointed out, the history is very important. And I would say that it's not only the child's development, after birth. I think before that, preconception is also very important, where we can also get issues of developmental delays in the parents or the sibling. So those can also add to our diagnosis. And very important thing I would like to impress on all the postgraduate students is that whenever child below the age of 5 years comes, whether it's intellectual disability, global developmental delay, or the language delay, or some stereotypic behavior or any sensory issues, it should be a multicentric approach. It should be, early intervention with speech therapy and behavior modification, ABA. So these are the things that, we found great improvement. It can be any comorbid or having all symptoms. If you give all the modalities of treatment at a stretch, the child will be in a better position to improve. I hope, you agree with this. This is just addition to what you said.
Thank you, ma'am. And I think Madam has clearly echoed the importance of very young children, because when we talk about whether it's global developmental delay or specific developmental delay, and forget about the diagnosis, any developmental delays or deviance, which with careful screening of the children for the developmental domains, that's something when we talk to our other colleagues, also pediatricians, and these days the developmental pediatricians or pediatric neurologists or even the general practitioners, etc. And even ourselves, having a good understanding of the normative development of children, and especially the certain domains we should not ignore, like socio-emotional development and language development. Because usually screening, we just restrict ourselves to gross motor, fine motor, and maybe some cognitive development aspects. So all these multiple domains has to be assessed, and it has to be monitored, and the regular follow-up with early intervention, and then seeing whether it goes into a particular developmental pattern. Because among the neurodevelopmental disorders itself, whether the etiopathogenesis or even their clinical presentations, we know that now that there is a lot of overlap. In fact, there is a particular theory which is called neurodevelopmental continuum hypothesis, which says that even the psychiatric disorders which appear later in time, they all have certain neurodevelopmental kind of origins. So having said that, this is something which has to be taken as a lifespan perspective and evaluated right from the early childhood, and with careful monitoring and early interventions. Thank you.
Thank you, Dr. Sagar. I would like to add that managing neurodevelopment disorders itself is a challenge. And when there is associated comorbidities, it becomes even more challenging. And of course, with all these scales and all, we can screen. But I would like to stress that prevention is the best. You have not touched upon the preventive aspects. So maybe that will help check the comorbidities at least, if not the neurodevelopmental disorders. Or to some extent, even neurodevelopmental disorders by genetic counseling and other like antenatal and prenatal management of the mothers.
Yeah. So with regards to the prevention, I think very important point wherein in the during the preconception phase itself, the health of the woman, and also during the pregnancy, especially the maternal stress, things like that are getting related to neurodevelopmental conditions now, and also maternal infections, maternal nutrition. These things are very important, and also providing some of the nutritional supplementation on time, and recognizing some of the especially the metabolic disorders and some of the inherited kind of disorders early. And there are like especially certain therapies that are being developed now, like enzyme replacement therapies, etc., to be provided, so that will also assist along with the developmental interventions, whatever we provide.
Thank you, Madam Gauri Devi, Madam, for mentioning all the sensory aspects. Most of the pediatricians who practice outside, usually they miss because they don't have the concept of early intervention. The pediatricians who are working in the institution, they only have this concept. Otherwise, the people, they go on neglecting. This is the main root cause for till 5 years or till 6 years. Even the speech development is delayed, they will be assuring. This is the main problem. Thank you, Madam. And regarding the treatment protocol, sir, you mentioned initially the psychosocial interventions. I think based on the symptom severity, we have to go just like initially we have to start with psychosocial interventions or next medication.
Sir, it depends. I think it's initially with as even Gauri Devi Madam has highlighted, it's a combination of the behavioral interventions along with the proper psychoeducation of the parents and frequent follow-ups, and adding the medication when definitely there are target symptoms, like say for example when there is hyperactivity, when there is aggression, when there is self-injurious behavior, adding medications like low-dose antipsychotics, or when there is clear symptoms suggestive of anxiety or depression, adding the SSRI group of medications, etc. With careful monitoring. I think both go hand in hand.
Right. Thank you, sir. Thank you, sir, for answering all the questions.
Thank you.
Over to the organizers.
Thank you so much, sir, for such a wonderful presentation. And we are glad that you could join us virtually and share your knowledge. I hope the PG students must have gained a lot of knowledge from this presentation. Thank you so much, sir.
Thank you, madam.
I would now request Ashok Reddy, sir, to kindly present mementos to our chairpersons. Thank you, sir. Thank you, ma'am. So just a couple of announcements before we break for lunch. So the poster presentation is between 1 to 2, that is during the lunch break in third floor Krishna Hall. So the presenters are expected to be there while the moderators visit them. And also the students who have enrolled for the RTMS workshop are requested to assemble at the desk, registration desk by 5 p.m. and any delay or if any slots are available, the next interested candidates would be accommodated. So we're breaking for lunch from 1 to 2. I would request everyone to assemble by 1:45 so that we can get back on our schedule.
check.
in Psychiatric Disorder, which will be presented by Dr. Arun Kandaswamy. To chair the session, I would like to invite Dr. IRS Reddy sir and Dr. Naresh Wadlamani sir. Now I request chairpersons to kindly introduce our speaker for the day and do the further proceedings.
Good afternoon, everyone, and welcome to this PGCME. I think since morning you had wonderful sessions, and added to that we have another session, an excellent session, Substance Use Disorders, Cause and Effect in Psychiatric Disorders. The speaker is Dr. Arun Kandaswamy. He is the additional professor of psychiatry from NIMHANS, and his special interest is in addiction medicine. With this introduction, I will leave the rest of the session to Dr. IRS Reddy Garu, who will introduce the topic. And yes.
Yeah, thank you, Dr. Naresh. And so this is the first session after lunch. I think many people are still in the lunch and they have to come back. Anyway, so any session after lunch will be a little difficult to, because of the post-lunch effect. Anyway, we have got a speaker, but it is on virtual. See, there is a proverb in Telugu. I think many Telugu people are there. Guddu munda, kodi munda ani. And whether the chick is first or the egg is first. So whether the substance use is the primary or the mental illness is the primary, which causes what? So many times, no, substance they cause, like alcohol causing psychosis or delirium, cannabis causing psychosis, cannabis psychosis, and at the same time mental illness leading to substance. For example, in social anxiety, many people take alcohol to overcome the social anxiety, especially many of the stage artists and cinema artists, writers, for the creativity or for social anxiety, they take substances like alcohol or tranquilizers. So, or some depression. In depression, many people take stimulants to overcome their depression. And in schizophrenics, it's very popular. Many schizophrenics they used to smoke a lot. Understand? So this bidirectional phenomena is there. And in addition to that, the treatment also is little difficult. When we have got both substance and also psychiatric illness, treatment also becomes difficult because of the poor adherence, number one. And also the increase in metabolism. And sometimes these people are very violent also. So the adherence and compliance also is a problem. Anyway, our speaker Kandaswamy is a better person to speak on this, and he is in NIMHANS, and so we are all happy. And so over to Dr. Kandaswamy for his topic on this important subject.
Thank you very much, Chairperson. Am I audible?
Yes, you are audible.
Yeah, thank you. At the outset, I would like to thank Professor Gauri Devi and all the organizing members for inviting me to do this lecture today. Also, they've kindly allowed me to do the Zoom presentation because I am currently in isolation and still not out of symptoms also. Thank you very much to all of you. It has been a very well thought out program, which I could look at the whole list of topics which I had seen. Also, I've been listening from the morning, all the presenters, how they are moving towards proving the hypothesis every step. In fact, the first two presenters have made my job very easy because I don't have much to present in terms of the theoretical aspects of it. Let me focus only on the evidence with respect to the substance use alone to whatever extent possible, and then we can take it up further on the discussions if the time permits. without much ado, I'll move into my presentation, which is substance use disorder, cause or effect of psychiatric disorders. I'm sorry if my voice is going to be a little unclear, or I'm going to have cough in between. Pardon me. Greetings from my alma mater. I do not have any kind of conflict of interest at this point of time to reveal. Outline of my presentation is going to be, I would like to first give a background fact to set the stage in terms of discussion towards this whole comorbidity angle, and then move on to the relationship debate between substance use disorder and psychiatric disorders. A chunk of my presentation is going to be on the current evidences towards cannabis and psychosis relationship, because it's also a PG training program where a lot of questions are going to be on that side for them in the exams. And when I'm an examiner, I will also ask the similar kind of questions to them. And then we will move on to the relevance of this understanding towards the interventions. As our chairperson, Dr. IRS Reddy has pointed out, this is an age-old story, right? Chicken and egg, right? Now, who came first? There's always a fight, right? And this fight is more relevant to settings where there is one addiction unit and there is another mental health unit. Both of them are fighting who will take this case. But if it is a single practitioner or single the setting, it really doesn't matter. But whether this question is relevant to date or not, let's see this through this presentation from now on. From all the discussions which we've had till now, pre-lunch, we have established that comorbidity is a rule rather than exception. Right? In fact, comorbidity is not the right word to use at this point of time. Now people use the word multimorbidity. What do we mean by multimorbidity? It is a combination, it's a platter of substance use disorder, mental illness, whole host of developmental stressors, right from parenting, school related issues to loss of loved ones, to so many things which are there in the developmental stressor group. Then communicable disease, including COVID. There non-communicable disease, which has been very highly associated with both mental illness and substance use disorder, right? Now, all these things form multimorbidity. There's no more one or two. Here, we will have to look for all these things together. Otherwise, it won't make much sense for the management plan per se. Okay, let's move on to the relationship. At one point of time, there was one mental illness, there's one substance use, and there is a interaction between two of them, and there is this middle part where both will be there. That's just how it was looked at. And then over a period of time, the number of studies published and the research happened. There are various hypotheses which had come up, like extensively presented about the different kinds of this relationship by Dr. Vikas. Now, I would like to focus on only 3 steps. One is unidirectional causal association. Second is reciprocal causal association. Third is the transdiagnostic hypothesis of the psychiatric illness, which I somehow feel is very important, shouldn't be missed. And this is more of clinical experience-based presentation with the evidence around it. Unidirectional causal association. Now, as of date, this is where most of the evidence is coming from, right? Primarily, substance use disorder leading on to mental illness is where the whole research had come from. And that is substantially contributed by research from cannabis side. And there is some from alcohol and some from stimulant side as such. Let's move on to the cannabis. I'm going to talk about some of the major studies which needs to be known by all the postgraduates during their training program without fail. Number one is a Swedish conscript study. Now, this is one of the pioneer study by Sven Andersson from the Karolinska Institute. Now, this stated that all the Swedish conscripts who have been recruited in the military, Swedish military, when they've been followed up for 15 long years, those who have used those who had heavy consumption of cannabis during recruitment. Heavy consumption here actually equates to 50 times consumption, right? Had the relative risk of schizophrenia as 6, right? This is after controlling all the confounding factors. The same cohort was followed up after 27 years, and they found that cannabis users had a relative risk of schizophrenia as 2.2, and heavy cannabis users, the relative risk of schizophrenia is 6.7. With this, the inference is that cannabis increased the relative risk of schizophrenia, number one. Number two, when the dose of cannabis consumption increased, there is a high probability of the risk of schizophrenia has been established from this study. Next comes the cannabis use and the earlier onset of psychosis. This is a meta-analysis from the large group, and it states that the age at onset of psychosis was brought forward by 2.7 years in cannabis users and 2 years in unspecified other substance users compared to the non-substance using control. So there is a brought forward hypothesis also being brought in, where the psychosis is brought forward even before what was supposed to be there in the normal controls. Next comes the Danish registry study, which is another very, very important study which needs to be read by people. This talks about the conversion rate of substance-induced psychosis to schizophrenia or bipolar disorder. And here also, cannabis has the highest rate of conversion. CIPD, which is cannabis-induced psychotic disorder, gets converted almost around 47.4% into schizophrenia or bipolar. Next comes the amphetamines, cocaine, hallucinogens, because these are the major substances which have been associated with psychosis and they have been tested. Among the CIPD, the cannabis-induced psychotic disorders, 50 and those who have converted to schizophrenia, 50% of them had converted within 3 years of their first psychosis, which is very important because then we really need to look very, very systematically in the first 3 years and keep them in follow-up in the first 3 years to understand whether this client is going to be converted into schizophrenia at all or not. This is another study which looked at it's a meta-analysis which looked at the level of cannabis use and the risk of psychosis. For users, there is twofold increase in the risk of psychosis. For heavy users, there's fourfold increase in the risk of psychosis. This is another interesting study by 40 group, which talked about the potency of cannabis and how the higher potency of cannabis might increase the chance of having first episode psychosis in individuals. And this is something which is some study which has been done in South London. There are ups and downs about it. These are people who use something called as skunks, which are high THC content cannabis, and they seem to have a higher risk of first episode psychosis when compared to the others. This is another thing which even the chair has talked about. First episode psychosis has happened and it is cannabis related or cannabis associated. Somebody is being followed up regularly. If they continued, what will happen if they continue to smoke cannabis, or what if they discontinue cannabis? If people are found to be continuing to use cannabis, then it has been found that they have higher relapse rate, longer hospital admissions, and more severe positive symptoms. There's another study which even proves that poor adherence to treatment also as a part of this group compared to individuals who discontinue cannabis use or those who never used it also. This is a review which I would want. This is a narrative review, which will be very interesting to read for the PGs. Cannabis and Psychosis Through the Lens of DSM-5. It's published in 2019. This talks about cannabis psychosis. The understanding is cannabis is associated with 3 forms of psychosis. One is cannabis intoxication psychosis, where what happens is when there is a higher consumption of cannabis, what happens is there is a psychotic phenomena comes up, which is usually aggressive, agitated, confused, perplexed, more of affective kind of phenomena with perceptual distortions, which lands up in our OPD or to the emergency line. And the peculiar nature of this is that if you give 1 or 2 doses of haloperidol to them, the syndrome melts away in hours, right? That's where it is called as cannabis intoxication psychosis. As it moves out of the urine, the levels of cannabis comes down in the body, the psychotic symptoms improves dramatically. When the same thing continues in this severity and duration, it moves into cannabis-induced psychotic disorder, which is lesser than 1 month duration from the last consumption of cannabis, which needs to be kept in mind. And here also, it is very clearly pointed out, it can be affective or polymorphic picture, but not negative symptoms, right? These are 2 cannabis-induced psychotic disorders per se. But this is actually falling in the continuum of schizophrenia, as we have seen in the previous slide, that almost 50% of this CIPD gets converted into schizophrenia by itself. This is again the meta-analysis which talked about the association of the gene and the environment. We all know COMT is associated with psychosis, right? So the gene part is, the genotype part is COMT Val-Met allele polymorphism, which when it meets with the environment, here it is cannabis, it expresses the phenotype, which is psychosis, right? And this interaction was tested across a meta-analysis, and it was found that the interaction is not very clearly established. Now, this could be because of various reasons. Maybe the authors also have pointed out that we need even better data to talk about it, because there's a heterogeneity of studies which is seen in real life. This is the latest publication on the cannabis use disorder and comorbid psychiatric illness, and I urge all the postgraduates to read this for reference. This talks about relationship of cannabis with all psychiatric disorders, and it states that the strongest evidence of potential causal relationship, not causal exactly, potential causal relationship exists between cannabis use and psychotic disorder. While there are some evidence towards the directionality of causation towards anxiety and mood, it is inconsistent. When it comes to personality disorder, it's even more confusing because both of them are in the development during that core 18 to 25 years of age. So the directionality is very difficult to demonstrate over there. Like this is this final one, and the author is Deborah Hashin. As you all know, she's one of the architect and well-published researcher on this area. So to summarize, if somebody asks a postgraduate in an examination, like, what is the relationship between cannabis and psychosis? The answer I would expect is cannabis has plausible causal, contributory, and exacerbatory relationship in psychosis, right? Higher the frequency of cannabis use, higher the dose of cannabis use, higher the potency of cannabis being used, then higher is the psychotic morbidity in terms of severe psychotic symptoms, severe positive psychotic symptoms, poor adherence to treatment, longer hospitalization, and higher rates of relapse. And the cannabis use brings forward psychosis by 2.7 years. And if you give this information, I think it's a good summary of all the published literature at this point of time. Alcohol use disorder, again, quite a bit of studies are available in terms of, we ourselves have published about alcoholic hallucinosis and association with alcohol and alcohol-induced psychotic disorder. All those things have been linked. Alcohol withdrawal psychosis has been published. But it's a very difficult thing to see when it comes for evidence. It isn't very clear to state the directionality of the relationship. It is said that the directionality is heterogeneous, and we will not be able to comment on it. Again, this is a work from Deborah's group, published in Lancet Psychiatry. Methamphetamine psychosis, again, 40% of meth users do develop psychotic symptoms. Again, the directionality is going to be very difficult to determine over here. This is a study which we have done. We tried to look at this study to look at what makes some people at risk of developing dual diagnosis. So we looked at dual diagnosis in almost more than 600 men with substance use disorder, majority of them alcoholics. And we found that almost 58% of our population had an additional psychiatric diagnosis too. And majority of them had depression. Almost around 24% of them had depression and other disorders also being noted. And you could see that the illicit substances seemingly had a higher number of psychiatric diagnoses when compared to alcoholics per se. And this is evident over here. One of the things which I want you to watch is the ADHD diagnosis. Here, it is found that 2/3 of our sample had an additional diagnosis of ADHD in their diagnostic profile too. So at the end of all this statistical analysis, what did we come up with? What is our understanding? We understood that younger the client, earlier the onset of substance use, illicit substance users, people with ADHD, antisocial personality disorder, comorbidity, people with family history of psychiatric illness have higher chance of dual diagnosis when it comes for substance use disorders. And most of them needed inpatient care too. Now comes the reciprocal direct causal association. Now, this is another very interesting, like we looked at substance disorder resulting in mental illness, but it can be in the other side also. Again, Dr. Eddy has pointed it out. Now, I would like to give it as a story. There are 3 different pathways in which this happens, and mostly 2 different pathways. One is considered the externalizing pathway, another is the internalizing pathway. What is an internalizing pathway? Depression, anxiety, all the distress which is there inside, the anger turned inwards, what it does to the person is significant self-related issues, and that resulted in looking for coping strategies. Use of substance use become an easy way of coping with them, and that's how substance use happen in internalizing pathway. So it's a self-medication pathway. On the other side, externalizing pathways like this. Externalizers most often externalize their distress, and their anger is displaced outwardly. And it includes people with ADHD, conduct, ODD, CD. What happens in them is they are found, they are very distinct in their response to the dopamine producing actions. Like they don't seem to respond the same way. The dopamine production is not very good with normal pleasurable activities. They seem to have an altered production, altered reward perception, and only the higher dopamine producing activities give them the pleasure. So obviously they are more prone for substance use. In fact, the behavioral equivalent is most of these people on the first use would have never become intoxicated. They would have stayed strong even in the first use of substance onwards. And it's considered as one of the behavioral phenotype for the risk of developing substance use disorder at the later stage. On the other side, substance use disorder, due to direct neurotoxicity, kindling hypothesis, and catechol hypothesis, COMT, DRD3 hypothesis, would result in mental illness. So there is a bidirectionality to this. And once the mental illness results in substance use disorder, the substance use disorder again can push for other forms of mental illness because of various reasons, like whether it is because of skill deficits or it is because of the direct toxicity, it is going to happen. So it is a bidirectional relationship. Now let's come to the transdiagnostic relationship. Now, why I said that it's very dear to me for the clinic is, whenever I try to assess people who come with substance use disorder, I would like to include the behavioral addiction group also over here. When we talk to them, sit with them and talk to them and look at their childhood history, we can clearly point out that they have one or other form of developmental stressor in them. And majority of them have parenting related issues. I'm not blaming the parents, but there are parenting related issues, you want it or not, is found in them. And there are significant amounts of stressors which has happened at critical, there's a neurocritical period, and the critical time there are stressors which has happened to them. And all of them have issues with either the self-esteem or identity, emotional recognition, emotional regulation, distress tolerance, identity, attachment, all these kind of issues, one or other, is found to be there in them. Now, they are not to the level of diagnosing a disorder per se when they come to us, the different disorder, not the substance use as such. But then they are all in the background, and that results in their propensity towards developing substance use, because they are not able to cope up with all the syndrome which they are going through, the syndrome, the subsyndromal issues which they are going through. They are not able to cope up with it. And what they do is they use substance use as one of the coping strategy to get rid of it. And once they have used it between 15 and 25, as we know about the neurodevelopmental hypothesis, these people are going to be getting hooked onto it. Earlier the onset of use of substances, higher the rate of getting hooked onto the substances. And once they are hooked onto the substance, they are not going to be similar to all their peer group. They are not going to learn skills for their life. They are not going to be on par with others, and that results in self-esteem issues, skill deficits, again, emotional regulation issues, and that results in further mental illness related constructs. So this was very commonly seen in all the clients whom we see. And when we talk the same thing with other colleagues who see schizophrenia, OCD, and other disorders, even they seem to be having the similar kind of work. Whenever we see people holistically, we are finding that none of our disorders are just coming de novo. They all have a background problem, maybe subthreshold, but still there are background issues in them, which results in a later point of time, a full syndrome per se. Now, what does this mean? That there is a shared genetic and environmental risk in these people. And that gets manifested into a phenotype. We really don't know where and when and why a particular group, why not another group. We really don't know at this point of time, but this is what is happening. So I am of the opinion that transdiagnostic relationship needs to be explored, at least for the intervention aspects of it, even if it is not for the understanding currently. Now, I might be saying all these things, I might be gassing around. Where is the proof on all this? Right. Now, this is one study which would help me to prove my own clinical hypothesis. Dunedin cohort, the best birth cohort which is available to date. 4 decades of people have been followed up. They have been followed up on 3 different dimensions of illness. One is externalizing disorder, which it include ADHD, CD, ODD, SUD. Internalizing disorder, depression, anxiety, PTSD, eating disorder. And thought disorders includes OCD, mania, and schizophrenia. These are the 3 different lines of the family of disorders. And it's beautifully seen that whenever there is comorbidity, the comorbidity almost around 75 to 80% of the time doesn't belong to the same group. Either it's not that internalizing disorder will go with internalizing. It's not that externalizing disorder will go with externalizing. They all go into the different dimensions. Internalizing people can have thought disorder or externalizing. Externalizing can have internalizing or thought disorder. Now, this is what we call it as transdiagnostic. And what is the meaning? Like when the authors talk about it, they talk about it this way. The finding that most mental disorder life histories involve different successive disorder helps to account for genetic and neuroimaging findings pointing to transdiagnostic causes. And it cautions against over-reliance on diagnosis-specific research and clinical protocols. This is something which we really need to keep in mind. This is another small research which we have done in substance users, and we found that behavioral activation sensitivity and behavioral inhibition sensitivity are equivalents of externalizing temperament and internalizing temperament. And we found that majority of our clientele had higher externalizing tendencies even before the onset of substance users, and it was continuing throughout their substance use history also. And there's one area which I have not touched is the behavioral addiction part. I haven't seen a single behavioral addiction case, especially internet gaming disorder, without an underlying either syndromal or subsyndromal psychiatric issues till date, which really means that this is a coping mechanism for the underlying other issues, whether it is the disorder per se or the developmental stressors. And COVID has actually changed the picture very, very different, and it has increased the prevalence humongously. So evolution of the addiction or mental illness need to be understood this way. There is a vulnerability which could be biological or environmental. Biological includes family history, temperament. Environmental includes adverse childhood experience, parenting related issues, loss of loved ones, right? All kinds of developmental stressors, right? And when this meets with a proximal antecedent, what is proximal antecedent? It could be at that point of time, there is some kind of loss of love affair can happen, or something over there can happen, or a substance use itself can happen at that point of time, would result in a particular psychopathology. It could be either addiction or mental illness per se. And when they are present, or both together, and when they are present for a certain period of time, they would result in certain set of consequences, which could be medical or psychological or addiction related or other high risk behaviors, right? And this is how evolution of addiction or mental illness commonly happens. And we really need to assess the addiction or mental illness in this way only. Whatever is the diagnosis is a primary illness for which a client has been brought to you. You need to look for the other diagnosis in each of the stages of these evaluation. Do not forget to add NCDs into this list because they seem to be present throughout. Okay, what is the relevance of all these understanding if it doesn't translate into a clinical practice, into the treatment related clinical practice? We can talk over and over about this, but then how is it going to translate into the clinical practice? That's where the intervention comes in. Intervention, I split it into two things: treatment related intervention and prevention related intervention. I will not go into much details because it's beyond the time for this. Let me just give a gist of it. A treatment flow is going to be like this. It's on the opposite side. When I talked about evolution, it starts from vulnerability, psychopathology, consequences. When the treatment, the flow should be from the consequences, which is the actual problem for which they would have presented to the hospital, to the psychopathology, and the last one to be handled is vulnerability. But unless the vulnerability handled, the lapses and relapses are going to happen. So till vulnerability being handled, we need to work on with them. Like this is going to be the treatment flow. With respect to dual diagnosis or comorbidity or multimorbidity, the treatment paradigms are three different kinds: sequential treatment model, parallel treatment model, integrative treatment model. Sequential treatment model. When it comes for sequential treatment model, that you treat one and then treat the another line. This is more or less becoming obsolete because it's not cost effective, and it's you will lose patients also. They will not get adequate care. Next comes parallel treatment model, where one group of people will be treating schizophrenia, another group of people will be treating addiction, because they see it as hair and nail, right? Again, it's of no use to the client. Maybe we are developing specialties, but it's not useful for the client. Integrative treatment model is the best model which can be given to people, and it has been found that having best evidence over here. Like, what happens is a multidisciplinary management combination of both pharmacological and psychosocial intervention, with understanding the client with both addiction and mental health related issues, and making a tailor-made plan for them, that is going to work better. Preventive interventions. Now, preventive interventions are primarily generic, and I would say that they are transdiagnostic. How do I prove that they are transdiagnostic? I'll take this example. This is the document, the latest document which is being produced by UNODC as the document for prevention of drug use disorders. Look at the intervention. For infancy and early childhood, the interventions are going to be perinatal and infancy visits, interventions targeting pregnant women, which includes pregnant women's nutrition and communicable diseases, pregnant women not smoking, not having alcohol, right? Early childhood education, supporting social and cognitive development. All these things are not specific to addiction. It is going to be improving the biological and the psychosocial environment of the child. Again, middle childhood also the same thing. Parenting skill programs, personal and social skills enhancement, classroom enrichment programs, policies to retain children in school like midday meals program, addressing mental health disorders. These are not anything specific to addiction alone. It can be transdiagnostic, and it can be even for obesity too. Early adolescence, again, prevention the education is based on social competence and influence. School policies on substance use, school-wide programs to enhance school attachment itself, and addressing individual psychological vulnerabilities and mentoring those who have difficulties. These things are not anything specific to substance. It's generic, and it's going to be useful across disorders. Adolescent adulthood, when it comes to adulthood, more or less it's moving towards substance specific person. Again, here the disease have already set in, so obviously there needs to be interventions for the secondary and tertiary prevention. Parenting. There is a whole host of things which I had put in over here, which talks about how to connect with the children and how to model the desired behavior and how to be the frontal cortex for your child and how to monitor the sleep, stress pattern in them, how to help them to take risk within a more safe environment and being in a network to handle younger ones, help them to do role play, and knowing what our kids do, and returning to the basics of our life, learning together and playing together. All these things are not anything which is specific towards substance use. It's going to be more enriching for the entire community per se. And the interventions to developmental stressors again, trauma-focused therapy, life skills training, peer-based interventions, money management skill, assertiveness and problem solving skills, all of this are something should be integral part of the prevention, and it is not specific for substance use. It is transdiagnostic. Community involvement, a caring neighborhood and community needs to be there. And the community should value the youth's potentials and allow the youth to experiment within a positive framework and give them certain avenue to do service and experiment on things, and sports activities being regularly conducted. And if it's a religious community and it is acceptable, following that is also a good thing. And again, these are transdiagnostic. So management in a nutshell, treatment paradigm needs to be more of integrative nature and multidimensional for a better outcome. Preventive interventions are not very different across all the psychiatric disorders. In fact, multimorbidity, including NCDs, obesity, hypertension, and diabetes also could be added to that as truly transdiagnostic. To conclude, multimorbidity is common in psychiatric disorders, including SUDs. Establishing the temporality in relationship is not the only factor for causality. Its importance in the era of gene to environment interaction needs to be re-evaluated. Transdiagnostic theories need to be kept in mind while formulating preventive interventions, as it will be cost effective. Now, in a lighter vein, which came first, the chicken, the egg, or the Delhi? Thank you. A big salute to all the Corona warriors who had worked and tirelessly working in this area. Thank you all.
Thank you, Dr. Arun. Thank you, Dr. Arun Kanswamy.
Thank you, sir.
Hello.
So could you hear me, sir?
Yeah.
Yes.
Thank you, Dr. Arun Kanswamy, for a very such a complicated topic. You made it very simple and clear. I think all our postgraduates were very clear about this. I think still, there will be a lot of questions, I think, because it is a very interesting and day-to-day problem in our practice. Both every day we come across these problems in our day-to-day practice. Now it is open for any comments, clarifications and questions, especially from the PGs first and then by the seniors. Okay. Please, we have got another about 15 minutes time. We can utilize the expertise of Dr. Arun for this. Yeah, please. You identify yourself from which place, which institute. Please give the mic. Identify and then ask the question.
Good afternoon, sir. I'm Dr. Navya, first year psychiatry PG from Apollo Jubilee Hills. Sir, so my question is, I wanted an insight on the scope of using cannabinoids in psychiatric practice, especially given that it's considered to be a gateway drug.
Okay. See, this is something which is going to be...
you need to unmute yourself, Dr. Arun.
I am unmute, sir. You're not able to hear me? Hello? Hello? Hello?
Yeah, now you're audible.
Okay. I think in between I'm lost. I think this is a very, very important question at various levels. One is on the therapeutic level. Another is on when you're sitting in front of your client and they come and ask you certain questions. Also, it's something which you ought to answer it like. Now, most of the research in terms of cannabis and its utilization in treatment is on CBD, not on THC. This is something which we need to be understanding. And the only disorder at this point of time which has gotten approval for use is Lennox-Gastaut syndrome, right? Epidiolex, and that's the only FDA approved situation, the orphan epilepsy, where this is being utilized. There are other areas where there are researches which has happened in terms of cognitive symptoms, in schizophrenia, certain thing. All the areas CBDs have been tried, and they have been found to be potentially a target for utilization in therapy. But none of this at this point of time had reached that threshold to say that they are good for treatment. Right? We really need to wait for a better evidence base to say that. We have been trying to bring in CBD. There are people who had brought in, wanted to do certain experiments. Still, hopefully, we'll be able to do some of these experiments and see how these are going to be. As of now, only the FDA approved indication is for the Lennox-Gastaut and not for any other syndrome. The most difficult question when it comes is from the clients when they say that like cannabis is curing cancer, this, that, and others. Like there is absolutely no evidence towards that at this point of time. All the evidence have come from usage of THC. THC obviously is going to help people to feel good. There's going to be feel good factor, and the feel good factor is going to be improving general health related well-being, right? So that people use it as the reason to do it. Scientifically, we don't have anything to offer from cannabis at this point of time. Maybe it will come in the future. We don't know. We can't preclude that. But at this point of time, we don't have enough to say. But it is a molecular target, not THC, but CBD. And CBD is not going to be psychotropic as THC.
Thank you, sir.
Yes, sir. Dr. Anand, sir.
That was a very nice presentation, Dr. Arun.
Thank you, sir.
The recent articles are talking about what is called as the psychedelic psychiatry. And that too for mental illnesses. Okay. So this appears to be slightly problematic to understand. Your impressions on this?
Sir, in fact, I did just before COVID all started, I did a presentation also on these things. This is the whole psychedelic medicine which has been now coming up. Now, this is a very different kind of understanding and intervention which people are looking at. The psychedelic induced psychotherapy is something has been found to be useful in certain disorders. For example, MDMA-assisted psychotherapy in MDMA-assisted psychotherapy in PTSD, and some things with LSD-assisted, single-dose LSD-assisted treatment with OCD. These are being tried, and they are found to be useful in experimental settings. But really, we have not come across. But we can't give away also, because these are for the treatment resistant group of people where nothing is working. If there is going to be a target of using these stuffs and they can be of help to people, then why not? But this is not for psychosis. These are for people who are into therapies, especially on the dynamic nature of it. And this opens up the whole LSD related, the psychedelic related experiences opens up a whole lot of areas to explore and insight facilitation towards achieving certain outcomes. Now, this is not something has come up into clinics that effectively at this point of time, needs a lot more research. The colleagues from, it's more from the European countries at this point of time. The David Nutt and colleagues have been working significantly on this area, the psychedelic medicine, psychedelic related psychotherapies. And there are a lot of publications which are coming up also. But again, these are all case series at this point of time.
I was actually wondering how the ethics committee has given any permission for the use of psychedelics without showing the theoretical model or some evidence towards that.
Sir, there are publications in the past, sir. There are publications in the past which had said that there is improvement when this thing happens. So what they do is usually see for single patient related treatment strategies and then case reports which they are being generated. That will be shown as thing. And then there are lots of checks and balances which they will put in, and how they need to be monitored and all those things. Possibly something agreeable to that kind of setting. Unfortunately, in our settings, it's a very different ballgame. If we the argument is, if we agree upon surgical intervention and deep brain stimulation related interventions, why not this? They might bring in that way. Again, it is an experimental treatment. Nobody knows what it works, and this is for people who are treatment resistant. If they bring in that way, it still might be acceptable to people. And if all the protocols are being followed.
Next. Okay.
Yeah, still I feel that it's a human rights problem. Thank you.
Sir, actually, it's a very interesting argument per se. Like, but you do know that there are heroin-assisted clinics also available for opioid substitution treatment in European countries. So even that will be a lot questionable, but then it's existing.
That's a
right. No, but again, replacing heroin is something which is still questionable. In our country, there is still even question about using buprenorphine itself, and we are thinking of heroin replacement.
Anyone, please? I think, Arun, you have done a fantastic job in presenting the topic, which is complex topic, and one of the best slides, which I think for the PGs was that if they can understand the Dunedin birth study, so the trans-diagnostic birth study, that is one of the most important slides of the whole presentation that gives the whole gist, in the sense that if you can take, it's not like one diagnosis, if you can take, say for example, if you can imagine a banyan tree, every illness is a banyan tree. So by the time the shoot comes out, the roots have already been extended. So what you see the shoots is only the symptomatology and various symptoms of various diagnoses, not just one, say, symptoms of one diagnosis. So the concept of diagnosis itself goes off when you're imagining a banyan tree, in the sense that if the banyan tree is 100 years old or 1000 years old, you don't know where the main stem is, you don't know where the main root is. Right. So by the time they are 15 years old, by the time the few symptoms have come out, many of the illnesses must have come out by that time, including, like Arun has pointed out, the multidimensional, the comorbidities of medical illnesses too. And I mean, when you look at the genetic profile of various illnesses, so many genes are common to so many illnesses. Right. So the symptoms which they present, sometimes I tell some people that, the teaching students, is that depressive symptoms itself can be a presentation of diabetes. Or the diabetes, when you look at the blood glucose levels, if they are higher, that can be a presentation itself of a depressive illness or other comorbid illnesses. So I think the wonderful slide, I'm sure in the future we will see more of that study and more of such studies. So yes, anyone else? I mean, this is just the comment which I wanted to make. If there are no other questions, I'll hand it over to Dr. IRS Reddy for the closing comments.
No, I think Nothing more. I think it was a very good presentation by Arun, and I think all are benefited by this. I think with this we'll hand over to the organizers. Thank you, Dr. Arun.
Thank you very much.
Thank you, Dr. Arun sir. It was a wonderful presentation. I would like to request Anand sir to kindly felicitate our chairpersons, Dr. IRS Reddy sir and Dr. Naresh sir. Thank you, sir. Now we are moving towards our next session of the day. It is on anxiety disorders, comorbidity or spectrum disorder. We have as a speaker Dr. Vishal Indla. I would like to invite to chair the session Dr. Sri Lakshmi P. Madam is a senior consultant psychiatrist at Roshni Counseling Center and professor of psychiatry at Government Medical College, Sangareddy. Also, I would like to invite Dr. Chaitanya Deepak, director and consultant psychiatrist, Asha Bipolar Clinic, Hyderabad. I request chairpersons to kindly introduce our speaker of the day and do the proceedings of the sessions.
So, good afternoon, everyone. From an interesting start to the day where the first speaker spoke about comorbidities and went on to child and then substance, we come to now a topic which questions the concept and says, is it a comorbidity or is it actually a spectrum? So is it actually the clinical divisions into disorders, is it artificial or is it actually a biological division? So who better than to speak about it than Dr. Vishal Indla? My co-chairperson will introduce him, but a few words from my side. It's a very rare combination of a brilliant academician and a wonderful speaker, and he has many feathers in his cap, and I've had the honor to speak along with him in many conferences. So we welcome Dr. Vishal onto the dais, please, too.
Dr. Vishal Indla is a consultant psychiatrist and director at Indla's Vimhans Hospital along with his father, Dr. IRS Reddy. He is conducting PG DNB in psychiatry for the last 15 years and also postdoctoral fellowship in child and adolescent psychiatry recognized by the Dr. NTR University of Health Sciences. I'm sure there are a lot of other things, but like to be brief.
Am I audible? Yes. Good afternoon, everyone. And I hope the screen, yes, the screen is now there. And how do I get to the? Fine. Okay, looks like there's a slight problem with the slide changes. So a small change in the way I wanted to speak. I wanted to come closer to the audience and speak. The whole idea is this is the graveyard shift of CME. You know what a graveyard shift is. A graveyard shift is from midnight to early hours in the morning when a software engineer or a call center employee works. For speakers, this is the graveyard shift. After the lunch, the first and then the second are really tough hours because most people, the food is just digesting and they're just slowly going into their naps, and I will try to keep you awake for some time. So Again, I think the slide mover is not working. Please say hello. Yes. What is the way to do it? Okay, fine. Yes, so, well, this is the hunter-gatherer, the early man. In those days, the only anxiety was about getting their food, fighting with the predators, killing them, getting the food for the day. Small anxieties, family issues, stuff like that. Of course, there were no family structures in those days in the first place. But today, with all your social media feeds, with the breaking newses, you are exposed to the bad news of 8 billion people. That's the population of our world as on today, and we are still counting. Anything happens, any corner of the world, especially bad things, you immediately get the feed, and all these things are processed subconsciously, and there is an ongoing anxiety pandemic, if I may say so. Of course, all newspapers are filled with all kinds of bad news. You don't get viewership for anything or readership for anything if there is good news published in it. Your amygdala and your brain is structured, and it has evolved in a way that only bad news keeps it alert, and things will be interesting only if there is bad news. Now, this is the way today's presentation will be structured. Firstly, on deconstructing anxiety, what anxiety is all about, then the concept of spectrum and categorical classification, then on some of the classificatory systems and what they have to say in terms of which direction we are taking. Is it a spectrum concept or a comorbidity style that we are going forward with? And then finally, anxiety as a comorbidity of other conditions, and then the bottom line as to which way are we going. Is it a comorbidity? Is it a spectrum? I'm sure from morning you've heard a lot of things from a lot of eminent speakers, but the theme of the CME is actually a little complex for postgraduate standards. But I think some of the speakers since morning, they have done a fantastic job simplifying such complex constructs into as simpler ones as possible. In fact, when the topic was first given to me by the organizers, Dr. Gauri Devi called and told about the topic, and you immediately do a preliminary search to find out what is the latest in this area. And for my surprise, you hardly have anything on anxiety disorders as spectrum concept. There is a lot on comorbidity of anxiety disorders, but there's hardly anything on the spectrum concept in anxiety disorders. So it was like a good challenge for me to make this preparation and present it in front of all of you. So what is normal versus abnormal anxiety? Again, in a spectrum concept, it always is a panoramic view, and you go from normal to abnormal. So some amount of anxiety is normal and is always associated with optimal levels of functioning, but it becomes a problem when it interferes with your functioning, and then it is considered abnormal. So for any kind of anxiety, disorder, you need these two components, either overlapping with each other or in some proportions. One would be the fear construct and one would be the worry construct. When it comes to the fear construct, you have symptoms of panic attacks and phobic symptoms, etc. Worry would be anxious misery, apprehensions, obsessions. So all those are the worries. So in some combination, these two, fear and worry, are the two components in various permutations and combinations form all the anxiety disorders that we talk about today. Again, neurobiology of anxiety disorders is a very complex thing, but if you have to put it in a nutshell, and if you have to remember just two areas for each of them, it is very simplified in that sense. Don't go by this, but if you have to deconstruct them like this, then fear, of course, you have the amygdala's hyper-responsiveness, which is the underpinning for all kinds of fears. And for worry, it is the CSTC circuit, that's the corticostriatal circuit, which plays the major role. Again, worries could be in terms of anxious miseries, it could be in terms of ruminations. So the brain does not distinguish between all of them again. So any kind of a worry would be processed through the CSTC loops. This is a more organized slide for neurobiology of anxiety. I wouldn't go into the details of neurobiology because that's another presentation, but for us to go forward with this understanding of whether it's a comorbidity or a spectrum concept, it's important to know at least the main players in this game. The main players would of course be the amygdala, as you could see, and top down, in some sense, the one which kind of directs the entire movie would be the medial prefrontal cortex. Medial prefrontal cortex has multiple roles that it plays, being the top down approach on fear extinction, which we will see a little later. Hippocampus is there on the left there. That's the storehouse of memories. It kind of gives you inputs to the amygdala saying this is a safe situation, this is an unsafe situation, this is the way the body has to respond, and then amygdala immediately responds. Then you have various other players, locus ceruleus for the noradrenergic output, the autonomic symptoms that you have. You have the parabrachial nucleus. The parabrachial nucleus, the reason I am pointing out, though it's a very small structure in neuroanatomical overall scenario, it has close links to what deep breathing does to amygdala and what deep breathing does to anxiety symptoms. Parabrachial nucleus immediately is related to the deep breathing and has effects on a calming effect on the anxiety as soon as somebody starts breathing deeply, and the parabrachial nucleus is one of the important centers which mediates this whole role. So all the players here are of utmost importance, they all have a role, but the most important ones, if you have to remember, are the hippocampus, amygdala, the medial prefrontal cortex, of course the parabrachial nucleus. Again, in some more detail on the neurobiology, fear conditioning and extinction usually is mediated by the amygdalocortical interactions. Now, fear extinction, let me take just a moment to explain to you what fear extinction is. Conditioning, you all know. Now, a person has gone through a bad situation, say he's going on the road and a dog suddenly barks and comes behind him, and he has that. So every time he sees a dog or he hears a bark, all these things come into his mind. That's the conditioning part. What about the extinction part? Extinction part is mediated mainly by the ventromedial prefrontal cortex, and it is the structure which you could program through your CBT, exposure response, etc., where an unsafe situation also is given a different meaning, and then the ventromedial prefrontal cortex keeps giving top-down orders to amygdala saying, calm down amygdala, this is okay. You've only seen one situation, but there are various other situations where the dog barks but nothing actually happens. That's the fear extinction model. The amygdala is known to play a central role in threat assessment and fear response, whereas specific cortical regions are known to modulate amygdala function in this regard. And as I said, the VMPFC suppresses the amygdala response as it mediates the recall of extinction information, especially in conditions like PTSD, specific phobias, and for that matter, most of the anxiety and fear related disorders, the interventions, especially the psychological interventions, take this into consideration. Hippocampus modulates amygdala responses by providing information regarding safe versus dangerous contexts. So there are two types of amygdalocentric models in anxiety disorders. One is the exaggerated amygdala response. The next one is the deficient top-down modulation of the amygdala due to insufficient function of VMPFC or the hippocampus. So if the VMPFC is not doing its job properly, and if it is not able to process fear extinction, then there is still hyper-responsiveness of the amygdala which is unabated, which leads to a lot of anxiety symptoms and anxiety conditions. Now, amygdala hyper-responsiveness is seen when exposed to disorder-specific cues, and you have all these conditions like post-traumatic stress disorder, specific phobias, social phobia, panic disorder, GAD, OCD, all of them have amygdala hyper-responsiveness. Many other conditions also can have amygdala's hyper-responsiveness. Even a patient with psychosis can sometimes have amygdala's hyper-responsiveness if he has paranoid ideas about somebody doing some harm to him. But these are some of the classical conditions where you talk of amygdala's hyper-responsiveness. Again, amongst all these conditions, are they all similar? Are they different? We will look at those things. What about OCD? Models of OCD have focused on CSTC circuits or the frontostriatal circuits, which mediate these ritualized behaviors, negative cognitions, error detection, and implicit learning. The main players there are OFC, the anterocingulate cortex, the striatum, especially the caudate nucleus, which is responsible for a lot of stereotypic motor behaviors, the compulsions. Baseline hyperactivity and hyperresponse within the lateral OFC, ACC, and caudate is not found in imaging studies of other anxiety disorders. Now, what I am trying to do is to slowly say, okay, all anxiety disorders, if you look at ICD-10, I don't know how many of you are even familiar with ICD-10, because by the time you came, I think it's all DSM-5 and then now ICD-11. But in ICD-10, neurotic, stress-related and somatoform disorders is a huge category, F40. That has everything, right from your anxiety disorders to your somatoform disorders to your obsessive compulsive disorders. That was a huge area which was all covered under F40s, the neurotic, stress-related and somatoform disorders. But after that, things have evolved, our understanding has evolved, and slowly certain things have been separated from this broad category. So OCD was with anxiety related disorders for a long period of time, and for good reason. A lot of similarities in symptomatology, etc. But now we know that the differences between the classical anxiety disorders and the OC related disorders are still quite clear, and that's what probably led to separation of the OC related disorders from anxiety disorders in the latest versions of our classificatory systems, both DSM and ICD. So from morning, I'm sure you've heard a lot of things about what comorbidity is, what are the different types of comorbidities, etc. But what about spectrum? Spectrum is a group of disorders which are qualitatively distinct in appearance, but believed to be stemming from a common pathogenetic point of view. This concept suggests for presence of not a unitary disorder, but rather a syndrome composed of subgroups. So like light gets deflected by a prism to form the rainbow colors. So something like that. It's more like a panoramic view. And let's try to give you some more details for you to get a good understanding of what a spectrum concept could be. In psychiatry now, various authors have already given the concept of spectrum for certain conditions. And the hypothetical, I've highlighted hypothetical because at this time it's all a little blurred. It's still hypothetical. But the hypothetical common pathogenetic link among spectrum of disorders at this time could be one of these things. It could be familial genetic. Schizophrenia spectrum, well, there is a familial genetic association. So they've kind of grouped those things together to say, okay, these could be probably schizophrenic spectrum of disorders. It could be schizoid personality disorder, schizotypy, those schizotypal disorder. So all those kind of things. There is another way to get to a spectrum concept. It could be response to a common class of pharmacological agent, depressive spectrum, for example. But again, you would have a lot of questions in mind saying, in that case, you would use antidepressants for various conditions. You could use antidepressants even for anxiety related disorders. You could use SSRIs or antidepressants sometimes even in schizophreniform disorders. But this is a hypothetical thing. Just for a simplified understanding of the concept, I thought I'll take some of the common ways in which spectrums have been defined or looked at in psychiatry. Common underlying psychopathological traits, dissociative spectrum. Psychopathology is taken as the basis there to understand that, okay, all these conditions have some similarities in their presentation, in their phenomenology. And again, familial genetic and phenomenology for bipolar spectrum. And then there is this obsessive compulsive spectrum, more than frequent comorbidities amongst themselves, a lot of common psychopathology, a lot of overlapping symptoms, and at the transcendence from, say, a compulsive line to an impulsive line. All these things have been purported as some evidence for an OC spectrum of disorders. So what is the bad and the good of a spectrum concept? First, let's look at the good part of the spectrum concept. In something like psychiatry, spectrum concept actually makes a lot of sense because we do not have a clear etiological basis at this time to say, okay, this condition is clearly caused because of this particular gene or because of this particular agent. So when things are so fluid, it's important to take a spectrum view of things and not the usual yes or no kind of answers. Now what happens in our DSM-5 and ICD-10, you have criteria and the criteria clearly say, okay, for example, let's take ADHD. ADHD says, okay, inattentiveness, you need all these things. Hyperactivity, you need all these things. So many of this, 4 of this, 5 of that put together would probably give you a diagnosis of ADHD. That's a categorical approach to diagnosis. What is the problem with the categorical approach? A person who has, say, DSM says 5 criteria, but this boy meets only 3 or 4 criteria, then he will not be diagnosed as ADHD according to the current classificatory system. So it's like yes or no. He falls there because he has that many number of criteria, or he does not get that diagnosis. That's the problem with a categorical kind of a classificatory system. DSM takes a very categorical approach about diagnosis. It's being more and more descriptive now, but still there is no option at this time for policy makers, because that gives us a lot of uniformity, and for that reason probably they take a very categorical approach towards diagnosis. But it makes the whole categorization very myopic, and it's very difficult for clinicians, especially psychiatrists, because we don't have any proper investigations to say, okay, this is the clear diagnosis. It's impossible many times, like speakers from morning have been, and chairpersons have been making this point time and again, that psychiatrists, unlike other clinicians, should have a lot of tolerance to ambiguity. And ambiguity is something that causes a lot of lack of clarity, always causes anxiety. But psychiatrists should tune themselves to be, they're prone to anxiety because it's impossible to have clear clarity on some of these things, because our science itself is still evolving, unlike some of the other medical specialties where you have clear cause and effect relationships. But then what is if spectrum is so good, why can't we have a spectrum concept and try to use that to classify the entire range of psychiatric conditions? If you don't have operationalization, if you don't have categories, for various reasons, legal purposes, for insurance related purposes, for even communication among medical professionals, it becomes very difficult to understand what the other person is saying. For me, my schizophrenia, if I diagnose schizophrenia a particular patient, that might be entirely different. For somebody else, it might be entirely different. So for those reasons, for that kind of clarity, for communication, operationalization and categorical classification is what we have been following. As much as our systems are actually evolving for the better, being more descriptive, giving more flexibility, but still, unlike any other branch of medicine, or to a large extent, psychiatric diagnoses are still much more categorical than panoramic or spectrum wise, or changing from normal to abnormal. Again, one more slide for better understanding. Categorical, there are usually mental disorders with threshold symptoms only included. So anything sub-threshold, no, they don't get a place. Spectrum, it's not like that. Spectrum is like your colors of the rainbow. You have abnormal experiences in general population, that's number one. Then you slowly have personality traits. Then you have sub-threshold symptoms. Then you have mental disorder threshold symptoms, meeting diagnostic criteria in DSM-5 or ICD. And then you have certain non-criterion symptoms. They are not actually criterion, there are no criteria for that, but you commonly see them in general population, but still they have not yet found their place into the diagnostic guidelines. So in that sense, if you look at any psychiatric diagnosis, especially anxiety disorders, you can see that when you have a spectrum concept, you can be more inclusive in terms of understanding your patient and targeting your interventions in a more holistic manner, rather than having strict categories and saying, so because he does not have the fixed number of symptoms, I am unable to make this particular diagnosis, so I will have to wait until that symptom comes up. Or sometimes you push the history so hard that symptom automatically comes up and then you make the diagnosis. Because in exams there is no other option. The examiner will still ask you what are the guidelines, this fellow does not have so many symptoms, how did you make the diagnosis? So you have no option. Until your exams are over, you should know your DSM-5 number of criteria and the patient has those kind of criteria, and then you fit the patient into the diagnosis. The only unfortunate part is patients don't read DSM-5. So that's a bit of a problem for us clinicians and for all postgraduates, especially until they complete their exams, but there is no other option. After that, of course, you can take a more holistic view of the diagnostic systems, and then that will help you be a much better clinician. So comorbidity, I will not go into this because Dr. Vikas has covered it in such great detail. Just a couple of important points, that for any comorbid, to call something as a comorbid condition, there should be etiological differences between the two conditions that are in question. And there should be very minimal or no overlap of symptoms. So remember these 2 points. If you have to strictly call it a comorbidity, there should be clear etiological differences. There should be minimal overlap in the content of symptoms. Now, when you look at the entire range of psychiatric disorders, it's still very difficult to call anything the comorbidity of anything if you apply these 2 criteria very strictly, because there is always some overlap of symptoms. there are always cross-cutting of dimensions, cross-cutting of categories. Like morning, one of the speakers was telling, say you have anhedonia. Anhedonia can be a symptom in so many conditions. Sleep disturbances, decreased sleep. Sleep disturbances can cut across so many diagnostic categories. Similarly, distractibility, right from mania to ADHD, irritability, right from anxiety to mixed affective state to manic episodes. So you have a lot of symptoms which cut across diagnostic categories, and in that sense, to have true comorbidities in psychiatry is actually, if you strictly go by the definition, it's actually very difficult. This is just for better understanding of the next few slides. This is the DSM-5 meta structure as of now. These are the various things. Some very interesting things there. We will now, you look at the anxiety disorders specifics. These are the DSM-5 anxiety disorders. Can somebody tell me which are the anxiety disorders which have been added to this list from DSM-4 to DSM-5? DSM-4 they were not there, DSM-5 they were pushed into this category, rather merged into this category. Pushed is a bad word, they actually deserve place here. Any thoughts? Any awake PGs can tell us? Which among these were not there in DSM-4 list of anxiety, but they have been bumped into DSM-5 list? Okay, we'll come to that. Okay, briefly on what GAD. So these are again symptom domains that you see in some of the classical anxiety disorders. Let's look at GAD. For example, GAD, you have generalized anxiety, fear, the central ones, worry, apprehension, anxious misery. Those are the clear classical symptoms of GAD. The other ones also, you have sleep issues, you have concentration issues, you have irritability, you could have muscle tension, fatigue, hyperarousal, but these things happen in so many other conditions as well. But the ones in the center are the classical symptoms of GAD. Again, for panic, the core symptoms are anticipatory anxiety, fear, worry about panic attacks recurring again, unexpected panic attacks, avoidance of those situations or stimuli which cause those panic attacks. Social anxiety disorder, social or performance anxiety, worry about exposure to those cues. Panic attacks, of course, expected in those situations. Avoidance again to those kind of situations. OCD and its related disorders are no longer a part of anxiety disorders in the latest classificatory systems, but still I thought I will put it because until recently they were close cousins, and in fact one of the latest slides will talk about how the decision was made to take away OC from anxiety disorders and separate it. So in OCD you mainly have clear obsessions, compulsions. Again, there are worries, and sometimes when they are exposed to some of these things, there could be panic symptoms also. But the main thing is obsessions, compulsions, stereotype behaviors, etc. So this is one thing that examiners generally ask for changes from DSM-4 to 5. This again relates to one of the earlier slides that I different disorders. That's the feeling you probably would get if you are only looking at DSM-5. But for people like us who have seen ICD-10, then DSM-3, 4, 4TR and now 5, it takes some time to adjust to this. And I'll tell you how narrowly this just got into the other side. Otherwise it would have probably still stayed on the same side with anxiety and related disorders. Trauma and stress related disorders are grouped separately. They were also to PTSD, for example, was also a part of anxiety related disorders previously. The reason because they separated it is because there needs to be a clear traumatic exposure, a traumatic event necessary for diagnosis. Separation anxiety and selective mutism. The question I asked, that's the answer. Those are the two conditions. Unlike the previous placement in the first chapter, from neurodevelopmental disorders, they have been just taken and directly shifted to the anxiety and related disorders, fear related disorders. This is a big transition, but I think in the right direction, because at the end of the day, it's about focus of apprehension, it's about worry, it's about fear, and all the conditions which have that as the basis have been moved into anxiety and fear related disorders. Some other useful and important changes from 4 to 5, again for us to understand this concept, whether these are comorbidities or spectrum. DSM-5 has added a separate dimension of specifiers across entities. So you could have panic attacks as a specifier for any condition, right from schizophrenia to mixed affective state, you name it, you could have panic attacks as a specifier. A 6-month duration is now extended to all ages for most of the anxiety disorders, including specific phobia and social anxiety disorder. So the duration has been made more concrete. Panic and agoraphobia are now delinked or unlinked, each with separate criteria. There is nothing like agoraphobia with panic, only that kind of a diagnosis should be made. Both of them are kind of independent diagnosis now. The diagnostic criteria for separation anxiety no longer specifies that the onset must be before 18 years of age. Again, recognizing that separation anxiety can happen after separation from due to death of a loved one, due to failure in a relationship. A lot of other conditions can also cause symptoms very similar to separation anxiety, and it need not be looked at only in children. I feel ICD-11 has gone one step ahead of DSM-5 in terms of giving more clarity about which way anxiety disorders is moving. It's actually called anxiety and fear related disorders, so very clearly saying that all fear related conditions also would come here. The proposal for ICD-11 is that anxiety or fear as the primary clinical feature to be brought together in a new and distinct grouping titled anxiety and fear related disorders. And the main thing here is that these disorders occur across lifespan and are peculiar due to their focus of apprehension. This is a word that ICD-11 has used multiple times, and most articles after that which look at nosology of anxiety and fear related disorders use this word very, very prominently, focus of apprehension. We'll look at it a little more closely. The focus of apprehension is the apprehension for a stimulus or a situation that triggers fear or anxiety. And it could be very specific as in specific phobia, or it could be a situation or a broader class of situations as in social anxiety disorder. So that focus of apprehension, there is some focus of apprehension to a particular stimulus, to a particular situation, and that forms the basis of all anxiety and fear related disorders. Salient features of ICD-11 anxiety fear conditions: it eliminates ICD-10 decision to afford diagnostic primacy. So when we were postgraduates, one of the things is to clearly say, is it MDD or is it GAD? If there are symptoms of both, then you will make a big blunder by saying that it is a major depressive disorder with generalized anxiety. That would be like a blunder once upon a time. ICD-11 and even for that matter DSM now gives more flexibility in terms of taking away this hierarchical approach that okay, if you have one top diagnosis, you can't have anything else. And it actually gives more clear guidelines to clinicians saying that if the anxiety symptoms reach the level of a threshold for GAD, and they exist even at times when they are not having clear-cut guidelines for MDD, you go ahead and make both the diagnosis. And it takes away the diagnostic primacy of MDD, and also in one way actually states that GAD is a more chronic condition. So that kind of a hierarchical thing has been done away with in most of the latest classificatory systems. Additional diagnosis of, as I said, if it is even outside of depressive episodes, and ICD-11 allows for co-occurrence of GAD with other anxiety and fear related disorders as well as OCD. So you will not be wrong if you follow ICD and say somebody has OCD plus GAD. Of course, you need to make a clear case for both the conditions to be present for substantial period of time, and not that one is because of the other. Sometimes there are situations from clinical history where you could have anxiety because of the person's obsessions itself, or because his compulsions are not met with. So one, as long as one takes care of that issue, there is no problem with making multiple diagnoses according to ICD-11. Again, probably strengthening a spectrum concept than a categorical approach. RDoC, NIMH's INSAIL and group have come out with this. By now you would know a lot of RDoC. I think every speaker mentioned this from morning. Research domain criteria mainly looks at 5 dimensions, and the main difference from DSM, ICD to RDoC is RDoC attempts to classify and give a framework of mental disorders based on neurobiological underpinnings translating into behavioral manifestations, translating into symptoms. So that kind of an approach is taken by RDoC, unlike some of the other initial DSM and ICD which only talk about the symptoms. Okay, you have this plus this, it is this. RDoC says no, that's not a good approach. Let's look at what kind, okay, he has this kind of symptoms. So what are the neurobiological underpinnings that could manifest these kind of symptoms? So it's a good concept, but it's like hi-fi theory at this time because we don't have answers to a lot of these questions. We really don't know what kind of neurobiological underpinnings clearly give to what kind of symptoms. We only broadly know that this kind of neurobiological underpinnings lead to this kind of symptoms, but it's impossible at this time for us to say, okay, this causes this area causes. It's impossible to come to that kind of conclusion at this time, but it's a thinking in the right direction. But I think we are much far at this time in terms of the understanding that we have of our complex brains. Briefly on comorbidities in anxiety disorders. So anxiety can be a comorbidity with other anxiety disorders, with mood disorders, OCD and physical illnesses. I just wanted to highlight that as per the current diagnostic guidelines, even if you take DSM or ICD, the comorbidity between any two conditions is extremely high. You take anxiety comorbidity, then it's usually associated with more chronicity and treatment resistance, earlier age of onset, and also avoidance is of course common to all of them, so it makes it even worse if they have more than one condition. Comorbidity in anxiety disorders is a rule rather than an exception. In fact, in many of the studies now, when they do the exclusion criteria, what they generally say is, okay, if you have this condition, they want to study say panic disorder. So they would exclude other conditions by doing a structured clinical interview and saying, okay, we want to take only panic disorder and study those patients. So they exclude other conditions. But now the reviewers are very particular that if you want to exclude, say you know that panic disorder, you want to study panic disorder, but you know that panic disorder is quite commonly comorbid with MDD, depression. If you want to exclude depression patients, you have to clearly give a rationale why you want to exclude that. Otherwise it doesn't make sense. Every day in clinical population, these are the kind of patients that you see, and if you want to exclude these and just have panic, it's not easy to get that kind of sample. It's not representative of what we do in clinical practice. So now many reputed journals are actually saying, please don't exclude. If you want to exclude, give us very, very clear rationale on how you want, why you want to exclude, and how you managed actually to do something like that. Anxiety and mood disorders comorbidity, again many studies, just wanted to highlight one or two here. STEP-BD, which is large scale study of outpatients with bipolar, says that anxiety was the most commonly observed comorbidity in bipolar disorder, outpatient bipolar disorders. This high rate of comorbidity may reflect the direct or indirect influence of the primary psychiatric condition on the development of the subsequent disorder, and the existence of a common cause between both disorders through genetic predisposition and socioeconomic factors. So the multiple ways in which this interplay can happen, leading to one condition from the other. Some investigators in fact think that the two disorders occur along a single continuum with different patients manifesting different symptoms along a spectrum of disorders. But there are others who differ with this opinion. Again, some number crunching, bipolar disorder, anxiety prevalence is extremely high. So some people say if you want to consider a spectrum approach, then somewhere bipolar also probably falls somewhere in the spectrum. And in fact, one author, a group of others have proposed that I'll show it a little later. Overall prevalence of anxiety in bipolar is extremely high. All kind of anxiety disorders are very high. In fact, that's one of our challenges in clinical practice. When a bipolar patient has anxiety, choosing the right pharmacotherapy, getting the right balance, very, very difficult, nightmarish. 60% of all individuals with one anxiety disorder have at least one other anxiety or depression diagnosis, and 27%, that is 1 in 3, have 3 or more of these disorders comorbid. Suffices to say that comorbidity of anxiety with a lot of other psychiatric conditions is extremely prominent, especially more prominent with other anxiety, followed by depressive conditions, other mood disorders, bipolar disorders, and then of course schizophrenia also. You see a lot of patients with schizophrenia also having panic related symptoms and anxiety related symptoms. So is there a case for anxiety depression spectrum? The relationship between depression and anxiety disorders has long been a matter of controversy. I just highlighted the diagnostic primacy and hierarchical approach the previous systems were taking. Recent evidence suggests that genetic and neurobiological similarities between these two conditions are quite highly prevalent, and they have high factor loadings on the internalizing dimension. But is that enough to call that they both belong to the same dimension or the same spectrum? Other question, anxiety and OCD. What exactly went wrong? Why did they separate both these conditions? And as I said, in ICD-10, they were all put under one big classification, the F40 to 40, the F40 system. In ICD-10, OCD was classified separately, but now why did they separate? Well, in anxiety, the focus of apprehension, as we just discussed, fear, anxiety, somatic symptoms, these are the main things that distinguish and give that clear flavor to anxiety disorders. What about OCD? You all know that OCD, the focused repertoire of obsessions, intrusive nature, ego-dystonic nature, these are the ones that differentiate obsessions from the ruminations of generalized anxiety disorder. You don't have this ego-dystonic nature, the intrusiveness, the obsessive nature, the quality of obsessive nature, all those things are missing in some of the anxiety disorders. So phenomenologically, there is something to say, okay, these two things are not the same. There is something different and distinct between these two conditions. Is that it? Are there more differences? Clinical experience suggests that anxiety symptoms are somewhat variable and heterogeneous. Anxiety symptoms can vary and predominate at different stages in OCD. Obsessions are usually accompanied by anxiety, even to the extent of panic. And the most common anxiety disorder in patients with OCD is actually social anxiety. Now, this is something interesting and really something I found very interesting. In hindsight, now when we look at DSM-4, we would think DSM-5 is correct, ICD-11 is correct. They did the right thing by separating these two things. But if you look at the poll that was done just before DSM came out, it was very surprising for me that they did a survey of all the major authors who work in this area. They've taken all the OCD publications, then they posed this question of whether OCD should be together or should be separated from this. Approximately 60% of the 187 respondents, who were all researchers, big researchers in this area, 60% of them supported moving OCD out and 40% disagreed. So it's just a 3:2 kind of a thing. 3 people voted that side, 2 people voted this side. Now we see OCD on the other side. It's no longer with anxiety. We don't know the background story. So when we look at in print DSM-5, OC and related disorders totally separated from anxiety and the kind of explanations that they give, we feel satisfied that this seems to be the right thing to do. But it was ultimately a political thing, as in there was a voting that was done amongst all the researchers, and the researchers, based on their own understanding of this condition, just tilted the balance in favor of separating these two conditions. So that's the reason I'm saying it's not so clear cut as we think it is. But nevertheless, having said that, I think there is still a case for at least separating OC related disorders from anxiety conditions. Anxiety is integral across a range of disorders and OCD is no exception. But a few qualities which make OCD stand out, as we just discussed, these themes, you don't have sexual contamination, harmful, religious, these kind of themes usually don't exist in core anxiety disorders. Motor compulsions, etc. are not there. And also you would realize that a lot of patients with OCD early onset, they usually remit over time, whereas anxiety is more like a chronic condition. Some people even push for this thing of saying that anxiety is a trait. So trait is like a liability, it's like a latent thing which is there and it is always there. It's not like it comes in between and goes off, unlike OC related symptoms. So some people, some authors actually argue for this kind of a distinction between anxiety and OCD. Again, all these things have pushed and tilted in favor of OCD being separated from anxiety related disorders. Anxiety and physical conditions, I wouldn't go into details, but just for you to know that a lot of physical illnesses and anxiety co-occur. Medical disorders, as you know, come with a baggage of fear of diagnosis, hospitalization, painful procedures, which become the precipitating factor sometimes for anxiety. A few medical disorders are physiologically linked to the development of anxiety and related disorders. For example, IBS. There are common etiological underpinnings for both of them. On the other hand, anxiety can make a person vulnerable to various medical conditions. Genetic factors may predispose to both general medical conditions and anxiety disorders. So this is just for, as postgraduates, it's important to know some of the medical conditions which are commonly associated with anxiety, right from endocrine disorders like pheochromocytoma to peptic ulcers to fibromyalgia, migraines, Parkinson's, you name it, asthma. A lot of them are associated with anxiety related symptoms. And in IBS, of course, it's been suggested that infection or inflammation of the GI tract leads to anxiety. So there is now a theory that you could actually use some of the anti-inflammatory agents to good effect and actually help with some of the IBS symptoms. That's why the gut brain microbe system and some of the drugs that can target this system are being studied for some of these conditions. In asthma, again, it's been postulated that increased partial pressure of carbon dioxide is responsible for panic attacks. So these are actually shared physiological reasons for some of the comorbid conditions. So one group of authors suggested that all emotional disorders can be subsumed like a spectrum, and then you could look at bipolar disorders as one of them. You have bipolar 1, 2, cyclothymia in that. Then you have the distress disorders and the fear disorders. So though these authors have kind of given a very broad picture here, subsequently some of the authors have taken up the bipolar disorders and actually said that, okay, there seems to be a reason to believe from various lines of evidence, neurobiological evidence, genetic evidence and all those things, that distress and fear disorders are still a continuum. So there are a group of conditions where distress is the main focus of the patient's apprehension. That would be your say major depression, dysthymia, GAD, post-traumatic stress disorder. And some people said fear disorders. Fear disorders are those like specific phobia, panic disorder, agoraphobia. Those are your fear disorders. So again, some people said, okay, among the distress disorders, it doesn't make sense to have depressive conditions for certain other reasons. But broadly now, distress and fear on a continuum, saying some anxiety disorders fall on one end of the distress spectrum and some anxiety disorders fall on the other end of the fear spectrum, and there is a lot of overlap from this end to the other end. To make it more confusing, there is another group which says that why can't we have a social anxiety spectrum only, because they say that social anxiety spectrum is a more pure cohort, and it is defined by the core features of excessive fear of embarrassment, which is often accompanied by avoidance of social or public situations. Some others feel this perfectly fits for a spectrum concept. If in anxiety disorders, again, the next version of classificatory system comes, the push of some of the others is to say that you keep the anxiety disorders, but like you removed OCD this time, next time you can just push social anxiety spectrum and keep it as a separate entity. Things like social anxiety, avoidant personality disorder, probably dependent personality disorder, all those things can be merged into that group of conditions. The reason some others argue for this spectrum is again the trait-like qualities of early onset, chronicity, no empirically derived threshold that demarcates normal from clinically significant trait social anxiety. So this is one direction that the classificatory systems might take in the future. I think that these are the last slides. So where do we stand currently? Anxiety disorder, spectrum or comorbidity? Well, after this actually is a great topic for a debate. It would have been really nice to have two sides of the coin. I try to present both sides and try to come to some conclusion with the available evidence as on today. So all subtypes show similarities, all anxiety subtypes show similarities in presenting features, treatment strategies, but they still have characteristic and distinct features which demarcate them from each other. The unique features and separation of various entities like OCD, trauma-related disorders make it stand out like an independent entity. So previously all of them were together. Now they have kind of slowly distinctly demarcated some of the entities, saying, okay, OCD, no, not so much like anxiety, let's take it off. Trauma-related disorders, PTSD and company, again not so much like anxiety. Yes, there is overlap, but this has a different flavor that has certain other things, especially exposure to a traumatic event. So take it off and put them separately. So now anxiety disorders is a reasonably homogeneous group, but amongst that group, of course, as I mentioned to you, some people argue for a separate social anxiety spectrum group. Fear and distress dimensions is the direction that things might take in going forward. And high comorbidity with mood disorders is something that one needs to keep in mind. So finally, what is it? Is it spectrum or a comorbidity? Well, the bottom line, this is based on all the lines of evidence available as of now, there are enough things in common to be separated from the rest of the conditions like OCD, neurobiological areas, comorbidities, and treatment strategies, especially in terms of non-pharmacological modes. Pharmacologically, you use the same modes for most of these conditions, non-pharmacological modes of treatment. All these things give us some clues that anxiety as a homogeneous group, as something very specific to it, and as ICD-11 came out and said it's a focus of apprehension. That seems to be the key phenomenological or symptomatically, that seems to be the major manifestation. DSM-5 and ICD-11 have taken this stance of separating these two conditions now, especially taking off OCD and taking off trauma-related disorders gives a lot of clarity that this is a homogeneous condition. And if you notice closely, we all think now OC-related disorders are a spectrum. Yes or no? So many people have been talking about it. Now we know, okay, OC means spectrum. That's why they have separated. Actually, the reason is otherwise. The reason is that they are not so close to anxiety. There are some similarities, but net, they are two different things. That's why they've separated. The reason I'm saying this is, if you look at DSM-5 or ICD-11 for that matter, nowhere did they use the word spectrum for OC. Nowhere. They would just say OC and related disorders. The reason they're not using spectrum is because they want to play safe. These are again classificatory systems for various socio-political operational reasons. So they don't want to unnecessarily make any false or statements which can cause controversy. So though in day-to-day terminology in our scientific meets, in articles, when even major articles come in some of the peer-reviewed journals, they all talk about OC spectrum, but the main classificatory systems still don't use the word spectrum, probably to play safe. So if OC and related disorders are a spectrum as per what knowledge we have, for the same reasons we have enough evidence on the anxiety group of conditions also to say that they are a spectrum by itself. Of course, the main classificatory systems may not come out with this kind of a terminology because, as I said, even for OC they don't still call OC spectrum disorders in the main classificatory systems. So net at this time they look a very homogeneous group. Probably if you take the fear and the distress kind of module dimensions and try to group them, you would find maybe over the next few years, with more biological markers being available, more clearly defined neuroimaging abnormalities available, there may be a case to demarcate these conditions into a spectrum like concept. So with this I conclude by saying that you can only make certain things as simple as possible, but not simpler. It's a little complex topic, so I hope I haven't confused you enough, and I'm sure all the speakers as we meet on the sidelines, they've like, well, these topics are a little complex. Well, I hope we made it a little simpler for all the postgraduates to understand, and I hope I haven't confused all the listeners here, and I thank the organizers, Dr. Gauri Devi and the Telangana Psychiatric Society, the IPS South Zone, for giving me this wonderful opportunity, and I wish all the postgraduates success in their future. I'd like to thank Dr. Y.C. Janardhan Reddy. After reading all lines of evidence, he is my guru at NIMHANS. That's where I did my postgrad from. I called him and I told him, sir, these are the things that I'm thinking. I wanted to discuss with you, and I wanted to know if I'm on the right direction when it comes. Then he said, yeah, let me also think. And he's an authority on these areas in our country, and he's helped me in making this presentation to you. I thank my postgraduate, Dr. Harshini, who helped me in preparation of the slides. Thank you once again.
Thank you, Dr. Vishal, for such a lovely and succinct presentation. I'm sure lots of confusions lead to a lot of questions, and therefore you'll all read further. So he stimulated you enough to want to go explore further. If any questions from the postgraduates you'd like to take up now, please. You could still clarify your confusions here also. He's there, please take full advantage and ask your doubts. The faculty?
Thank you, Vishal. From confusion back to confusion, of course. That's what happens in psychiatry when we start talking about the theoretical aspects. If you look from phenomenologically, of course, yes, you can dissect as well as again you can suture the same things together. And then that means you have both the deduction as well as again induction, one followed by other, or in circles, going on in circles. Of course, the recent paper on anxiety disorder does not, that's a systematic review and meta-analysis, doesn't show any biosignature for any of the subtypes of anxiety group itself. That means, of course, biosignature to what extent that is valid or not is a different issue, but whatever the evidence is there till now does not show any particular biosignature for any of the subtypes. While the focus is mostly on the phenomenology, I think from neurobiological point of view, but overlaps are there, but distinct features are also there with the GAD and OCD. Apart from that, the management aspects, totally distinct type of management, especially the types of behavior therapy which you use for GAD and OCD, of course, very specific types of therapies are there for OCD. So the other aspects, what do you feel that it should have been separated or not based upon the other aspects also, for the practical point of view?
Sir, you mean from OC related disorders?
Yeah, this separation of GAD from OCD, from practical point of view, it is definitely looks like it is helpful because the focus of therapies are definitely different when we compare, not only GAD, the anxiety disorders itself, like panic disorder, agoraphobia, you do some.
I fully agree, sir. I think there is enough reason to separate. I'm not audible. Yes. Yeah. So I think it is. I fully agree with what you're saying. I think there is enough reason now to separate anxiety and fear related disorders from OC related disorders. Not only because of phenomenological reasons, but also if you look at the neurobiological aspects of these two conditions, there are some similarities, but there are clear-cut differences. In psychiatry, where it is very difficult to pinpoint differences, I think there is enough case neurobiologically also to separate anxiety-related disorders, where it is more of amygdala hyperresponsiveness versus OC-related disorders, where it is more the CSTC loop that is the pathological issue. I think for these reasons, there is enough to separate both these conditions. Also, as you said, in terms of management, leave the pharmacological aspect because for all pharmacological options are there, antidepressants itself. But when you look at non-pharmacological options, the kind of things that we do in OCD are more about exposure response prevention and things like that. Whereas in anxiety, it is more to deal with cognitive restructuring, more cognitive part, but in OCD, it's more also the behavioral part, the response prevention and things like that that work. So, and phenomenologically you already mentioned. So I think there is enough reason to separate these two things. But what confuses me and what makes it a little paradoxical is that survey that they did among all the researchers, it was a split hair kind of a voting that actually bumped OC and related disorders into a separate entity. Now looking in print, it looks, why was it such a confusion? But I think at that time when still things were what they were, it's very difficult to make that kind of a decision. I think there is always inertia to go with what has been going on for a long time and to make big changes, taking away OCD and separating it, probably that was the reason.
Yeah, the DSM itself says that the diagnosis, this category should be based upon the point of rarity, meaning that there should be some distinct biological underpinnings for these categories have got to be found out, and that's what probably is one thing which is driving this distinction between the anxiety disorders and OCD.
Any online questions do we have? Madam.
No, extension of what Dr. Anand has been saying. I just want to ask you, under anxiety disorders, okay, there is clear-cut distinction you pointed out about OCD and other anxiety disorders. How about anxiety disorders themselves? So if you look at anxiety disorder, separation anxiety disorder, social anxiety disorder, all these disorders, when you look at the underpinnings are almost same. Neurobiologically, you can't really separate them. The only thing is, what we study sometime back, anxiety is the basis. If it's fixed onto something, it becomes a phobia. The situation, it becomes situational anxiety. We used to, learnt it. I felt descriptively when you talk about, that seemed to be more meaningful. That was the reason I gave this topic to you. Categorical, yes. You have separate entity to make diagnosis so that I can convey to you that it's phobic disorder and things like that. But when you are treating a patient, especially when you look at the temperament and as you are talking about transdiagnostic classificatory thing, it doesn't make any difference whether you make a diagnosis of generalized anxiety disorder or phobic anxiety disorder, nothing. I gave this topic to you. Basically, I wanted you to, discuss about these three things also. Yes, OCD, I agree. And another point you said, like apprehension and distress, or fear and distress. When a person who has got fear, he is also distressed. I always feel, especially the anxiety, it's a play of words. It's more of a political, I don't know, it's too drastic a comment I make. But when you look at it, we forgot about psychoanalysis. We also studied about, I'm not bringing out that again, but understanding was little more when we are studying about anxiety disorder rather than now. We think we have more clarity, but when it comes to, yes, diagnosis, yes, but when it comes to treatment, especially anxiety disorder minus OCD, I think you do the same thing for almost all the anxiety disorders, and I don't find any rational separation anxiety disorder. This is my comment.
I think we have a better understanding after this talk about like why ICD-11 or DSM-5 have like gone ahead and separated OCD from the anxiety, and like what is going to happen in the future, probably as some kind of a direction. Some clarity has been achieved in that direction. And thank you for such a lucid presentation.
Thank you, Dr. Vishal, for such a nice presentation. I now request Dr. Sri Lakshmi Madam to kindly felicitate our speaker, Dr. Vishal Indla sir. I would like to request Dr. Vishal Indla sir to felicitate our chairpersons, Dr. Sri Lakshmi Madam. And Dr. Chaitanya Deepak sir. Thank you so much, sir, madam. Next, we are going to have quiz in few minutes in the same hall. We'll be starting in next 10 minutes. Tea and refreshments are served outside. Few announcements. Dinner will be served at the same venue, the Plaza Hotel, 8 p.m. onwards. Then Those PG postgraduate students, those who have traveled from outside the city, they can meet at the registration desk to Sun Pharma representative for reimbursement of their ticket fare. Okay. Yeah, you have to submit the tickets today, and tomorrow you can get your reimbursement. Okay.
This one will connect to this.
కడిగారు మనది ల్యాప్టాప్ ఇది
ఇది మందే
దిస్ ఇస్ యువర్ సార్
ఇది మంది సార్ ఇది
HDMI పోర్ట్ కావాలంట సార్ HDMI కేబుల్ కావాలంట సైడ్ కింది పడట్లేదు పైకి ఒక్క నిమిషం పొడే వాది రామరాజ్
Is the Anantapur Medical College team here? Anantapur Medical College?
Also, teams who have participated in the prelims in the morning, can you please come forward? We'll be announcing the results in a short while. So whoever is here, please come forward. Mini connected. Mini port.
Show mirroring actions menu bar when you have a tick mark lo unda తీసేయాలా ఉంటది
Because my team is in hotel. In hotel, so he has to come. We'll just be announcing in 5 minutes. I also have to see the papers. That. Yeah, we'll give no problem. Okay. Teammate is somewhere else. He's like, can you tell me if I qualified or not? I said, I also have to say, I don't know if you have. సరే అప్పటివరకు అయితే వేరే దాంట్లో చూద్దాం ఎట్లా వస్తుందో ఇది ఇప్పటివరకు అది మీరు ఇదైతే ఫిగర్ అవుట్ చేయండి అప్పటివరకు వేరే కంప్యూటర్లో పెట్టేస్తాం ట్రై చేద్దామా అది పక్కన తీసేస్తారా లేకపోతే కొంచెం ఇది అది ట్రై చేస్తుండండి అందులో వస్తే బెస్ట్ యాక్చువల్లీ ఒకసారి So all the quiz teams here who have participated in the morning, can you please come forward? We'll announce the results in just 5 minutes. Can you please come forward? Anybody who's taken part in the quiz, please come forward.
Final call for Anantapur Medical College team.
They're here. Just to show. Okay. Yeah, chapter. Yeah, I'm actually running very late. Chudali. I will give less time only. Roshni. వాళ్ళదేనా? So just count once again.
KS Hegde Medical College Academy, Dr. Rashmi K. She here.
Yeah. Do you have a teammate? You do not have a teammate? Okay, then we should go.
Dr. Srinivas and Dr. Ahuya from Pratima Institute of Medical Sciences, are they here? Oh, Srinivas and yeah, okay.
టీమ్స్ ఒకళ్ళిద్దరు రాలేదు సార్, వాళ్ళు ఎక్కడో
ఒక team
తిరుగుతున్నాయి సార్. అయిపోయింది. I'll just give out the answers to you. Okay, so before announcing the teams, I'll just give out the answers quickly for the prelims. So some answers may have cross references here and there, but we have taken standard references, so our judgment is final. There's no discussions on that. Okay. So yeah, the first question was which historical figure is credited with pioneering diagnosis in psychiatry, authoring the first ever international textbook and adopting a human approach with patients. That answer is Philip Pinel. Okay, some of you got it right. Then Nathan Ackerman is considered the pioneer of which form of psychotherapy? That is family therapy. Only one team got this, I think. So that was good, whichever who I've got. So name a new trauma and stressor related disorder introduced in DSM-5 TR. This is prolonged grief disorder. Okay, this is the only disorder which is actually introduced. An entire category is introduced in DSM-5 TR. It is only one new disorder. Okay. And yeah, time frame for symptoms in gaming disorder as per ICD-11 is 12 months or 1 year. Then type of illusions in which vivid illusions occur without the patient making any effort, result of excessive fantasy thinking, that is pareidolia illusions. Opposition of passive movements by a catatonic patient with the same degree of force as used by the examiner, the term is Gegenhalten. Okay. And prevalence of common mental disorders in India as per National Mental Health Survey is 10%. Clear answer given in the survey findings. Common mental disorders is 12%. Any morbidity is around 12 to 13%. Common mental disorder is 10%. Okay, it's clearly mentioned in the survey. And as per Maudsley guidelines, retitration of clozapine is recommended from 12.5. It is missed for how long? Answer is 48 hours. Okay, again, clear guideline in API guidelines, Maudsley guidelines, everywhere it's a uniform guideline, 48 hours. Daily dose in the range of 1200 to 1800 of lithium is expected to produce a serum concentration of 0.8 to 1.2. Okay, that is the therapeutic range basically in mania. In relation to olanzapine depot injection, what does PDSS stand for? I don't think any team got this. This is post-injection delirium sedation syndrome. Okay. And deep TMS, deep transcranial magnetic stimulation, it's not currently FDA cleared for which of the following indications? Options are major depression, OCD, smoking cessation, and persistent auditory hallucinations. Answer is auditory hallucinations, cleared for the rest of the three. All the following are therapeutic factors involved in group therapy. Identification is a factor, universalization is a factor, ventilation is a factor, overgeneralization or cognitive distortion. That's not a factor in group therapy. And first line approach to OCD in children is CBT. Okay. And theory of multiple intelligences is by Howard Gardner. As per NDPS Act, quantity of buprenorphine that counts as a commercial quantity is 20 grams. Finger agnosia, acalculia, agraphia, right-left confusion, cardinal features of Gerstmann or parietal lobe we are giving. Gerstmann, we are looking for Gerstmann syndrome, basically. That is the answer we are looking for. And complete the blank in following list for Papez circuit, hippocampus. The blank we are looking for was mammillary body. Okay, anterior cingulate and anterior nucleus of thalamus and cingulate. Benzodiazepines act via GABA A receptor. Just GABA will not fetch you any points. Okay, GABA A is the answer. Mechanism of action of sildenafil is PDE5 inhibitor. That is what we are looking for. Most teams have answered that. And not in the list A of telepsychiatry operational guidelines is sertraline. Imipramine, fluoxetine and escitalopram are all in the list A. They can be prescribed on a first visit. Sertraline is not in that particular list. Okay. So now we'll be announcing the teams to have qualified. This is in no particular order of qualification. Dr. Atif Chandna and Harkishan Mamtani from Nimans, Bangalore. Dr. Hamza Hussain and Dr. Uma Maheshwari from IMH. Dr. Anudeep and Dr. Navya from Apollo Institute of Medical Sciences. Are you here? Dr. Sai Sudhir and team from NRI. Dr. Maunika and Dr. Neha, I hope I got your names right, from Anantapur Government Medical College. Dr. Srinivas and Dr. Anuhya from Pratima Institute of Medical Sciences. Now, please draw lots to just check your stage position. It will not affect the flow of the quiz. Don't worry about that. Whoever you sat with, if you're from the same college, it's fine. Okay, we'll allow it. No problem. Same college? You can take, no problem. Same college? Same college in Kerala. Yeah, you can pick lots for your stage position. NRI Mangalgiri, Vallepenne, Mangalgiri. Yeah, same college, right? We are not from the same college? Sorry, then we can't allow that. No. Previously, we are not allowing that. We will have to go for the next team. We are sorry about that. So the last team to qualify will be from ESIC Medical College. Is the team here? ESIC Medical College? Yes, please. Dr. Santosh Mita and Dr. Navya. Yeah. చేయండి స్టార్ట్ చేయొచ్చు డిస్ప్లే. Yeah, ఇప్పుడు నేను చెప్తాను each round ki I'll just brief them and you can also listen at the same time. So welcome everyone. So we are in a hurry. I would have asked for introductions otherwise, but we are short on time. So we'll jump straight to the round one of the quiz. Okay, so round one is a bit from everywhere in psychiatry. So there are specific scoring rules which I'll explain to you. So now we are introducing in PG quiz the concept of pounds. Okay, so that your stage position does not affect which question you answer. So it means that for any question, irrespective of, so we'll start the first round from the first team and go clockwise and anti-clockwise in successive rounds, okay, till the end of the quiz. And wherever we start, whichever team gets the direct question, every other team can raise their hand and say pounds. And you have to answer while in writing, or you can just tell us slowly. You cannot announce out the answer, okay? So if you pounce and get it right, it does not matter which team's direct question it is. If you pounce and get it right, you get plus 20. If you pounce and get it wrong, you get minus 20. Okay. So this is scoring with pounds. So if you don't want to pounce on a question, that's fine. That's not mandatory. So the direct team gets the opportunity to answer the question first. Whichever team's direct question it is, that team gets a shot at the question. So if you answer, that is 10 plus 10, and there are no negatives for answering a direct or a past question. In the first round, there is no passing. In subsequent rounds, they may be passing. Okay. So are we clear about the rules? Any person, any team can pounce on any question with risk of plus 20 and minus 20. Okay. If you have any questions at this point, you can tell me. Otherwise, we can just go straight to the first question. Any questions? Okay. First round is mostly MCQs, MCQ based. Okay. So let's go to the first question. And the team with direct question can also pounce, by the way. So if I'm starting with team 1, this is 1 to 6, right? The 1 to 6. Okay. So if I'm starting with team 1, if it is your direct, you can still pounce and get double points. Okay. If you're confident about the answer. Clear? You just raise your hand and say pounce. If you raise your hand, I'll understand that as a pounce and I'll come to you. Yeah. No, it's 20. So that will count only for the pounds, no 30. Okay. So then you don't give out the answer. Okay. So in case a direct team pounces, 15 seconds. For pouncing it, the time limit is 15 seconds. After that, the pounce closes and the regular, for the direct team will get a chance to answer the question. Okay. And if a direct team answers by pounce, in this round, because there is no passing, the question ends with the pounce itself. It doesn't pass to anybody else, right? Okay, so let's start. Let's go to question 1. Okay. Yeah. And anybody pouncing? Team 1 is pouncing. Team 1 gets plus 20. Anybody else? Yeah, last pounce. Team 6 gets plus 20. Okay, so the pounce is closed, and since team 1 it's a direct question, they can give out the answer. They've already gotten the question. Please answer. Bipolar 3. Yeah, that's the correct answer. So hypomania due to antidepressant drugs is in bipolar 3. So both team 1 and team 6 have gotten plus 20. Okay, next question to team 2. Anyone pouncing? Team 1 is pouncing again. Team 1 gets plus 20. Team 4 is pouncing. closed and it is yeah, so you have to answer after the pounds is closed. Okay, I'll tell you when to answer. Yeah, so it's team 2, your direct. You can give out an answer. Yeah, so team 2 gets plus 10. One second. Sorry. Minus 20. 10 minus 20. Okay, so this is the next question. Direct to team 3. Anyone pouncing? Pounce about to close in 5 seconds. Team 6 is pouncing. Team 6 gets minus 20. So pounce is closed. It is team 3 is direct. They can answer if they wish to. Sorry? No, C is not right. This is A. A 35% reduction in Weibull score is considered as a treatment response. 25 to 35% is considered a partial response. Below that, it is not even a partial response. It's just between 25 and 35 at least. Okay, so the next is direct to team 4. Team 6 is pouncing. Team 5 is also pouncing. Team 6 gets minus 20. And team 4 is pounced. Team 3 has also pounced. Pounce is closed. Team 5 gets plus 20. So teams 3, 4, 5 and 6 have pounced. Only 5 gets plus 20, rest get minus 20. Okay. And it's since it was team 4's direct, they've answered the question. Question ends there. Team 5 have gotten it right. Okay. Next, direct to team 5. Team 2, 5, 1, 2, 5 and 6 have pounced. So team 1 minus 20, team 2 plus 20. Team 6 is minus 20. Team 5 is plus 20. Okay, so this is intellectualization. Everything else is a mature defense mechanism. Going to direct to team 6, this is the last question of the round. Teams 2, 4, 5 have pounced. Pounce closes. Team 6 direct. All 3 get plus 20. Teams 2, 4 and 5 get plus 20. It is team 6's question. Direct, you can answer it. There's no negative. You get plus 10 or 0. No, that's the answer is A. 10 ml or 8 grams of pure ethanol. That's 1 unit of alcohol. So we are at the end of round 1. And scores will be informed later. We can just continue with the quiz. Just 1 second. So let's move on to the next round. The next round, next round is a visual round. It will start from team 6 now. We have started the first round with team 1. Now we'll start from team 6 and move anti-clockwise. Same pounce rules apply. In this, there is passing also. These are not MCQ questions, so these can be passed. Okay, so if the direct team does not answer it, it can be passed. None of the pounce teams is supposed to give out the answers. Or any team, before I invite them, please don't give out the answer. Okay. So same rules apply for pounce. Pounce closes in 15 seconds and passed just gets 10 seconds. You won't get a lot of time. And pass and direct get the same 10 plus 10. Okay, and no negatives. No negatives. Negative only for pounce. Yeah, so the first question to team 6. Team 2 has pounced. And pounce is closed. Only team 2 has pounced. It is team 6's direct question. You get 15 seconds now to answer. So team 6, I will be needing an answer from you right now. Sorry. Yeah, you can tell. You can give out the answer. No, it's not that. We are looking for a very specific answer. Team 5, it passes to team 5. Yeah, corticostriatothalamic pathway for, sorry, which disorder is implicated, like the dysfunction is most commonly implicated in which disorder? OCDs, I'll give you marks for OCD, yeah. No, this team 2 has pounced, minus 20. You need to write the pathway and the disorder, both are wrong here, okay, so. Yeah. Team 5 gets plus 10 for this question. Next direct is to team 5. Passes also, like whichever direction we are moving in the questions, it passes in that. Direct to team 5, team 1 has pounced. Team 1 has pounced. Anybody else pouncing? So far only team 1 has pounced. And pounce has closed. Okay, I'll allow for team 4 also. Team 1 and team 4 have pounced. It's team 5's direct. Team 5, I will be expecting an answer shortly. No, we are looking for a specific answer. It's not that. The question, team 4 has pounced, so the question goes to team 3 now. Who is this? 4, no? Write the name also. You were given half an answer, please. So the direct goes, yeah, 1 second. That's all, that is your answer. Okay, so team 1 gets plus 20, team 4 gets plus 10, and now the question is still passing, it goes to team 3. Any answer, team 3? Passing to team 2? No, that's not the answer we're looking for. So team 1 has answered correctly. Yeah, so they can give out the answer. Bulimia nervosa, yes. Okay, and other eating disorders also, but we'll accept bulimia nervosa as an answer. Okay, next direct to team 4. Next direct to team 4. Anybody pouncing on this? Anyone pouncing? 5 seconds left. You're pouncing? Team 4, are you pouncing? Okay, you are pouncing. Team 1 is also pouncing. Pounce is closed now. It's team 4's direct question. It'll. So again, team 1 gets plus 20 and team 4 will get plus 10. This is half an answer, so we'll get again plus 10. So it is team 4's direct. So the question is not yet answered, so you can pass to team 3. Team 3, any answer? Team 2? Team 1 has pounced. Team 6? Team 6, do you have an answer? Team 5? Team 4's direct, they have already pounced. So team 1 has given the complete answer, you can answer it. Yeah, it's a deep TMS machine. RTMS is correct, but this is a variant of RTMS which we have asked for a specific answer. So deep transcranial magnetic stimulation. Okay, next direct to team 3. Team 5, are you pouncing? Are you pouncing? No? Team 6 is pouncing. Pounce is now closed, only team 6 has pounced. It is team 3's direct question. Oh, no, that's -20 to team 6. Okay, so this is team 3's direct question. Do you have an answer? The time is up. Do you have an answer? No? Team 2? I need both. I need the personality and I need the phenomenon, both. Team 2, do you have an answer? No. Team 1? No. No, that's not valid. You have to pounce clearly. Team 6 has pounced and gotten it wrong. It's team 5, your passing question now. And? Okay, that's +5 to team 5. And team 4 have not. You have not pounced, right? You can answer the remaining part of the question. No? Okay, the question ends there. Anybody in the audience? So they have answered Konrad Lorenz. What is the phenomenon? Imprinting, yes. Okay, so that is imprinting phenomenon with the Gies experiment that he used to do. Okay, so next is team 2's direct question. Anybody pouncing? Team 2's direct. Team 1 is pouncing. And pounce is now closed. Only team 1 has pounced. Team 2's direct. Team 1, do you have an answer? Have you written it? Okay. Team 1 gets +20. Team 2, it's your direct. You can answer. Do you have an answer? No. So team 1 has already answered. Goes to team 6. Team 6, answer? No. Team 5? No. Team 4? No answer. Team 3? Okay. So team 1 has gotten it right. You can give it out. General adaptation syndrome. Okay. This is a model of stress response proposed by Hans Selye. So next is last question of the round to team 1. Direct to team 1. Anybody pouncing? Team 1 is pouncing on the direct question. Any other pounce? Team 5, yes. Is that a pounce? Okay. Team 5 is also pouncing. Pounce is now closed. No, pounce is closed. Pounce is closed. This is whose? So team 1 and team 5 both get +20. And it is team 1's direct. They've already answered. So it can be answered by team 6 now. Any answer? No. Team 5 has answered. 4. Any answer? Team 3? Any answer? No. Team 2? Sorry? No. This is not Budzinski's sign. This is Hoover's sign. Okay. Hoover's test or Hoover's sign. They used to differentiate between functional and organic weaknesses. Okay. So this round is over. Team 1 and 5 got +20. Yeah, next round. After this set, we'll have. దీంట్లో ఉంటుంది Okay, so we'll after this score, after this round, we'll get to the scores. We'll have a brief break and get to the scores. So yeah, this is you have to identify the disorder in most pictures. If there is any exception to that, I'll let you know that in the question. Pounds and passing rules apply, same as the last round. Okay, clear? So this round we are again starting from team 1. Okay, because last round we went anti-clockwise. This round we'll go clockwise and start from team 1 again. This is team. Okay, this is team 1's direct question. What is a psychiatric disorder? Are you pouncing? Yes, team 6 is pouncing. I want a disorder, okay, like proper disorder diagnosis. Nobody's only team 6 has pounced. We'll just wait for their answer and proceed with passing. Team 6, I need an answer. Team 6 gets plus 20. Team 1's direct, you can answer. Yes, that's right, plus 10. Dissociative identity is the answer, okay? That is depicted in this book, Dr. Jekyll and Mr. Hyde. Next question to team 2, direct to team 2. Team 5 has pounced. Team 2 has also pounced. And pounce is closed. Team 2 and team 5 have pounced. We'll wait for the answers. No, team pounce is closed. So team 2 and 5 get plus 20 and it is team 2's direct. So now it goes to team 3. Team 3, do you have an answer? There's no negatives. You can go for it. Sorry? Tic disorder? No, that's not what we're looking for. Okay, give it to plus 10 to team 4. So this is autism spectrum disorder. Team 2 and 5 got plus 20, 4 got plus 10. Okay. So next is team 3's direct. Team 3, are you ready? Direct. Teams 1, 2, 3, 5.
Okay, all of you right.
4 also. Okay.
But see the question first.
Yeah, pouncers, please raise your hand again once. 1, 3, 4, 5. Right? Team 2 and 6. Last chance. 2 and 6 are not pouncing. Everybody else is pouncing. So teams 1, 3, 4 and 5 get plus 20. All have answered it correct. And it is team 3's direct. So please. Yeah, okay. Yeah. Next, team 4's direct question. Team 1 is pouncing. Only team 1 has pounced. Nobody else pouncing? I thought this was easy. Okay. Team 6, okay, I'll allow that. Team 1 and 6 have pounced. It is team 4's direct. Team 6 gets minus 20, 1 gets plus 20. And team 4's direct, do you want to give out an answer? Yeah, plus 10, Alzheimer's. Yeah. Okay, next is next is team 5's direct. Team 5, ready? Yeah, so this, any pounce? It is actually quite conspicuous if you watch the movie. Any pounce? No pounce. Pounce. I'm closing the pounce. Last chance if anybody wants to pounce. Team 5, yes or no? Not pouncing. It's your direct question. Okay, so nobody is pouncing. Team 5 can start answering. No, I'm looking for his condition. That's why I put him in the picture. Sorry? No, not autism. Team 6, do you have an answer? Team 6, I'm going to pass. Team 1? Yes. No. Team 1 is wrong. Team 2? No. Team 3? No. Team 4? It's Team 5's direct. Nobody got it. Audience? Anybody in the audience? Yes. No, not alcohol dependence. Good answer though, but not alcohol dependence. Close but no cigar. Close but no cigar. Any other answers from the audience? Not PTSD? Not personality disorder? Who said? Bipolar, yes. So this is from a screen grab in the movie. Okay, this is a direct screenshot from one of the scenes in the movie where he quits the case and the main characters are googling for why did he quit, and they find this. So he is supposed to have manic depressive illness, right? So he's suffering from bipolar and he's on medication while arguing that case, basically. Okay, so this is okay. It was Team 5's direct. Last question of this round to Team 6. Okay, yeah, Team 6. This is your direct. Any pounds? Team 6, you've pounced? Okay. Only Team 6 is pouncing. Oh, no, minus 20, no. Team 3 is also pouncing. Pounce is now closed. I'll allow that, but pounce is now closed. Okay, I'll give this one. I'll give plus 10 for this one. It's a partial answer. Okay, I'll give plus 10 to Team 3. It's Team 6 is direct. You have pounced already, right? So, okay, so it passes to Team 1. No, it's not gaming disorder. Good try though, but not gaming disorder. Team 2? No? Team 3? Okay, you pounced and got plus 10. Team 4? No answer. Team 5? Go for it. No negatives. No, not borderline personality. Okay, so all the audience, anyone in the audience? Yes, PTSD is one and they have given another. So PTSD and panic attacks or panic disorder. She is the victim of a sexual assault. That is the premise of the start of the movie, and then she's being treated by it in a VR session, virtual reality session by a therapist. Yeah, so that is the thing. So now we'll take a short break for this course. So we'll just break for 5 minutes. In the meantime, I'll just engage the audience and also the teams. You can have a shot at these bonus kind of questions. Okay, so yeah, audience. SLD, yes, dyslexia, many answers. Okay, and yes, this one. Autism spectrum, yes, Asperger's. Okay, and yes, this one. Who is this first of all? Who is this? Robin Williams, yes. So what did he have? Major depression secondary to? Yes, Lewy body dementia. Okay, and I think we have one more. Yeah. Yeah, so what, like the question, there's a question there. Yes, SRS. Okay, so SRS, that is, yeah. So fairly easy. Okay. Idi, I wanted him to switch off this thing actually. Scores announce చేసేవరకు just we are moving to this thing. Great. అయిపోతుంది సార్ 5:30 5 ఇంకా 2 rounds and అయిపోతుంది. Slide show it.
Team 1 scores, total score is 150 as of now. Team 2 is 50. Team 3 is 10. Team 4 is 40. Team 5 is 135. And Team 6 is minus 80.
Brownie points for pouncing though. That's very good. I like that. Brownie points. Only brownie points, not actual points. No. I know. Okay, so we move on to the next round. We start with team 6 again. Okay, so pounce rules, passing rules all apply. Right? Clear? So we start with team 6. This is mostly a psychopharmacology based round. Okay. So we'll start with team 6 now. Team 6, you're direct. Team 1 is pouncing. And team 5, are you pouncing? Team 2 is also pouncing. Okay, 1, 2, and 5. One, 2, and 5 get plus 20. It is team 6 is direct. Pounce is closed. 6, do you want to answer? You can go for it. It's a no negatives. Go for it. It's your question. Pick one. Go for it. Team 6. No. Okay. Team 5, you've pounced. Team 4, pass. Team 3. No, not escitalopram. Team 2 and 1 have already answered. Okay, so the answer is paroxetine. Okay. So next, direct to team 5. Team 5, this is your direct. Any pounces? Team 1 has pounced. Only team 1 has pounced so far. This is a very specific answer. I'm going to be wanting the exact thing. Okay, there's just like 4 or 5 words in the answer. I want that. Team 1 gets plus 20. Team 5's direct. Do you want to go for it? Yeah, go for it. No, I'm looking for a mechanism of action like no. So receptor mechanism of action, if I have to be more specific. Okay, do you have an answer for that? No, pass. Team 4? No, team 3? Team 2? No, team 6? Not going for it. Team 1, you can give out the answer. at GABA receptors. Okay, they gave the near perfect answers. I'll give them plus 20. So next, direct to team 4. Ready? Any pounces? Pounce closed. Team 4, it is your direct. Do you want to answer it? No. Team 3? Team 3, do you have an answer? No. Team 2? No. Team 1? That's already in the question. I want an answer. No? Team 6? Team 5? Anyone in the audience? Audience, go for it. What is unique about this drug? So no answers from the audience also. It's a transdermal patch. Okay, it is the first of its kind. It's very recent approval. Okay, so moving on. Next question directly to team 3. Team 3, are you ready? Team 3, direct to you. Anybody pouncing? I will accept a close enough answer, but that is under my discretion. You can answer. Team 5 and 4 and 5 have pounced. That's not a range. Not pouncing. Team 4 and 5 have pounced. I'll give both. 4 and 5 plus 20. Okay, 5 have the best answer, but I'll give both plus 20. So this is team 3's direct question. Team 3, do you want to go for it? Just, sorry? 30. I'll give you the plus 10. That's close enough. Okay, so it's 28% remission at the first stage. The importance of this is that it was used in popular media to bash antidepressants, basically. So that's the point of asking this question, that only 28% get better once you have tried a single antidepressant. But by the end of it, around 70% got better with multiple trials, different antidepressants, augmentation, all of it. Okay, so just a small snippet there. Okay, next, team 2. That is your question, direct. Take some time to read the question. I'll allow for a later pounce on this one. Any pounces? Yeah, this is team 2's direct. Any pounces? Yeah, so now I'll need a pounce confirmation in the next 5 seconds. Pounce is almost closing. If anybody wants to pounce, it's your last chance. Yeah, team 1 has pounced. I'll allow that. Now pounce is closed. And we'll wait for team 1's answer. Team 1 gets plus 20 and team 2's direct. No, that's not MAO inhibitors. Team 1 has already answered, passing to team 6. No? Team 5? Go for it. Give me a class of drugs. I want the name of a class of drugs. Okay, I'll give it to you. Plus 10. Okay, dopamine receptor agonists. So this was a study done in 2014. I just wanted to give out this information. They took all the incident reports to FDA. Okay, incident report with any drug that has impulse control disorders as the resulting side effect. Okay, 1580 reports they got. Out of that, 45% were related to dopamine receptor agonists in Parkinson's. So it was a clear association that they noticed. And it was noticed after many people went through incidents like this. So that's just, yeah, team 5 gets plus 10. So last question to team 1. Team 1's direct. I have pounced on it. Team 1 has pounced. Team 5 have also pounced. Both team 1 and 5 get plus 20. 1, okay. Team 1 gets plus 20. 5 are yet to answer. Team 5 gets minus 20. Okay, so this is team 1's direct. Team 6 gets to answer. Team 6, do you have an answer? No. Team 4, 3, 2. Team 1 is given out the answer. 5 is wrong. Audience? Yes? Yeah, correct. Okay, I'm answering, right? So we are at the end of this round. I'm just moving to a different slide. Okay, so yeah, I heard some. I'm hearing some exclamations. So I thought we'll end on a lighter note after all the heavy psychopharmacology stuff, right? Oh, hey, this is light only. These are stories. Okay, so anyway, so this round again starts with team 1. Okay, I put in some stories also. Let's see if anybody enjoys it or not. Team 1. Okay, team 1, this is your direct. Yeah, they are pouncing. Team 1 is pouncing. Yeah, I'll give it plus 20. Team 1's direct. The pounce is closed. Team 2, do you want to go for it? Team 3, 4, 5, 6. No, not sexual dysfunction. Okay, all the teams have answered. Audience? Team 1 has got it right. Audience, anybody in the audience? It was withdrawn in 1.5 years for a very specific kind of side effect. No one in the audience? Team 1, you can give out the answer. Neuropathy, yes. Guillain-Barré syndrome was the more specific answer I was looking for, but I'll give it to them. So this was a very high incidence of this was observed in the 1.5 years in the post-marketing surveillance kind of phase. So this drug was withdrawn. Okay, next is team 2. Team 2, you're direct. You ready? Okay, so I'll need like a specific answer again here. So anybody pouncing? This is a recent work, very recent work. It has been in the news in the last, say, 1 or 2 years. It is a recent and very comprehensive body of work. That is like enough clues, I think. So team 2, that's your direct. Is anybody pouncing? Last chance to pounce. Nobody is pouncing. So team 2's direct, you can give out the answer. No, it's not hypnotherapy. Team 3? No. Team 4? Team 5? No. Team 6? Team 6? Any answer? No. Team 1? That's not answer. Like if you can expand on it, I'll allow for just like 5 seconds. No. Okay. Anybody in the audience? Asylums? Yes. Can you modify that answer? It is related to asylums. Yes. Can you modify it, please? So there was a famous psychological experiment, the Rosenhan experiment, where this psychologist called Rosenhan sent healthy people to asylums to go and mimic psychiatric symptoms. So they went and they did not even report classical symptoms. They were told vague things like I'm hearing tinny sounds or I'm hearing like clicking sounds. They said things like that. So basically his thing was to see whether the psychiatrist of that time could differentiate between a healthy and a sane person. Sane and insane person. That was the idea. So he claimed at that point that many people, even when they reported vague symptoms like this, were diagnosed with schizophrenia, treated with antipsychotics, and institutionalized for years. So this person, the person who wrote this book, followed all of them up. Whoever was alive, she followed all of them up, and she found that the entire study was fabricated. And this is important because it was widely reported in the media, and it was a solid ground for the anti-psychiatry movement at that time. So he was a legend until this particular work came out, and now the entire thing has been debunked by this book. Yes, by this book. Okay, so next is Team 3's direct. Team 1 have pounced.
What is the most common?
No, there's only like, yeah, just connect. We'll see. Yeah. Team 1 have pounced. Anybody else pouncing? I'm going to close pounce. I'll allow a last one if anybody's pouncing. No pounce? Yeah, pounce is closed. Team 1 gets plus 20. Team 3? Team 3? No. Team 4? No. Team 5? Team 5, any answer? No. Team 6? No. Team 2? No. Audience? Team 1 has already answered. Audience? No answers from the audience. Team 1, you can give it out. Yeah, these are Nobel Prize winners related to the field of psychiatry. Okay, this is almost an exhaustive list, except for one other person along with Arvid Carlson and Eric Kandel. This is almost the entire list. Nobody else has won. These people have won Nobel Prize in medicine for work related to psychiatry. And as a little afterthought, Julius Wagner-Jauregg was also later discovered to be a Nazi and participated in anti-Semitic experiments. So that again is a blot on his legacy. Yeah. So next question to Team 4. Team 4, ready? This is just you can take some time to read this. I'll allow for a later pounce. Team 1 has pounced. No? Team 1 minus 20. This was a direct to Team 4. Team 4, any answer? No. Team 5? 5, any answer? No. Pass. 6? 6, no. 1 have gotten it wrong. 2? 3? Audience? Anyone in the audience? This film is on Amazon Prime right now. You can watch it. So this is R.D. Laing. His book called The Divided Self was very famous back then as a sort of a sociological explanation of schizophrenia. And this actor is also very famous. David Tennant is in a bunch of stuff. Doctor Who and yeah. And a bunch of Marvel stuff also. Okay, so Team 5, you're direct. Are you ready? Anyone pouncing? Last year's Team 1 pounced. Team 5's direct. Team 1 has pounced. Team 1 gets plus 20. Team 5, you have an answer? Team 6? No. 1 has answered. 2? Team 3? Team 4? It was 5's direct. Audience? Who coined the term psychiatry? Johann Christian Riehl. Yeah, this is... Okay, moving on to Team 6. This is the last question of the quiz. And Team 6, are you ready? Okay, this is also my favorite question of the quiz. So I put it at the end. Okay, so you please read it. I'll just explain if something you cannot understand. So this is a particular agent based on which one of our drugs was developed. So Yeah, you will get part points. You will get part points. If it's correct, no negatives. So the drug, the agent X was used in this vulcanization of rubber, and this doctor, Dr. Williams, he observed that after this vulcanization, when the workers participated in this particular activity, Y, right? I'm not giving out the activity because it will give out. So after they participated in that, they got sick, right? This drug at the time was also used to treat scabies. There is more of the question also. 5 have pounced, but I'll give more time for decision on pounce. There is more to this question, the 2-slide question. So other doctors investigated this drug and they themselves participated in the activity Y, and they found the results to be replicated. Whatever the workers suffered, these people also suffered. Okay, then they made it a formal experiment. These are the symptoms that they got. Okay, so nausea, vomiting, all these symptoms they got. Flushing, headache, dizziness. So they participated in this activity. They made it into a formalized experiment. They did a full-blown study and they found definitive evidence, and then the drug was approved, FDA approved. It is the first FDA approved drug for this particular condition. Okay, team 5 has pounced. So the why here is the activity that they did that caused them to develop these symptoms after being exposed to X. Okay, they got exposed to X in the factory. They did a particular activity. Then they got symptoms. So team 5 gets plus 20. I'll allow for a last pounce here. Anybody pouncing? No. Okay. 6 direct, you have an answer? Yeah, so that is, yeah. So team 6 gets plus 10. This was disulfiram alcohol consumption. It was discovered incidentally in a rubber factory. Okay, and then it eventually it got approved for alcohol dependence. Okay, so in the meantime, while the scores are calculated, I have just a audience question. If you can go, I don't know if the print is visible. This is a bit of a long question. So this person called Christina Pearson, she was 14 years old when she again started engaging in a particular behavior, creating a problematic physical appearance basically. So, and this was in 1970, so that condition had no name, no treatment. Okay, but you know, because of this, she was removed from high school. Then she went on to a fringe life, getting addicted to drugs, alcohol. Then after like 20 years of getting affected by this, there was a study in the NEJM, New England Journal of Medicine, saying there is a name for this. They have actually incorporated it into formal medicine. And after that, she went on to achieve great heights. Like she left her job by then and she started an advocacy line for this, which went on to become a worldwide organization. So any guesses? Anybody? The clue is in ungainly physical appearance. What activity causes an ungainly physical appearance? This, sorry? Not bulimia. Trichotillomania, yes, that's the correct answer. He started plucking her hair, and at that time in 1970 there was no name for it. There was no name, no diagnosis. The term was coined much earlier, but it was not applied to this particular condition. Okay, so the answer for this is trichotillomania. So that brings us to the end of today's quiz, and we are just computing the scores. We'll just let you know the results briefly. Sorry? It's called a Trichotillomania Learning Center. She founded one of those things, and then it went on to become a worldwide kind of organization where, yeah. Any quick feedback from the finalists before we announce the scores? Thank you. Any negative comments? You're welcome with those as well. Too boring, too long, too tough. Off. So you have done very well if you're first years. You have pounced on a lot of questions. I'll give you points for that. Bravo for coming and participating, getting to the final and pouncing on questions. So yeah, we're ready to announce the scores. Team 1 finishes on 325 points. Team 2 finishes on 115 points. Team 3 finishes on 35 points. Team 4 on 95. Team 5 on 240. And Team 6 on 15. Yes. So Team 1 wins today's quiz. Congratulations. And Team 2 is the Team 5, sorry, is the runner-up. And Team 2 is the second runner-up. Congratulations to all of you. And thank you for coming and participating in the quiz. Thank you for a very vibrant audience also. We usually do not get this much audience in quizzes. So thank you to all the audience members who participated in answering the questions as well. Okay. Moving on with the next step, anybody who was registered for the RTMS live demo, you can assemble at the reception counter, please. Okay, all of you have registered.
For the postgraduates, the dinner is at the same venue, the same place where you had your lunch. 8 p.m. Well played.